to restrict ourselves to meet everybody, to run the program. So whatever small thing was there because of the COVID, we had a focal approaches. But yes, now we won't have a biopic approach. We'll have a joint approach with all the bodies. We'll also move out of Patna now since we are COVID free almost, at least in this season. So we'll have the program at different levels. Thank you one and all for calling me here and giving the.
Congratulations, Dr. Mandal. I am Dr. Sanjay D. Cruz from Chandigarh. It's indeed a good beginning, and I'm very encouraged to see the effort that is being made by ISOT Bihar. A couple of points I would like to make is, it is a team effort.
Right.
And the most important cog in the wheel is the neurosurgeons, because most of the organs that you would be harvesting would be from the ICU care setting. It's good idea. I don't know whether you have neurosciences.
We have branded committee. He is heading the branded committee at our center.
And not only heading it, positive feedback, and it's a to and fro process. Another thing is involvement of social workers, because if we as a doctor approach a prospective donor, then they would think there is some vested interest and all that. So we practice that in our institutions. Tell them to approach them, and then we are in the background. That has helped in our setting. And I also belong to St. Michael's, and happy to be in the city of Patna, and privilege, and thanks to the organizers for having me here. Thank you.
So thank you once again, Professor Manish Mandal, Dr. Sunil Shroff, Dr. Satyajit, and Dr. Sanjay for giving important inputs. And I also thank my co-chairperson, Dr. Prakash Kumar Dubey, HOD Anesthesiology, IGIMS. With this, we come to the end of this session. I hand over the mic to the organizers, Dr. Chandan. Thank you. Thank you once again.
Thank you, Chandan.
Thank you, sir. Thank you, everyone, for participation. So we move on to the next session. And the session is going to be chaired by Dr. Prabhakar Kumar, who is a consultant nephrologist at the Tata Memorial Hospital, Jamshedpur. Dr. Brojain Singh, who is Associate Professor, Department of Nephrology at RIMS, Imphal. And I would also like to invite Mr. Nirmal Bahadur, the Transplant Coordinator at IGMS Patna, and the man behind the mission, a backbone of transplantation at IGMS Patna, Nirmal ji. And to conduct this session, I would like to call Professor Sunil Shroff, who doesn't need any introduction. He's the President of Indian Society of Organ Transplantation. Sir, welcome, sir.
Good morning to all of you. Very, very emotional for me to be here, because what I am is because of my very dear alma mater, Patna Medical College. Currently, I am the president of the society, and it was my dream to have a conference during my tenure in Patna. And I'm very happy, thanks to Om and Harsh, for making this happen and making my dream come true. There can't be a bigger honor than coming back to your parent city and doing something which is very dear and close to me. We have a very good 2-day session, and I invite you all to come back again into this meeting. I can promise you, you'll go back very enriched with some new knowledge. And that's the idea of having this meeting in this very, very old, historic, hallowed city of Patna. So I'm going to talk to you on the legal aspects of organ donation transplantation, not the easiest topic to digest, but you need a legal framework to do anything in this country. We have Dr. Arpita Roy Chaudhary, Dr. Manish Mandal, and if Rajiv Ranjan, has he come from Jharkhand? Is he here in the audience? He did not come. He's also expected to come. And they are here because of the law. I'll do it, don't worry. Where's my presentation? Yeah, take it, thank you. Don't worry. So over the next half an hour, and I'm so happy that we are on time, and we'll try and be on time. इसको बंद कर दें? Yeah, you go ahead. And thanks to COVID, at least now a lot of people have joining virtually. So we do have audience from other places as well. I think we have some chairpersons also joining virtually. Dr. a renowned lawyer, and they made a framework for transplantation in India. But before that, India was very infamous because a lot of commercial dealing in organs were happening. And to take, we were getting a lot of international criticism. So to overcome that, they wanted to form a law. And initially, when the law was formed, they had allowed for commercial dealing in organs. But when it went to Rajya Sabha and Lok Sabha, that was rejected and it had to go back. So it took at least 2-3 years for this law to come into some kind of format. And it was 1994 in September that this law came into force. So slides are not changing here. Raja? We need to have either, otherwise I can do it from here straight, Yeah, okay. I think it's a little slow. Okay, thank you. This is my different affiliations. I also do a lot of telehealth, by the way. So, not changing, Raja. Yeah. ये इससे करें क्या? अच्छा ठीक है. Perhaps this, yeah. I use this all the time. आपका जो यहाँ चेंज हो रहा है वहां नहीं हो रहा है, ये इसके लिए है शायद. Sometimes you have these hitches and glitches, but by hopefully in the next 1 hour, it'll all get sorted out. I can proceed without the slides also, well, if I need to. So, what I'm going to tell you is country is governed by law. Law is passed as, acts, as parliamentary acts. Rules are practical workings of a law. It's not coming here. Then you do amendments as you go along. There are official changes in the law. And then law and, health and education are state subjects. And they have to be passed by the local parliament. So after the center has passed, it has to be accepted by the other states. And Transplantation of Human Organ Act took a long time to be passed by many states. And now it's passed by more or less all the states. And states can then pass their either own law or also change the, the rules of the law. They can't do more than that. Sorry about this. Parliament is still stuck here. Sorry about that, but my slides are not moving. Can you do something from here, or what shall we do? Hello. आ गया? Very good. ये तो अभी आया. ये पहले वाली स्लाइड का है. अच्छा ठीक है, आगे बढ़िए. Next. Okay, great. Disconnect somehow. What I'm seeing here is not there. What is coming there? तो वहीं से change करेंगे क्या? Then I should say next. Okay. So this is our gadget. Next. ये तो यार बड़ा पेनफुल है. मैं वहीं आग से कर देता हूँ presentation. Let me stand there. I'm sorry about this. Right? Give me the काम करेगा. Okay. Please. I'm fine. वो change होना चाहिए ना. मेन तो बात ये है. So we have actually got a law manual which you've written on transplant law, which is a 300-page manual of explaining the law, going into the intricacies of the law and so on. So what does this law entail? There are two essential things in this law. That organ donation is possible after brain death, and organ donation from living person can be either related or to emotionally related, but not because of money. And also it accepts brain death as form of death. All regulatory frameworks and rules are around these two aspects of living donation and brain death and organ donation. There are 7 chapters in this law. I'm not going to go into great detail and bore you with all but I'm just going to give you some highlights. The chapter 1 is the first chapter, and it defines brainstem death kya hai, just like Dr. Manish Mandal said, that the stage at which all functions of brain has ceased to function. Brainstem, not the whole brain. Brainstem is your midbrain, pons, and medulla. And that is your part of the brain, which is the most essential part of the brain to keep your respiration, your blood pressure, your awakefulness there. And that's why brainstem death is a UK definition of brainstem death. The US definition is whole brain. But both are literally the same. After the brainstem, the whole brain also goes. So we follow the UK standard of brainstem death. And who can donate? Living person may, son, daughter, father, mother, brother, sister, husband, wife, and grandparents now. So this is about chapter 1. Chapter 2 is about authority for removal of human organs. Who can remove the organs? So a person may authorize removal of any organ before his death. Like you can carry a donor card. I don't know how many of you carry a donor card in the audience, but if you want to champion the cause, you must carry a donor card and promote the organ donation concept. I carry a donor card. And person may express his wish to donate his organs in the event of his death. And in the event of death, the family is always asked, and informed consent is taken from the family, even if you're carrying a donor card.
for diseased or cadaver donation. Can you just take that bar down? Upar wali bar. So if you want to have, if you want to donate organs, you need to have this conversation with your family also, besides carrying donor card. You need to tell your family or next of kin ki hum donate karna chahte hain. You can do it through donor card, which is form number 7. At least it used to be in the old act. Now I think it's changed. Or you can carry a very simple pledge card. Why is it not moving? It's now getting a little irritating. ये कर क्या रहे हो आप लोग 10 आदमी खड़े होके यहाँ? मुंह करेगा तब जाके हम बात कर सकेंगे. So you have a pledge card, and now you also have the Indian driving license, on which you can also, pledge for your organs, which is unique. And this has happened only 2 years back. And apparently 2 crore people in India have pledged the organs to the driving license. Can you believe it? In such a short time. So Indians are very giving. As I said, eye donations happens so frequently in India. So ऐसा नहीं है कि organ donation हो नहीं सकता है public में. And all this championing has been done by many NGOs, many volunteers in this program. And today we have 11 million blood donations happening in this country every year, which is not small. We have more than 60,000 cornea donations which happen in this country, which is again not small. We do the highest numbers of corneas in the world. Remember that. So Indians are very giving. Problem is, according to me, not in the public domain. The problem is in the hospital domains. We as doctors fail the public to be able to make it happen. And this is an organ donor card which we distribute as a foundation. Declaration of brain death, 4 doctors are required, and twice they need to do it. So it's very foolproof, including people from government panel. It has to be a neurosurgeon. It has to be an intensivist. And that's very important. And this is a patient with brain death, completely brain is gone. And then you'll have this form number 10 now. Previously it was form number 8. Keep moving. So these are the 4 people. Keep moving. And this is form number 8 for old, 10, and you see 4 doctors' signature. It has to be done twice. 1 doctor will do the test and 3 will observe. Next. Also, in case of medical legal case, you need to involve the forensic people. That's very important. Next. Chapter 3 is about regulation of hospital. If you want to do transplant, you need to get permission as whether you want to do transplant. And in the new rules, necessarily, if you don't have the infrastructure to do transplant, you can also do just organ retrieval. So it's called non-transplant organ retrieval centers, NTORC, and there's a form number 13 for that. And that so all medical colleges in Bihar can become NTORCs, because all medical colleges, I think there are 14, and government wants to put 26 medical colleges in Bihar, so you can get 26 organ retrieval centers immediately. Chapter 4 is about appropriate authority. Who gives authority for permission for donation? Next. So the authorities give grant to hospitals for registration. Authorities give grant to people who want to donate out of emotional, reason to donation. So that grant is given by, again, some kind of appropriate authority which is appointed by government. Usually it is the DGHS, who is the appropriate authority, the Director of Health Services. And the Director of Medical Education is usually the person who gives authorization for donations, for living donations. जैसे कोई kidney donate करना चाहता है, and they are not related. So you need to show that you're not donating out of commerce. So you need to go to the authorization committee. Next. Then there is chapter 5 for registration of hospitals. Hospitals need to apply for license, and they need to apply to appropriate authority. Next. They need to have skilled manpower. You need to have infrastructure in a hospital to get permission. And chapter 6 deals with offenses and penalties. If you do wrong, what happens to you? And penalties are very, very tough, very strict. I think Indian law is the toughest law in transplantation in the world. I've read all the laws, believe me. And this is the toughest law. The penalties are huge. Previously, it was only 10,000, 20,000 rupees. Now it has gone up to 1 crore. Previously, it was 2 or 3 years jail for people who did wrong. Now it is 10 years. So we have, very strict laws. And for doctors, their name will get stuck off from the register to practice. Next. So you see this, removal of organ without authority, 10 years imprisonment, 20 lakhs fine. Go back. Removal of organs without authority by RMP, first offense, the registration goes for 3 years, second offense permanent. Commercial dealing in organs and falsification of documents, especially in kidneys, 5 to 10 years, 20 lakhs to 1 crore fine. Any violations of THO, again 5 years and 20 lakhs. So nobody should try and beat this law and try and do all this hanky-panky in this program anymore. We have to make sure organ commerce never happens. And then there's a miscellaneous in this chapter which talks about that anything done in good faith is permissible. So if you're running an NGO for organ donation, it's permissible. So that's also the law allows that. So very well written law. It protects the interest of the public. Very, very important. Next. And then in 2011, after having the law for about good from 1994 to 2011, about 16 years, we made an amendment. We made an appeal to the government because we felt that the punishments were too less. We needed to make the punishment more strict, and still commercial organ donations was happening. So we wanted this to stop. So we made an appeal. After many appeals, we had an amendment. Next. And this is a comparison to show what amendments did. So in 2011, tissues also were included under the Transplantation of Human Organ Act. The definition of a transplant coordinator was there in this so that they can, help this program. Consent. Previously, there was next of kin you asked, but the consent changed a little bit. We brought what is called required request, which meant that if there is a brain death in an intensive care, listen to me carefully. If there is a brain death in intensive care, it is a moral duty of the doctor treating the patient to ask the relatives for organ donation. That's what is required request. And that is there in the law, but it's not being implemented. Medical certification board previously was only neurosurgeons, but now we also included intensivists. And authorization of hospital was only for transplantation and storage and retrieval. But now we have also non-transplant organ retrieval center to increase the scope of organ donation. Yes, understood, I hope. So these are the broad changes in the two. And transplant coordinator is a person who can coordinate on the floor. Very important person because doctors are very busy. Intensive care is very busy. So you need somebody who's trained who can do this. Next. And transplant coordinator needs to have subject knowledge, needs to be a decision maker, need to be able to do counseling, need to be able to have some interpersonal skills. Next. And they need to coordinate with various departments, be it medical, be it donor family to do counseling, be it the lab, the X-ray people, the authorization, finance, organ allocation body, police for forensic cases, and the retrieval team. So transplant coordinator, that's why it's very important. That's why we brought them in. Next. And this is just a flow chart to show you how it happens. An early identification of brain death is done. First information is given to transplant coordinator. Rapport building is done with the family. Brainstem first certification is done. Inform the state body. Start counseling for organ donation. Consent for organ donation from next of kin is taken. Then inform the state body that yes, consent has been given. Once consent is there, if it is a non-medical legal case, then second brainstem test is done. Written consent, make sure it's in place. Coordinate with the state body, coordinate with recipient team. Organ and tissue retrieval is there, body handed over. This is the flow. So very complex. Multiple kind of areas where things can go wrong. And you have to make sure you have a standard operating procedure to do all this. If it's a medical legal case, then forensics come in. Next. Kya hua? If it's a medical legal case, forensics will come in. You need to coordinate with the police, need to get their permission. They need to then, then again, same thing, coordinate with the forensic and the state body, get permission for which organs can be removed. If the forensic says, I want the heart, you can't remove the heart or lungs. Coordinate with the recipient team. Next. And then you do retrieval and then you hand over the body. Next. And then there is a post-mortem as well. So it's quite, it can be very traumatic to open the body twice. So we have appealed to many state governments to do the post-mortem at the same time as organ retrieval. Next. And then you need to have all the legal documents in place. The brain death certificate, the consent should be in mother tongue if possible, police clearance, forensic clearance, what forms all for the organs. And then you need to have donor evaluation form and so on. The amendment also gave the power to appropriate authority of civil court, which meant that the appropriate authority could order an arrest of a person, be it a doctor or a recipient or a donor. Next. And then again, in this act, we also have the national body, the NOTO, the ROTO, the SOTO, that came on. And this is how it is, the structure, as Dr. Mandal also said. There are 5 ROTOs, and there are 2 SOTOs, one in Bihar, here I'm talking of this region, in IGMS and in Jharkhand. And then there are rules in this 2014, as I said, and law is the legal structure and rules are how to implement the law. And the cost was not there in the previous law. Now it can be shared. The disease donor cost of maintenance can be shared between the recipients and by the government and by some NGOs. And the costs are of retrieval, of preservation and transportation. Next. So these are the people who can share the cost. Next. Next. And if you see the disease donation, there are only about 3 or 4 forms. Form 7, living person who wishes to donate. This is like a donor card. Form 8 is consent from the family, from next of kin. Form 9 is for unclaimed body. Unclaimed body's donation has never happened. And Form 10 is brain death form. Bus, 4 forms are there. In fact, only 3 forms are there. And required request is there. As I said, asking for organs in the event of brain death in the hospital is now compulsory. Next. You have also doing a driving license. As I said, this is our Indian driving license. This is Bhavna Jagwani from our foundation who worked very hard to make this happen. And now it's there. Next. But we have some problems. Brain death is linked to organ donation, is not accepted as death. Many times in India, diagnosis of brain death is only done if organ donation permission is given. But this is a catch-22 situation. If you don't certify brain death, you can't ask for organs. It's not legal. So at least do one certification. But many intensivists do not certify brain death unless there is organ donation happening. So it's sometimes becomes a very difficult situation. So in a corporate hospital, if somebody is brain dead, they will switch off the ventilator for organ donation. But if the family says, yes to donation, but if family doesn't say yes to donation, the ventilation continues, and that creates a lot of moral problems. Next. So switching off ventilator in corporate hospitals becomes a challenge. Next. These are some government orders from Tamil Nadu on how to share organs. We started this in 2000. We're doing this from year 2000 on how to share organs. One organ remains, in the hospital. That is, if there are 2 kidneys, one kidney will remain in the hospital and one kidney goes to the, common pool. The liver and heart, if there is recipients available in the hospital where retrieval happens, the organ stays there. Otherwise, it goes into common pool. And this is how the organ sharing is happening today in the country as well. And we have one rule for government hospital and one rule for private hospital. In the government hospital, we give higher priority to patients who are less affordable. By also in the private hospital, if donation happens, then the first priority, of course, is the one kidney they can keep, but the second kidney, the first priority is to combine list of the government and the private hospital. So they get a little advantage. Next. We also have, the government of Kerala has come out with a government order there, how to switch off ventilators in a situation where relatives say no to donation. So that order also there, and we are trying to get a uniform declaration of death by Government of India. At the moment, only cardiorespiratory, death is recognized in our Birth and Death Act. We're trying to change that. Next, keep moving forward. Next. And this is the geo of Government of Kerala. If you have any problem, you can refer to this in your state, in Bihar, that Kerala has a geo for switching off ventilators in event families say no to donation. Next, these are just some of the geos. And there are forms, Form 12 to apply for license for organ transplantation, cost 10,000 rupees. Next. And there's no fee for, being a retrieval center, that is non-transplant organ retrieval center. Next. All hospitals in Tamil Nadu, about 25 beds are made organ retrieval centers. Next. And there's a form for banking as well. Next. 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 And renewal of the hospital is vain. There are 21 forms in the new law. You can go through that. All this is available. In living donation, go back. There are many forms. There are 3 forms for consent in living donation. One for related, one for spousal, and one for unrelated. And all the form says that there's no commercial dealing in organs. I've been explained that. So if you are found signing this form, it's like an affidavit. So you have to be very careful. And then there's Form 4 which treating doctor signs. We call medical fitness. Then there's Form 5 for genetic relationship. If HLA doesn't, match it, then you do need to do genetic relationship. Then there's a spousal donation, and then a joint declaration by donor and recipient. So there are how many forms? 1, 2, 3, 4, 5, 6, 7. Next. And then all these forms again, swap donations, there's a luck form, which, you can exchange organs between 2 families and so on. And then the one for domicile, if there's somebody from outside state, one for foreigners. So that 21 forms, of which most of the forms are for living donation, so that there's no organ commerce. Next. So with a lot of efforts in the last almost 25 years since the law has been passed, it was 2012 that this program started to take a turn. And in 2012, we did close to about 196 donations. And you see these human beings, going up and up and up. To 196 in 2012. Come 2017, we had 905 donations, which meant that the donation rate went up by almost 5 times in about 6 years. Because we had, by that time, started doing training of coordinators, training of intensivists. Next. A lot of capacity building was done in this program. And a lot of trust was also, is very important factor of this program. We have an NGO, which I know Dr. Satyajit ji said also, we in now 25 years old NGO. Next, we do a lot of awareness. We do a lot of training, capacity building, counseling. We have our counselors in government hospitals in Tamil Nadu, in Andhra Pradesh, in Telangana, in Maharashtra, in Jaipur, and so on. We do networking. So we do a lot of training courses for coordinators, ICU surgeons. We have a training course with European guys where we do for organ retrieval. Next, we have apps, we have a helpline. We've done a lot of capacity building. Our transplant coordinator training program is very popular. We just finished 2 such courses, both one in Chennai and one in Delhi. We train on medical aspects, legal ethical aspects, religious aspects, how to do grief counseling, how to do coordination of the flow. And this is a curriculum. Next. This is the first structured program of its kind in Asia. We also have 1-year postgraduate course. Next. So this is just an example of what a trained coordinator can do. So we have placed our trained coordinators in Government General Hospital in Chennai. And in about 8 years or 9 years, we identified 260 brain deaths in that hospital. 253 families were approached for donation. 85 said no, but we got yes from 168 families in a government hospital in Chennai, which is a 2,500 bedded hospital, very busy hospital, just like PMCH. And of this, we did 119 went on to do multi-organ donation. Next. And we had a conversion rate of 66% of families saying yes to donation. So when you go out of this room, don't think that people will not give for, if you have a trained person handling the family, many of those no's will come yes for donation. And from one hospital, we had so many organs, as you can see, liver, kidneys, lungs, heart, corneas, everything, bodies recycling. From one government hospital in Tamil Nadu. And that's the success of Tamil Nadu. And that's why Tamil Nadu keeps coming up again and again in this program. Next. Next. We have apps, helpline apps. You can download free of cost. We have brain death apps for donor maintenance. We have app for how to certify brain death. So if you don't know how to do it in the middle of the night, just download the app. It tells you each step by step. We spend a lot of money on technology. We have online courses. Next. These are the apps which we developed in NHS. NHS is, as you know, the UK's largest health body in the world, in fact. And we have this app with NHS, and many people have downloaded it because we have an MOU with them. And this is a capacity building ICU workshop, which we have conducted several times. 14 ICU workshops, 500 staff sensitized. We have ICU profession. We have also for organ donations, a professional course, which we do next. We have an organ retrieval workshop, which we do wet lab workshop in MS Ramaiah in Bangalore. And we train many surgeons, almost 200 surgeons in that wet lab with Dr. Sonal Astana, where we teach them how to explant and implant an organ. And this we have done with Oxford Group. Every time we get faculty from Oxford. And these are some of the surgeons who have got trained. I know I'm just getting there, just another half a minute. Next. Next. And this is from those workshops, just stay there. From those workshops, we have had surgeons who have never seen a transplant go back and do heart transplant, 18 heart transplant in public sector, 2 hospitals. And this is a gentleman, a surgeon, a cardiothoracic surgeon from Madurai Medical College, who had never seen a heart transplant. He said, "Sir, it's my dream to do a heart transplant in my medical college." He did the workshop, went back and did heart transplants in Madurai Medical College. Because of all the transplants, I think heart transplant is the simplest. And it is one transplant which gets the maximum emotion from the general public. The arteries are so big, the veins are so big. Of all the transplants, I think the heart transplant is the simplest. Believe me, I'm not exaggerating. So he went back and did heart transplant. So that's the success of doing training and capacity building. Next. So thank you very much for listening to me. I'm sorry about some glitches, but I hope some knowledge transfer has happened. I hope I inspired you to some extent, and I'm sure we can do it in Bihar. Yes? Yes. Good. Thank you.
Dr. Brujain, are you there?
Yeah, I am here. Am I audible?
Kindly unmute yourself.
Yeah, already unmute. Am I audible? Hers, am I audible? I'm here.
Yeah, you're audible. Please go. Your comments, please.
Yeah, thank you, sir. And well explained about the various aspects of this legal framework about the organ donation. I think it is one of the most important aspects in transplant to save, especially in the health cares, including we doctors, from any legal issues coming up later on. And at last, first I want to thank all the organizer committees for giving me the chance. There was some network issues, connectivity issues, and in the beginning we could not see and we could not hear. And again, I congratulate all the organizing committees, especially Sir Om, then Dr. Hers, for a successful program. Thank you.
Thank you, Brujain. Thank you so much. Dr. Prabhakar, can we connect with you? Are you there, Dr. Prabhakar? Okay, thank you, sir, for an excellent deliberation on the various aspects of diseased organ donation. Now, any questions from the audience? We can take 1 or 2 questions.
Good morning, everyone. I am Dr. Sanjay Kumar, Professor Head, Critical Care Medicine at IGMS Patna. My question is from Sunil Saraf, sir. Sir, right now we are working at ICU, and most of the time, a few cases I have seen which is waiting for the organ. We are planning for brain death since I.
Yeah. Come here and being from ICU is very important.
Since I am also member of brain dead committee along with the Dr. KM Jha, sir. And one thing just I want to know that sometimes we have to face a situation where we just see that patient is about the brain dead, and after that, as you said, that they refuse to, after all convincing, and initially they agreed, but after that they refused to, no, we will not donate. and they need some a little bit help that if you don't allow postmortem, then I will do this thing and like thing. So in that situation, it is very difficult to us that what further we have to do. And like you say that in Kerala, we just remove the ventilatory support, but in our state, there is no such I
Very, very
think,
difficult.
guideline.
Very
So
true.
can you enlighten us regarding this?
So that's why we need to have, guidelines in place. That's why we are appealing to the government of India. The Birth and Death Act, Birth, Marriage and Death Act is getting amended right now. And we made an appeal that there should be uniform declaration of death, just like you have in US. So not only cardiorespiratory, you can't have definition of death is in 3 laws in India. The Indian Penal Code mein hai, death ka definition is done in Birth and Death Act, that's the main act, and Transplantation of Human Act. तीनों में 3 different definition hai. Whereas the transplantation of human organ death definition, it talks about both brain death and respiratory arrest. So we are telling that in Birth and Death Act, which is our main act, usme bhi aap exactly the same definition include brain death also, so that if you switch off the ventilators, you don't have any problem. But it is important that when you have such a situation, aap brain death declare kar dijiye. If you declare brain death twice, that is death. Second declaration becomes the time of death. And then, if you even switch off the ventilator, if you documented it, I know kya hai ki you said trust is lost and families get very upset. Your ECG is still going, the body is still warm, or aap kaise off kar sakte hain. So it's very traumatic. You need good counselors to build rapport with the family, to tell them what brain death is, explain karna padta hai ki kya hai exactly. And have a proper explanation done to the families. Many families will accept it. Time lagti hai. So sometimes what you do as an intensivist is you start cutting down all the supports. जो आप NORAD दे रहे हैं, dopamine, vitamin दे रहे हैं.
For that, we need the just from the attendant consent that we are going to for this thing.
No, see, it is your. If person is dead, then you can't give any care. Only end of life care में the best thing is just to tell them that look, सब चीज खत्म हो गया, आप जा सकते हैं. तो many intensives what they do is, I know that is not perhaps ethical, but they start cutting down all the supports. That's what most of the states are doing it. And at the moment, I suggest कि Dr. Manish Mandal hai, you speak to them, get a guideline in place. कि इस situation में क्या करें. That's why Kerala is a good example. I can share the geo with you. Very clearly they are laid down. So a government order आ गया है. So there's no legal problem with that if you do that. If you have some kind of an order.
So even without permission of the attendant, we can go for this thing.
Go for
this disconnection from the ventilator support.
No, you need to first have in that situation, if you cut off your supports, तो cardiac arrest तो होगा ही.
Yeah.
And once cardiac arrest is done, then you have gone on the.
Some ethical issue or moral issue. So.
But tell me one thing. If you use Form 10 and declare brain death, and if you do an apnea test, death तो define होगी.
Yeah.
अगर वो बोलता है कि हम organ donation करेंगे, तब तो आप organ donation के लिए जाएंगे उसको. आप death को declare तो कर दिए, है कि नहीं? Yes or no?
Yes sir.
तब जब अगर वो बोलता है कि हम organ donation नहीं करेंगे, पर death तो declare कर दिया आप, फिर क्या problem है? क्या legal problem होगी? Death तो आपने declare कर दिया. ये आप सोचिए ना, ये mind block है और कुछ नहीं है.
Sir, problem is usually arises from the attendant of the.
तो attendant को यही तो समझाना है ना आपको कि जब death हो गया तो हम और नहीं कर सकते हैं कुछ इसमें. जब मरने वाले को और क्या हम कर सकते हैं? जिया तो नहीं सकते नहीं हैं हम. So you have to have trained people. I understand. This is more problem in corporate hospital and government than government hospital. Believe me. Corporate hospital में और भी problem है. And उसमें एक और आपको backlash होगी. मीडिया ये भी बोलेगा कि मरे हुए व्यक्ति को आपने ट्रीटमेंट देना है, उसका बिल बढ़ा रहे हैं.
बिल्कुल.
तो हमको तो sometimes double hit मिलती है as doctors. So that's why you need to have some guidelines in place also. तो सोटो बिहार से, see, this is an evolutionary process. To be comfortable, we are trying to get your guidelines in place. हो जाएगा. Soon it will be happen. But for the time being, just use your coordinators, use your skills, soft skills, and slowly wean off the ventilator.
Thanks.
Thank you.
Dr. Prabhakar, can we have you?
Yeah.
Can we have your comment, your experience from Jharkhand?
Harsh, hello, Harsh, am I audible?
Yes, you are audible.
Very good morning, sir. Thank you, sir, for enlightening us with such a nice thing about the organ donation. I think Jharkhand and Bihar is really lacking, especially in disease donor. So I think, sir, I think training is one of the important part, and also the mindset. So I think, can you just give us some brief idea about where we should train so that we can encourage our seniors as well as the coordinators to initiate such program in these areas of which are usually lacking, especially in Bihar and Jharkhand, sir.
So training is happening all the time now in the country. NATO is doing training. Intensive care training just happened with Spain. 20 trained, people got trained from India. As an NGO, our Mon Foundation is doing training for coordinators, intensive care. So training opportunities are multiple. And this workshop was also a training workshop only. And this kind of discussion is more of a discussion of practical everyday problems. So training there are not so much of challenges. 10 saal pehle we were having not many training, but today we have so many training going on at some time of the year. So you just have to be in touch with SOTO Bihar. Some training will come up either from NATO or somebody else. You can join one of those training. Koi dikkat nahi hai. And I also got ICCM जो है Indian critical chapter वाले हैं वो भी training करते हैं ICU के लिए.
Okay, sir. Thank you, sir. Thank you, sir. Thank you very much.
Prabhakar, with this we end this session, sir. Thank you very much for this lively discussion, sir. Thank you, sir.
Thank you.
Thank you, sir.
Dr. Chandan for the next session.
Thank you, sir, for an informative session. And for the next session, I would like to invite the chairpersons, Dr. K.M. Jha, sir, Professor and Head of the Department Neurosurgery, IGMS Patna, Dr. Swati Ma'am, Additional Professor, Department of Anesthesiology, IGMS Patna. Sir, please take the stage. Yes.
Dakshina, are you here?
Good morning. I welcome to this session. Dr. Swati most probably will be joining.
Can you play that video? Hindi wala pehle. So we have two videos, short videos on brain death. And one is in Hindi, just a very simple explanation for some of the paramedical staff are here, I think. Yes. So for them, and then there's an English video, again a short video. So pehle Hindi wala video, can you play that? So this talks about kya brain death kya hai, just आपके समझने के लिए.
नमस्कार, मैं डॉक्टर संदीप वैश्य हूँ और मैं पिछले 20 सालों से बतौर न्यूरोसर्जन प्रैक्टिस कर रहा हूँ। अगले 5 मिनटों में मैं आपको यह बताऊंगा कि ब्रेन डेथ क्या है। ब्रेन डेथ या न्यूरोलॉजिकल डेथ ऐसा शब्द है जिसे लोग ठीक से समझ नहीं पाते। वो समझते हैं कि ब्रेन डेथ का मतलब है कोमा में चले जाना। यह एनिमेशन आपको विस्तार से बताएगा कि ब्रेन डेथ क्या है और यह किस प्रकार कोमा से काफ़ी अलग है। आइए हम पहले दिमाग की संरचना को समझते हैं। दिमाग के 2 हिस्से होते हैं, कॉर्टेक्स और ब्रेनस्टेम। कॉर्टेक्स दिमाग का बड़ा हिस्सा होता है और ब्रेनस्टेम छोटा, जो वास्तव में रीढ़ की नस का ऊपरी भाग होता है। कॉर्टेक्स हमारी अहम गतिविधियों को चलाता है, जैसे पढ़ना, लिखना और बोलना। यदि कॉर्टेक्स डैमेज हो जाए तो इंसान कोमा में पहुंच सकता है। वो होश खो बैठता है, लेकिन कोमा में होने के बावजूद भी वो इंसान दर्द महसूस कर सकता है या किसी हरकत पर प्रतिक्रिया दे सकता है। कभी कभी कोमा में पहुंचे व्यक्ति की चेतना दोबारा लौट भी आती है, किंतु ब्रेन डेथ कोमा से अलग है। इस शब्द का मतलब है कि दिमाग मर चुका है, कॉर्टेक्स और ब्रेनस्टेम दोनों। ब्रेनस्टेम मानव शरीर का केंद्रीय नर्वस सिस्टम और चेतना का केंद्र होता है। यदि ब्रेनस्टेम मर जाएगा तो सांस बंद हो जाएगी। जब दिल को ऑक्सीजन मिलनी बंद हो जाएगी तो वो भी मर जाएगा और धड़कना बंद कर देगा, और बाकी अंग भी ऑक्सीजन की कमी की वजह से मर जाएंगे। ब्रेन डेथ कैसे होती है? यदि किसी व्यक्ति को सिर पर बहुत जोर की चोट लगे या बड़ा स्ट्रोक आए तो दिमाग में सूजन शुरू हो सकती है। क्योंकि कपाल या स्कल बेहद सख्त हड्डी का बना होता है, इसलिए वो दिमाग को फैलने नहीं देता। डॉक्टर दवा देकर या ऑपरेशन कर सूजन को कम करने की कोशिश कर सकते हैं, लेकिन अगर उन्हें कामयाबी न मिली तो दिमाग पर दबाव बहुत बढ़ सकता है, जो कि दिल की धड़कन से भी ज़्यादा दबाव होगा। ऐसा होने पर दिल ऑक्सीजन से भरपूर खून को दिमाग में पहुंचाने में नाकाम रहता है। जब दिमाग को ऑक्सीजन नहीं मिलेगी तो ब्रेन सेल्स मर जाएंगे। वास्तव में ब्रेन सेल्स एकदम से नहीं मरते। एक प्रक्रिया शुरू होती है जिसे लाइसिस कहते हैं, जिसमें ब्रेन सेल्स गलने लगते हैं। गलने की इस प्रक्रिया के बाद ब्रेन डेथ की स्थिति को फिर से पलटाया नहीं जा सकता। एक बार ब्रेन स्टेम मर जाए तो व्यक्ति सांस लेना बंद कर देता है और दिल के बाकी अंग ऑक्सीजन के अभाव में मर जाते हैं। हमें कैसे पता लगेगा कि ब्रेन स्टेम की मौत हो चुकी है? आधुनिक चिकित्सा विज्ञान में यह तय करने के कई तरीके हैं कि ब्रेन स्टेम मर चुका है या नहीं। एक तरीका है उन न्यूरोलॉजिकल गतिविधियों की जांच करना जिन्हें ब्रेन स्टेम नियंत्रित करता है। यदि व्यक्ति होश में नहीं है, सांस नहीं ले सकता, निगल और खांस नहीं सकता, पुतलियां रोशनी पर प्रतिक्रिया नहीं करती, तब ये सभी इस बात के संकेत हैं कि ब्रेन स्टेम की मौत हो चुकी है। भारत में ट्रांसप्लांट ऑफ ह्यूमन ऑर्गन एक्ट ऑफ 1994 में कुछ टेस्ट बताए गए हैं जिन्हें 4 डॉक्टरों की टीम द्वारा किया जाता है। इसके बाद ही किसी व्यक्ति को ब्रेन डेड घोषित किया जाता है। ये परीक्षण 6 घंटों के अंतराल पर 2 बार किए जाते हैं। लेकिन ये कैसे संभव है कि एक ब्रेन डेड मरीज का दिल धड़कता रहे? दिल को ऑक्सीजन कहाँ से मिलती है? ब्रेन डेथ से पहले मरीज को सांस लेने में मदद देने के लिए वेंटिलेटर पर रखा जाता है और उसके बाद ब्रेन स्टेम मर जाता है। भले ही ब्रेन स्टेम मर चुका हो और फेफड़े काम न कर रहे हो, फिर भी दिल धड़कता रहता है क्योंकि उसे वेंटिलेटर से कृत्रिम ढंग से ऑक्सीजन मिलती रहती है। यदि ब्रेन स्टेम की मौत हो गई हो और बाकी का दिमाग भी मर चुका हो, तो क्या चीज़ दिल को धड़कने का आदेश देती है? दिल दिमाग से अलग है। यह एक ऑटोमेटिक पंप होता है। जब तक दिल को वेंटिलेटर से ऑक्सीजन मिलती रहेगी, वो कुछ समय तक धड़कना जारी रखेगा। ब्रेन डेथ के बाद यदि मृतक को वेंटिलेटर पर रखा जाए तो कितनी देर तक शव का दिल धड़कना जारी रहेगा? दिल कुछ घंटों तक धड़क सकता है, कभी कभी कई हफ्तों तक भी। औसतन दिल 2 या 3 दिनों तक धड़कता है और फिर मर जाता है। ब्रेन स्टेम की मौत का मतलब है कि मृत्यु हो चुकी है और इसे पलटाया नहीं जा सकता, और बाकी सभी अंगों का फेल होना रोका नहीं जा सकता। ब्रेन डेथ के बाद आज तक कोई भी व्यक्ति फिर नहीं उठा है। यदि ब्रेन डेथ का मतलब है कि मरीज मर चुका है, तो मृतक के शरीर में गर्माहट क्यों होती है और वो सोता हुआ सा क्यों लगता है? इंसान मर चुका होता है, लेकिन उसके अंगों जैसे कि दिल को कुछ दिनों के लिए जीवित रखा जाता है, जिससे वो सोता हुआ सा लगता है। किसी अंग को शरीर से बाहर रखकर भी ऑक्सीजन देकर जिंदा रखा जा सकता है, लेकिन एक बार दिमाग की मौत हो गई तो इसका मतलब है कि इंसान मर चुका है। ब्रेन डेड व्यक्ति दिमाग की मौत से पीड़ित नहीं है, वह मृत है। जब ब्रेन डेथ की पुष्टि हो जाती है तो मृतक के परिजन इस सवाल से परेशान होते हैं कि अब क्या करें। तो क्या उसके परिजनों को तब तक प्रतीक्षा करनी पड़ती है जब तक दिल धड़कना बंद ना कर दे, या फिर वो यह इच्छा जाहिर कर सकते हैं कि बाकी लोगों की ज़िंदगी बचाने के लिए वो अंग दान करना चाहते हैं? यह एक मुश्किल फैसला है और हर परिवार को वह करने का हक है जो वह करना चाहता है।
Next film is on how to certify brain death in an ICU. And we've used again an animation. We've used Dr. Ramakrishnan, who is an intensivist. So he will show you, it's a short film again, 4 minutes, 4.5 minutes ki film. Can you show the second film? The tragedy of our increased urbanization of 21st century has been the increasing incidence of road traffic accidents from year to year.
Of the body.
Longer one. 4 minute ki hai. I showed you. नहीं 1 मिनट कितने मिनट की है ये
each one of these. To check the absence of pupillary response to light, a bright pen torchlight should be shown into each eye in a darkened room. The pupils may not necessarily be fixed and dilated in brainstem dead patients. However, there should be no pupillary response to light. It's normal to expect grimacing of the face to painful stimulation. However, this is absent in brainstem death situation. A firm supraorbital pressure should be used to check this cranial reflex. We will now check for the doll's eye phenomenon. To do this test, the doctor holds the patient's head between his hands and moves the head from side to side through 180 degrees. You should hold the head to one side for 3 to 4 seconds and look at the simultaneous eye movement to that side. A similar movement is done to the opposite side and the eye movement is observed. If the cerebral hemispheres are damaged but the brainstem is still alive, there will be an obvious deviation of the eyes to the opposite side for a second or two, followed by a release phenomenon when the eyes will get realigned to the side of the head. We are now going to check for the corneal reflex. What needs to be done is taking a moist cotton tipped swab and applying a firm pressure to the cornea, of course without damaging it. The patient is observed for involuntary blinking of the eyelids. Let's now perform the vestibulo-ocular reflex, also commonly referred to as the cold caloric test. This test involves instilling 20 ml of ice cold water into the external auditory canal and looking at the eyeball movements of either eye for about a minute. No eyeball movement indicates an absence of the reflex. To check the gag reflex, a cotton tipped swab or a spatula or a yonkar could be used to stimulate the posterior pharynx to look for the response. We will now check for the cough reflex, and this is going to require a temporary disconnection from the ventilator. The cough reflex is tested by using the bronchial suctioning. Either a closed suction or the open suction method may be used when a patient is having an endotracheal tube. For this test, the patient is disconnected from the ventilator for 10 minutes. However, to avoid hypoxia to vital organs, 100% oxygen is given for 5 minutes before disconnection from the ventilator. Even during the test period, 100% oxygen is given through a tracheal catheter. In the patient who is brain dead, the carbon dioxide tension increases at a rate of 2 millimeters of mercury per minute during the apnea testing. If the initial carbon dioxide tension before the testing is about 40 millimeters of mercury, then the arterial carbon dioxide tension after about 10 minutes is likely to be 60 millimeters of mercury. This test is often considered as the ultimate test to establish brainstem death. The spontaneous respiratory response fails to occur even in the presence of stimulatory drive from increased carbon dioxide. Declaring brainstem death is, if anything, a very, very sensitive issue that I think every single doctor needs to be cautious, because families still have a significant denial on accepting the concept of brainstem death. And that puts the extra burden on us as clinicians to be doubly sure that all the right process has been followed before we actually declare that somebody is brainstem dead. Making sure that there are no abnormalities with the electrolytes, making sure that the temperature is normal, making sure that there is no narcotic medication or sedation on board, are all steps that should be included in our protocol and an algorithmic approach. Therefore, there is no flaw in any of the steps followed while declaring brainstem death. Demonstrate each one of these.
This is just to give you
Check
an idea,
the absence of pupillary response to light.
dummy, to show you how it is done. Just, so that, in intensive care, some of the intensivists, some of the nurses, intensive care, and follow those protocols. And it also shows that each test defines one or two cranial nerves, and brainstem, all the cranial nerves originate from brainstem. So by testing those nerves, and when there's no reaction, you're defining brain death. And the apnea test is the gold standard test. And in India, many times you're not able to do apnea test. And sometimes we lose donors because one apnea test may be possible. Second apnea test, patient becomes very unstable. Sometimes there's a chest injury. So apnea test is not possible. So again, we are trying to get the law to, if there are some alternatives to apnea test, whether we can use that. Okay.
Thank you, sir.
Thank you, Dr. Sunil Saraf and Mohan Foundation for some of the beautiful films you have. I have seen so many films from the Mohan Foundation, and there were some of the films were much better than what you have presented. And in fact, in our program of in IGMS, we have used some of your films, and we are happy, and we acknowledge it for your thing. Is that I am associated with this transplant program for maybe more than 30-40 years. See, once I finished my MBBS and internship, I joined CMC Vellore and I was posted in neurology department. And I was given charge of a renal transplant unit for 4 months. So what we have to do is, once nephrology fellows give us the patient for transplantation, I used to look after them, see all the programs, and then with the patient, used to assist the renal transplant patients, either in the recipient or the donor. And then with the patient, I used to go into the transplant room, and I used to stay for the transplant patient for 48 hours. And I would come out only after those patients will come out. So I have seen the agony of the patients and how they feel. Every half an hour, they will ask how much urine I have passed. So it was really painful. And after that, I have been in Saudi, and I have been with the transplant program. And then in IGMS, I was given this charge of certifying the brain death. So thing is that it's okay for us. It's a part of the life and part of the job of a neurologist, neurosurgeon. Only thing I want to comment is that in any brain death, especially for transplant, you have to decide the known cause. Unless there is a known cause, you can't decide, you can't say that this is a brain death and can go for. So this has, because this has not been highlighted in this meeting till that, that's why I'm highlighting. Otherwise, these films are beautiful. Dr. Sandeep Bess is a personal friend of mine, a neurologist and a neurosurgeon, and he is from AIMS. And he had also many videos on brainstem death and the brain deaths, and some of them are more beautiful. So I thank all of you. Thank you. And
Thank you so much, sir. Thank you, sir, for chairing this session. So now we move on to the next session. Dr. Chandan, please. Thank you so much. Dr. Chandan.
Excellent session. And for the next session, I would like to invite the chairpersons, Dr. Ajit Kumar sir, Additional Professor, All India Institute of Medical Sciences, Patna, and Dr. Abhishek Chaudhary, DM Critical Care Medicine. Sir, please come on to this. Hello. Am I audible? Hello.
Good morning, everyone. I would like to call upon stage Dr. Stakshina Mulik. She is an intensivist at Kolkata, and she has finished her MD General Medicine, then IDCCM, then FNB in Critical Care Medicine. Also, she has finished her EDIC. So, welcome, ma'am, on stage.
So good morning and thank you. Thank you for the kind introduction. Good morning, everybody. So while you were getting set with the technical stuff, may I ask how many neurologists there are in the audience? One. Thank you, sir. Neurosurgeon? Euro nahi, sir. Neuro. Because I'm going to be talking on identification and declaration of brain stem death. So that's what I was asking. So neurologist or neurosurgeon? Thank you, sir. Intensivist? Okay, fine. Okay. So I've been invited to talk on brainstem death identification and certification. So my only disclaimer is that not a single word here in these next few slides are my own. So what I've done for the identification of brain death, I have referred to the most recent, can everyone hear me? Yeah. Right. So I've referred to the most recent, it's a consensus statement from the World Brain Death Project, and it came out in JAMA. It's a free download, and if you're doing this, I would advise you, I would ask you to just go through this document, and there are lots of supplements to this document also. And for the certification of brain death, obviously, according to the law of the land, we have, as Dr. Shroff has also pointed out, we have our Form 10, which is directly from the NATO website. So everything is all copied stuff. It's all copy paste. So coming to brain stem death identification. So what was the World Brain Death Project about? So basically it was seen that different countries, different regions, different societies, they had different concepts, different definitions, different ways of determining brain death. And this was problematic and it was confusing. So what they did, the Brain Death Project did, they got together, they approached neurology societies, neurosurgery societies, anesthesia and intensive care societies all around the world. They got some people together, they formed a panel, and what they did is they sifted through the evidence for the concept, the determination of brain death, and they came to some recommendations. Now, these recommendations are of two categories. You need not go through. I'll just run it. I'll just run through what's written there for you. So the recommendations are in two categories. One is we recommend and we suggest. So we recommend either is a good quality of evidence according to the studies and the evidence that they have, or there's a consensus of the majority of the panel, versus the we suggest guidelines that they've given, which is there's less evidence for many reasons. There can be less evidence on this topic, or the people didn't come to a consensus. So we'll be going through these recommendations in the next few slides. Now, what is the relevance of this World Brain Death Project? So if you come to the, where's the pointer gone, please? Pointer. Yeah. So if you come to the last para, the relevance is the recommendations for, thank you. So it's basically recommendations for the minimal clinical standards for determination of brain death. Now there's a BD, which obviously stands for brain death. There's also a /DNC. So DNC stands for death by neurological criteria. Now, why did this term come up? See, death and it, understanding death also helps whoever is declaring brain death to get it across to the family. We come across a lot of difficulty in making the families understand what brain death is all about. So when I personally, have to declare, so I tell the family there are two main important organs in the body. One is the brain, one is the heart. So in very emotional terms, we think and we feel from the brain and the heart. So either one dies, you're dead. So that is, I think, the simplest way of putting it. So we are normally used to circulatory death. So death by circulatory criteria vis-a-vis death by neurological criteria. So DNC stands for death by neurological criteria. And the terminology actually is changing. The only reason the word BD is still retained, and that's why they've kept a BD/DNC, is because the term BD is so popular. That's all there is to it. And it's the explanation for this is there in the document also. So these international societies come together and the Brain Death Project. The recommendations can help guide professional societies in actual development or revision of their protocols and the procedures for the determination of DNC. So the document has a whole glossary of 1.5 pages of definitions. I've only picked up 2 from that. And the rest of the document deals with what the worldwide variance in the concept of brain death, the worldwide variance in brain death or brainstem death. Because, if you are in UK and India follows UK, so we do brainstem death testing. If you were in America, it would be brain death, where you would have to have the cortical death also along with your brainstem death. So they're trying to unify all this together. So the concept, what are the criteria and the prerequisites, the actual clinical testing, which you just saw the video of, just the second video that you were shown. I won't be dealing with this in very great detail, the apnea testing, and there are a lot of pitfalls here. The number of examinations that one has to do, the minimal clinical criteria for determination, the confounders which are also dealt with in the prerequisites, what the ancillary testing are, and some special scenarios and how to document and what the qualifications for those who actually do the testing should be. So I'll go to the definition. So death by neurological criteria is defined, and here every word, just like in every definition that we've read so far, every word is important here. So death by neurological criteria is defined as the complete, and Dr. Shroff also, I think, mentioned this in his talk, the complete and permanent. So complete and permanent. There is no reversal. Even in the video, the first video which you saw by Dr. Vaishya, he also mentioned this, the one in Hindi, he mentioned that it was permanent, it was irreversible. Loss of brain function. Here they're not differentiating whether it's brain or brainstem. Loss of brain function as defined by unresponsive coma with loss of capacity of consciousness, the brainstem reflexes, and the ability to breathe independently. So all these 3 we test separately in our brain dead testing. This may result from the etiology. Someone was just mentioning etiology. I think our last chairperson was mentioning etiology. So this may result from permanent cessation of oxygenated circulation to the brain. That's an absolute cutoff of circulation to the brain, and or after a devastating brain injury. This brain injury can be traumatic. It can be a vascular accident. So this part is what I explained about the definition of death by neurological criteria. And I've just kept the term brainstem death because that's what we do in India. So it's the diagnosis and confirmation of death based on the irreversible cessation of brainstem function. That is your midbrain, the pons, and the medulla. And that's why we do the cranial nerve testing and the apnea testing. So what's the worldwide variance, in the concept What the Brain Death Project they tried to do is they recommended that the minimum criteria for death determination be incorporated into the DNC determination protocols worldwide, all throughout the world. And the hospital policies should include the most up-to-date guidelines. And it is recommended because, there's something new here that we don't have in India, which I would really like to highlight. And there are a lot of people from the government. There's ROTO and SOTO. So I'm wondering what the government is thinking about this. We'll just come to that. It is recommended that clinical checklists be in place, and it is suggested that training and credentialing be there in place for the clinicians who are actually doing this testing and declaring. So what is the concept all about? It is recommended that DNC be defined as a complete and permanent loss of brain's function. Now, there can be activity at the cellular level in the brain, but it does not necessarily preclude that, but it does not necessarily mean that your patient may not be brain dead. So cells might work, but the organ as a whole is dead. If the organ as a whole is dead, your patient is dead. And if all your testing is positive, then your patient is dead by neurological criteria. So individual cells might be working. So that's what they're saying. In the context of death determination, permanent refers to loss of function that cannot resume spontaneously or with any sort of intervention. It is recommended that ensuring irreversibility of a person's clinical state in DNC does not require performance. So basically, let's say a person comes in with a massive bleed, with a midline shift, near coning, and you call, obviously, from the emergency, the patient comes in, they do a CT scan, they'll call in the neurosurgeon, right? So the neurosurgeon will come and see the CT. And often they say there's nothing to be done for this patient. So even if I do some intervention, even if I do put in an EVD, I cannot save this patient. So what they're saying here is that if this therapy or this intervention is futile, but there is a neurological substrat, there is an etiology which can actually lead to brain, then don't go for that intervention, or don't go to give your patient mannitol or hypertonic saline or any sort of hyperosmolar therapy. Accept the fact that it is irreversible. It is not necessarily to be always instated. Was that, I mean, did you get it? I don't see, there are not many people in the audience who are doing brain stem testing. Anyway, so basically, don't just put in an EVD or do hyperosmolar therapy just for the sake of doing it. This is what they're saying. Next point, it is recommended that the persistence of hormonal regulatory function. So we know when the patient cones, the pituitary stalk gets pulled, it gets elongated, and the pituitary stalk elongated, and some of the hormonal functions, especially the posterior pituitary and some of the anterior pituitary, they don't work. So you have things like diabetes insipidus because of AVP, ADH deficiency. So it might not happen always. It might not be full. It might be partial, but that does not necessarily mean if all your testing is positive, then your patient is not. If all your testing is positive, in spite of that, your patient is brain dead again. So it is suggested that the terms, so this, I mentioned this about terminology. And the next point, it is suggested that if an assessment for DNC is being made in a region that equates whole brain dead, like in the US, then if there is an isolated brainstem pathology, then you have to go for ancillary testing. And in ancillary testing, you have to prove that there is no circulation to the whole brain, anterior or posterior circulation. You have to actually show that there is no perfusion to the brain in order to be confident in declaring brain death. But if there is any circulation present, then you cannot declare. So the minimal criteria, the prerequisites, basically you need to establish from the clinical history, the etiology and neuroimaging, demonstrate that the person has experienced an irreversible, devastating brain injury, which can lead to loss of all brain functions, which is compatible with the diagnosis of death by neurological criteria. And there are no confounders that could make the person appear to be brain dead. So what are confounders? What are the defining as confounders? The circumstances during which a diagnostic test or clinical evaluation may become unreliable and require, I'll give you examples of this, and require repetition over time or application of an ancillary test to actually prove the clinical state. So you have to, it's recommended that pathological conditions, confounders, or reversible conditions that may mimic DNC be excluded, and it must be demonstrated prior to commencing a determination. It must be demonstrated that the person has an established neurological diagnosis, and which can result in the irreversible loss of all three: the consciousness, the brainstem reflexes, and the spontaneous breathing. So prior to making a determination, so there has to be neuroimaging evidence of intracranial hypertension. So you actually need to do a CT scan at the bare minimum, and which will show severe cerebral edema with herniation, and intracranial pressure measurement, which is at least equal to or more than mean arterial pressure. So if you remember our formula for intracranial pressure, so intracranial pressure is equal to mean arterial pressure minus cerebral perfusion pressure. Now, in a person who is brain dead by neurological criteria, there'll be no cerebral perfusion. So the cerebral perfusion pressure part is 0. So that leaves us with, what do we are left with in the formula? So we are left with an ICP equal to mean arterial pressure at the least. It might even be more. In fact, there are ancillary tests which can show reversal of flow also. We'll come to that. So it is suggested that in the absence of herniation on neuroimaging, you should be really cautious in going ahead with this diagnosis. Because if there's no herniation, it's extremely unlikely that your patient is, the brainstem is affected irreversibly, fully and irreversibly. So the following prerequisites are required to go ahead with the testing. So the minimum core temperature should be 36 degrees centigrade, the minimum systolic blood pressure 100 millimeter mercury, mean arterial pressure of 60, and the following confounders are excluded. Pharmacological paralysis should not be there. If it has been any paralytic has been given, you should do a TOF test, that's a train of force stimulation test, or at least a clinical test of assessing your deep tendon reflexes. Then CNS depressant drugs like toxins, or any drugs where, we give sedation, we give analgesia with sedation effect. So in case such drugs, or we suspect a toxicological background for this patient's unconsciousness and leading to this condition, because your toxin might be associated with something. Let's say someone drank and drove, had an accident, had a head injury, and then landed up in the emergency, CT done, big bleed. But if let's say the alcohol level is very high, or your toxicology screen shows as some other toxic, something drug abuse, abuser drug, which is high or positive, then you need to give time for that drug to wash out. Or you need to do an ancillary test later on. So you have to do a tox screen, and you get those tox kits in the emergency. Most emergencies have them. And most of the commonly used the drugs of abuse are included in that. You can do drug levels, or you can allow for 5 elimination half-lives, which will be a safe here. If you don't know what toxin it is, then you're in a trouble. Then you probably have to do ancillary testing, or you don't know when it was administered. Both these, you don't know what was given, when it was administered. So you can't calculate your 5 half-lives from X time if you don't know that initial time 0. So alcohol levels must be less than equal to 80, and you need to exclude severe metabolic causes, acid-base abnormalities, and endocrine derangements that also could alter your examination findings. So then interventions to decrease ICP, as long as it is, the neurologist or the neurosurgeon comes and says this is irreversible, probably irreversible. There's a doubt, then they should be put in. Just like the opposite, I said that when it is beyond doubt that it is irreversible, you shouldn't put it in. But as long as your patient is in the therapeutic phase of care, then you have to try all measures to save the patient. And it is recommended there should be an adequate observation period. So the initially for anoxic brain injury, it is 24 hours. So if your patient has a cardiac arrest, CPR started, revived, but now your patient is unresponsive. So you have to allow at least 24 hours before you can even start thinking anything. In the meantime, obviously, you can, rule out your prerequisites. You can do the brain imaging. So you can do those things, but you can't think of, or you can't start thinking about brainstem testing at that before 24 hours. And for other brain injuries, which are non-anoxic in nature, then it should be determined on a case-by-case basis. Previously, say about 20, because one of the first articles on this came out in NEJM by Elko Vijix, and Elko Vijix was the gentleman who first wrote was one of the authors of the AIN guidelines, which were the initial American guidelines. So he had said in non-anoxic states, it should be 6 hours. But nowadays, they are stating that it should be determined on a case-by-case basis. So the minimal clinical criteria, firstly, it is a clinical test. So it should be all patients should be assessed for devastating brain injuries, regardless of whether they are potential organ donors. So this is something that I believe, and I'd like to invite Dr. Shroff, Dr. Arpita also for comments here. This is one thing you just mentioned, that a patient who's brain dead tested, because it is a catch-22 situation. Unless you go for the testing, you cannot even think of donation. But nowadays, I believe that even if this patient, because in Form 10, there is an option whether yes or no the patient's family is going, or the next of kin or whoever is signing on Form 10, is Form 8 is going for, in Form 10, are they going for organ donation? Yes, no. So the government actually has given the physicians an option to declare brain death without organ donation. So I think now it's very clear. So now we are in a happier state of mind. We can actually, go ahead with the brain death test, brain death declaration. And this whole quandary of corporate hospital and disconnecting from the ventilator, if you've certified death, then yes, you can disconnect the ventilator. There's nothing wrong in that, because this patient is declared death. Only the form is different. It's not the usual death certificate that you will give for circulatory death. It's a different death certificate. It's Form 10 that we'll be giving. So I don't think there is a quandary about this anymore. So if any aspect of the clinical examination cannot be completed, then you should think of ancillary testing. And there are many reasons why the different parts of the testing might not be able to be completed. But it's just because one of them cannot be done does not mean you don't do the others. You try to do the others, right? So if you can't say, if there's some injury which has, bashed the eyes, the globes, so you can't obviously see the pupillary size or the reaction. You can't do a corneal reflex testing, but you should go for the rest of the testing. But if you couldn't do that, then you should go for an ancillary testing. So the testing actually, this was shown in the second video. So your assessment of coma, then the pupillary reaction, the corneal, oculocephalic, oculovestibular reflexes, facial movement to noxious stimulation, the gag reflex, the cusp reflex, and no motor response to noxious stimulation of the limbs. So coming to the apnea testing. Now, the apnea testing is stressful for the patient, whether you want to call the patient a patient, not yet a body. Probably during the second testing is a body, because again, there is a controversy regarding that currently. So the apnea test should be conducted last, because there is a risk of increasing the intracranial pressure. So if your patient actually is not dead, is alive, then you are hampering the patient's chances of living. So you should complete the rest of the brainstem testing and then go for the apnea test last. So one of the primary requisites is that patient should have no spontaneous respiration in a normocarbic state on the ventilator in a spontaneous mode. Obviously, you'll have to change the settings so that the patient doesn't keep on going into backup mode. And it should be performed by personnel with experience in resuscitation, because it might happen that your patient destabilizes, and probably should not, but may happen that your patient even arrests while you're doing an apnea test. You probably shouldn't let your patient go into an arrest situation. You should stop the apnea test, draw an ABG sample and put the patient back on ventilator. So ventilatory requirements should be known by whoever is doing it and should be assessed, predetermined before. And if there is a high cervical cord injury, you should not do an apnea test. In that case, you should go for ancillary testing. So there are the same prerequisites actually repeated again for the apnea test. So the same BP targets, the same temperature, and the patient should be pre-oxygenated at 100% FiO2 on the ventilator for at least 10 minutes. So basically your apnea state starts at minus 10 minutes. You've hitched up the FiO2 to 100%, 10 minutes, draw an ABG, then choose your mode of doing the apnea test. I'll be coming to that. And then depending on the stability of the patient, repeat your blood gas. You should have an arterial line in place also. Did I do something wrong? Or am I out of time?
Yeah, you have time left.
May I cancel this?
We have 6 minutes.
We have 6 minutes, I think. So go ahead, please.
Okay, so while they're canceling, so the modes in which you can do your apnea test, either you can keep your patient on a CPAP, that is, you only give PEEP to the patient, you give a pressure support of 0. So the patient is supposed to be breathing on their own, but not supposed to be breathing rather. So you're testing the not supposed to be breathing. If there is any spontaneous breathing, automatically your patient, is not, or the patient is alive basically. So that's one. Number two, you can put the patient. Okay, right. We're back. Good. You can you can disconnect from the ventilator after having pre-oxygenated for 10 minutes. You can do what we call a tracheal insufflation. So a tracheal insufflation, you just put a catheter down the ET tube up to the level of the carina at 6 liter oxygen per minute and observe your patient for 10 minutes. Try to observe it. But you obviously have to, constantly keep your eyes on the monitor to see if your patient, and you have to observe for spontaneous breathing and keep your eyes on the monitor to see if the patient is desaturating, if your patient is becoming hypotensive or having an arrhythmia, which is making the patient hemodynamically unstable. In that case, you have to abort the apnea test. Now, the third mode of doing it is putting the patient on a breathing circuit with a PEEP valve. So you're giving about, say, if you're a neurology patient, you would give about 6 centimeters of PEEP. So you give this patient 6 centimeters of PEEP with a PEEP valve and a breathing circuit, and you watch for spontaneous breathing. Right. So I think we've done that. So at the end of 10 minutes, if your patient was stable, you draw your second blood gas. Next. Chale galo. Gone. Yes, thank you. So you either may have an ABG machine in your ICU or you may not have an ABG machine in your ICU. So if you have an ABG machine, your point of care POCs for point of care testing, if you have an ABG machine in your ICU, what you can do, and your patient remains stable throughout the 10 minutes, when you draw the second blood gas at 10 minutes, you can keep the patient on whatever mode of apnea test, apneic ventilation that you were keeping the patient, if your patient is stable. And you then see the CO2 and the pH of that second blood gas. Now, if the CO2 is above 60 millimeter mercury or 20 millimeter mercury above baseline, if your patient, because you can have a COPD patient who's, whom you are testing. So a COPD patient will normally be a carbon dioxide retainer and have a higher CO2 baseline to start off with. So you need to go 20 above the baseline. So this is the cutoff.
Just a reminder, ma'am, we have 3 more minutes remaining.
Right. Okay. Yeah, apnea test is important and very confusing. That's why I'm doing this one in detail. The rest I can cut. So if your patient were unstable, forget about it. You put the patient back, you stabilize your patient. You might even have to re-recruit your patient to improve the oxygenation status. Repeat the test. That's one. Two, you do it, you get above 60 or above 20 above baseline, and your patient is positive. Now, let's say your patient became unstable. As I said, you still draw blood gas and put the patient back. If you've already reached the targets, even if it's before 10 minutes, your apnea test is still positive and you can go ahead with your declaration. There is another where your apnea test might be negative. Now, if you had the ABG in your ICU, then you can continue the apnea test for another 5 minutes, repeat another blood gas. It often comes as positive. Or what you can do, if you don't have it, you reconnect it, get the ABG back, say after, if it's not in the ICU, it will be back in 10 minutes, 10 more minutes or so. And then you repeat your apnea test again at a suitable time and with an extended time for maybe 15 minutes. It might even, this time might even have to be extended. I hope it was clearer than before. Thank you. Achha. So I've mostly explained most of the apnea test. Yes. So last point, if the apnea test is aborted and cannot be repeated safely, let's say your patient is repeatedly becoming hypotensive, repeatedly becoming arrhythmic, and you cannot do it safely, and you think you're going to lose the patient, and you probably might even end up losing organs for this, then you can do an ancillary. You restabilize your patient and do an ancillary test. So the number of examinations, now this is the only point that I found in the brain death world, brain death project statement, which is really different from us, different from what we are doing. So what they are saying that only a single examination is sufficient because you have already given the patient ample time. You have checked for irreversibility, only then have you gone for your first testing. So they are saying that only one set of testing and one apnea test is enough. Now, there are different rules in different parts of the world because these are all, if you've noticed, these are all suggest. They are not recommendations because obviously there could not have been consensus in the world panel on this. So they are saying at the end of the day, follow your local guidelines. So that's what we are going to do. We are going to do 2 sets of testing till our government actually comes around to this.
We are out of time, ma'am.
Yes. I am the only speaker right now. Okay. So the ancillary test. So basically the ancillary test is done in the following circumstances when you can't, as I said, clinically can't finish. There are confounding factors which you cannot overcome. There is uncertainty regarding the interpretation when you have a high spinal injury and you cannot do an apnea test, and the clinical examination as best as possible must be completed to the fullest. And so that ancillary, and there are many families who don't accept the brain stem testing, the testing clinical results. For those people, there is a suggestion that you can do an ancillary test, because if you say do a 4-vessel angiogram and there is no flow to the brain, then you can actually show a picture to the family saying there is no blood going to the brain and so your patient cannot be alive. So it probably will help them accept the death better. So what is recommended? So for conventional 4-vessel cerebral angiography, that's the gold standard. Some radionuclide studies like your SPECT and perfusion scintigraphy. Transcranial Doppler ultrasound. Now, many intensivists nowadays are very into doing bedside ultrasound, and they have bedside ultrasound available in almost all reasonably sized ICUs across. So to do this, in very short, you need a baseline, a transcranial ultrasound to prove or to show that initially when your patient came in, there was flow. At least at 30 minutes, the minimum gap between these two needs to be 30 minutes. There have to be 2 testing. And then you have to show that there's no flow or reversal of flow. It has to be done bilaterally, anteriorly, and posteriorly. So all 3. So for the anterior circulation, for your middle cerebral circulation, and for your posterior. So 3 and 3, there have to be 6 areas where you have to look into. It is not recommended for pediatric, by the way, because I won't have time to go into the special situations. Right. So when there is presence of blood flow, if you have gone for an ancillary test, and as I mentioned previously, and there is blood flow, you cannot declare brain death. So repeat examinations should be conducted. EEG is not supposed to be routinely used anymore. So, but if EEG is used, it has to be done with either brainstem auditory or somatosensory evoked potentials. It can be used only if there are regional laws for the same. CT and CTA, that's CT angiography and MR angiography, is not supposed to be used, and the rest modalities are not. And what they can look into is CT angio with perfusion scanning, CTP, that is. So this is something. So for shortage of time, I won't go into the neonatal and
I
pediatric.
think we can move to the next session, and we'll still have time to discuss some of these issues.
That's why I'm not going into the special.
In the donor optimization, which you're supposed to do, we can club it with the next session with Rahul Pandit, and we can do it in the panel because it's all about the same discussion.
Right. Right.
So that will save some time.
Yes.
Thanks a lot.
So documentation.
You can finish in a minute if you want. Not a problem.
There's nothing. This is just the form.
Yeah, sure.
It's all, the rest is all pretty.
Sorry to take away from you, Abhishek. I thought since we're running a little late, wanted to bring it back on time,
Okay.
So, yeah.
We can take a comment from Dr. Ajit from AIIMS Patna.
Hello. Am I audible, Harsh?
Yes, you're audible.
So very thank you for Harsh for giving me this opportunity, and I would say this presentation is very nice, elaborative, and if you for the determination and brain stem identification and certification, it is very crucial part of the organ donation part. So what you need to consider, you should have always rule out the co-founder factor, co-founder factor and the testing. Generally, you will not able to do any testing, very authentic testing, and will proceed. Okay, so that's good, and I thank Dr. Malik. That's very nice presentation. Thank you.
Thank you, Dr. Ajit. So the next two sessions.
Just a second.
Okay, Dr. Abhishek would like to make a comment.
Yeah, thank you for the wonderful and exhaustive presentation, ma'am. One thing I would like to tell that the doubts which Dr. Sanjeev was asking. So ICU regarding transplant brainstem death testing, jitna karenge, utna we get confident, utna we know how to handle. And also it needs a lot of counseling. You have to counsel the ICU. Working in an ICU, of course, there is treatment part and there is everything else, but counseling is very important. You cannot expect to counsel a patient right bedside near their patient. There has to be a separate counseling room. There has to be a place where the patient can sit with one other relative, and the doctor with a nursing in charge and a social worker have to counsel a patient, all ICU patients daily, on a daily basis. It's not like कि हाँ cardiac arrest हो गया, अब transplant करना है तो चलो अब counseling करना start करें. जब भी ऐसा शुरू होगा, there will be a conflict and we will land up in trouble. So counseling is important. It has to be done daily. As much as important it is to treat a patient, it is very important to counsel the patient and the attenders. Thank you.
Thank you, Dr. Abhishek. For the next two sessions would be clubbed. So I would like to invite the chairpersons, Dr. Arvind Kumar. He is a faculty of anesthesia and critical care at Indira Gandhi Institute of Medical Sciences, Patna. And Dr. Amit Kumar, he is a senior consultant nephrologist from Ranchi, Jharkhand. And the panelist of the sessions, and I would also like to invite Dr. Rahul Pandit. Whosoever is present physically in this audience, that is Dr. Abhishek, Dr. Sanjeev Kumar, to kindly come on stage to chair the session, sir. And Dr. Sudakshina Malik, ma'am, would be conducting this session. Okay.
Dr. Rahul Pandit is there in the audience, is a very senior critical care, functionary in this country. He's also, I think, president-elect of the ICCM, the Indian Critical Care Society. So Rahul is joining us from Bombay, and he's a champion of organ donation. He has done many brain death certification. And one question which was asked earlier, when there is no consent for organ donation, how do you switch off ventilator? He is also going to give you some answers if you want. He's done that many times. The panelists are already here. So the donor maintenance, what we are going to discuss, Rahul is going to take you through various clinical scenarios, which will be more applicable in intensive care. Rahul, over to you.
Thank you, Dr. Shroff. Just one correction. I'm not the president-elect yet. I was the vice president, and let us see how things move forward on that direction. Thank you very much for the kind invitation. And can I get all my panelists on board? I've got Dr. Bhattacharya. I could see Pradeep shortly. Pradeep Kumar Bhattacharya. Yeah, he's there. Dr. Ajit Kumar, Dr. Abhishek Chaudhary, Dr. Sanjeev Kumar, Dr. Dubey, and Dr. Malik, of course. She had a wonderful presentation. So am I allowed to share my slides?
Yeah.
Thank you. So I've got I've got around 20-30 minutes with me, Dr. Shroff, as per the timing, up to 12:15, right?
Half an hour, yeah, 30 minutes.
So I'm going to move quickly with the case capsule so that...
On, Rahul.
Sorry?
12:15, you're on.
Up to 12:15, I'm on, right?
We have enough time.
Yeah. All right. Okay. So I will start up with, the simple test. I've got around 10 scenarios, very clear, just to sort of clear off the doubts of everyday life. And I would first like to sort of address this question to Dr. Bhattacharya. Pradeep, when should I start testing for a patient for brainstem death? The patient is in ICU. The patient is having a irreversible brain injury as per the history and a CT scan. When do you think we should actually initiate this testing? It's a very simple question, but is very often asked by many doctors, many nurses, many residents. If you could just throw some light on that, sir. Dr. Bhattacharya. All right, anybody else from the panel? Looks like Dr. Pradeep is just gone offline. Anybody else who could take that question, please, from me?
Dr. Abhishek Chaudhary here.
Yes, Dr. Chaudhary, thank you very much. Please go ahead.
So, according to I am quoting the US guidelines. So, patient, normally the number one criteria is the patient should be on the ventilator. And number one criteria. Number two, Glasgow coma scale should be, he should be like 2T, E1, V1, and T by 15. Third one is we have to, the cause of brain death. If we are suspecting brain death, what is the cause of brain death? We have to be sure of that. We have to rule out the confounding factors. And of course, there are no confounding factors like hypothermia or, poisoning or any other poisoning in the sense any muscle relaxant or any paralytic agents were given. And of course, the patient should fulfill the criteria. Like should not be more than, the criteria which says not more than 80 years of age. And of course, should not have any active malignancy or active hematological malignancy. And of course, the other functions like the electrolytes should be.
Thank you. I think what's important is malignancy is actually not a precondition to be fulfilled at all. Malignancy becomes a contraindication whether the organ will be assessed or not. I think I think you've answered excellently well. I just like to add just one word here. We need to decouple the two processes of organ donation and testing for brain death. So even if there is a malignancy there and if the patient is brain dead, I think our first job is to actually go ahead and declare the patient dead. Organ donation can be an outcome, may not be an outcome. And as Dr. Chaudhary rightly said, look for potential causes for brainstem death, dysfunction or death. Look for obvious reversible causes and look for the other confounders. So hypothermia, electrolytes, alcohol, sedation, neuromuscular blocking agents. So if you have sedation on board, at least wait for 5 half-lives of sedation to be gone. If you have got any doubt about neuromuscular paralysis, get the help of your anesthesia colleague from OT. get a neuromuscular peripheral nerve stimulator, and you can do a train of 4 if you are really not sure whether the patient has received any neuromuscular blockade or not. But usually that's not the case. Again, 5 half-life should be enough. Electrolyte abnormalities on the extremes of the border, a little bit of up and down electrolytes is fine. And obviously you want a patient who is normoglycemic and has got a reasonable acid base, which is no closer to normal. Okay, I'm just going to skip up and come up to the first case scenario here. And maybe Dr. Dubey, if you're there, you could answer this, or Dr. Ajit Kumar could answer this. We are starting to do the brainstem death testing, and the patient sort of has a little bit of a flexion of the elbow, not fully up, just a little up, little flexion of the elbow, not against the not against the gravity, just around the gravity. And that was to the pressure given on the nail bed on that side. Is this patient's diagnosis of brainstem death still possible, or it is not possible? If you could just explain, this question revolves around the spinal reflexes, and I would like you to sort of talk the audience about spinal reflexes and where should we be giving the deep painful stimulus. Dr. Dubey or Dr. Ajit Kumar, either is fine.
Hello, sir. I am Dr. Ajit.
Hi, Dr. Ajit.
Sir, what observation, there are two things which are compatible with brainstem death or which are not compatible. So what the compatible things are: spinal reflexes, sweating, blushing, normotension without pharmacologic support, and absence of diabetes mellitus. But these were incompatible tests, that is decelerate or decorticate positioning, extensor of flexor motor responses to painful stimuli. So I think this is you should not consider for brain dead patient, the patient having such type of.
Okay, I think this. Sorry, go ahead.
When we are doing this test, we must explain to the patient relatives and whoever is there present about the spinal reflex and how it is there, so that there is no confusion in their mind about this thing.
Excellent, sir. I think you've absolutely pointed out the right thing. The patient may still represent a spinal reflex for two reasons. One, as sir rightly said, we need to talk about the spinal reflex to the family. Whenever I do a testing, we've just actually completed an organ donation this morning. We did the last test at around 1 a.m. today, and the patient went for organ retrieval early in the morning. So we allow the family to actually witness the test if they wish to. That's something which we have as a unit. We are very comfortable. We are very confident of what we are doing, and we are very, very thorough in the communication. So what we tell the family is that there are some spinal reflexes, and the spinal reflexes are present because anything below the neck, anything below the foramen magnum is still working, and that's basically the spinal dermatomes. So if you give a pressure into the nail bed, you may likely stimulate a spinal reflex, and you may have some movement at the elbow joint. So it's very important to give a deep painful stimulus at the point where you have afferent and efferent, both in a cranial nerve distribution. So as intensivists and neurologists, we know that, but I think it's imperative that we actually tell everybody about it, that this is where we should be giving. So the medial canthus of the eye, or the trapezius squeeze, or a jaw lift are the ones which are actually acceptable deep painful stimuluses, and they are afferent and efferent both with the cranial nerve within the cranial nerve distribution. I think we should be very clear what we are doing that. So that is very important, cranial nerve distribution. So the second evolves around the same, which is a Lazarus sign, and I will just continue with what can happen. This has happened to me at least twice now in the last so many years. We must have done more than 150. I must have personally done more than 150 to 170 organ donations in the last 20 years or so. And we've had twice the patient actually had a full Lazarus, sat up and fell and went back. And again, I think communication. Somebody was mentioning before, I think Dr. Chaudhary was mentioning before we actually lead to the organ donation as a topic or brainstem death as a topic, several hours of communication have already gone in. And that several hours of communication revolves around several issues, not just the patient's current condition, but potential problems, brainstem death testing if you're going to do, And we actually walk through the brainstem death testing. Every test is explained to the patient, and then we talk about spinal reflexes and Lazarus reflexes as well. That clears the communication with them. That gives them the confidence that doctor is actually telling what are the various possibilities which can happen. And one more thing I always tell them, that when I'm testing for brainstem death, some of the buzzwords which we use, I tell them that I'm looking at the functions with which we are born. So the baby who is 1 minute old, whatever brainstem functions the baby has, those are the functions which we test. All the cranial nerves are intact in a healthy baby who is 1 minute old, and the baby does not need to learn how to breathe. The baby just breathes by itself. Everything else is learned by us. And I also tell them that it is the breathing which makes the difference between life and death, and not the heart rate or the cardiac activity. The cardiac activity starts in the 5th week of gestation in the mother's womb. We do not celebrate the patient's or person's birthday in the 5th week of gestation. We celebrate the person when the person started living, and that living means when he started breathing. If you say these kind of explanatory things to the family, they quickly understand that it is the life is basically about breathing, not just about cardiac activity. And if you are assisting breathing with the ventilator right now, the cardiac activity will continue for some time. Of course, it will also stop ultimately, but it gives you that window of period where you can test the patient for brainstem death and perhaps talk about organ donation after that. So I think these are the two things which I wanted to come up from these 3 tests. Now, this is, I think, partly been addressed by Dr. Chaudhary, but I would just like to sort of talk about it anyways, because it's an important thing. This is again a real life scenario. I'm on the Roto committee for ICU, so I keep on getting these calls from across the state, few other states as well. A 22-year-old female, unknown poisoning, brainstem death done 48 hours post admission, and both apnea tests were done and criteria was sort of satisfied, is what they said. There was no documentation of hypoxia, arrest, trauma, and the cause of brain death was given as metabolic encephalopathy. Any one of the panelists, I am keeping it open, maybe Dr. Malik can take it, anyone, it's very clear for intensivists, but I think for everybody else who is on the audience to understand that can this be a problem for us, and what is the problem in this? If anybody could just throw light on that, please.
Hello, Dr. Pandit. Yeah.
Hi, good afternoon. Good morning, rather. It's still not midday.
Yeah. So, the problem here is the word metabolic encephalopathy. So metabolic encephalopathy is something that the cause should be found out, and it probably should be reversible. So I mentioned this when I was when I went through my lecture also. So if it's a poisoning, we often don't know when or what poison. So that is a problem, because when the patient might come into the emergency, but then so the possibilities are doing a tox screen, doing drug levels, or allowing 5 half-lives if we know. But then if we really don't know, then it is, if the prerequisites are not met, then we can't even start testing. So that definitely is an issue. In spite of that, clinically, if we think, and there is a milieu, there is a, there is a etiology, there is a neurological evidence that there is cerebral edema, there is herniation, we should go for a clinical test, and we should follow up with ancillary tests to confirm.
Absolutely correct. Lot of poisons, specifically organophosphate poisoning. I have seen great bite presenting like a brain death patient. Absolutely no movement, all rest, all brainstem reflexes absent. If you do not have a clear conclusive diagnosis, first do a CT brain. And if the CT brain does not show you anything which can be proceeding towards the brainstem death as a diagnosis, just concentrate on treating the patient. Don't even think of organ donation. Don't even think of brainstem death as a diagnosis. That's the first important thing which we want to talk about. In the same context, in this case, I have another question. Maybe if Dr. Bhattacharya joined back. Pradeep, are you there? So the second question is about hypothermia. We often see that these patients are hypothermic, and I personally feel that hypothermia contributes immensely towards the hemodynamic instability. So my expert panel, if you could throw some light, on how to deal with this complex issue. First of all, why do they become hypothermic? And if they do become hypothermic, how do you negate that? Is prevention better than cure? Those are the things which I would like to hear the pearls of wisdom from you guys.
Dr. Ajit here, sir.
Hello.
Hi.
The main cause of the hypothermia is since patient is going to the towards the brain dead. So all the just like the skin and there the just put to avoid the just making the a little bit warmer, the all activity of the skin is ceased. So in that condition, the patient is going towards the hypothermic stage, and for that we have to since for the proving the brain death, we have to just rule out the hypothermic state. So for that we have to keep the patient rewarming state. So for that we have to just keep blanket and the warming, and we have to just adjust temperature. In this way, just until unless the temperature is going toward the around the 36 or 36.5 degree centigrade. So after that we can decide the now we have to our test is at the proper levels.
Okay, excellent. Any other points anybody else wants to add?
Dr. Ajit, sir. Sir, please.
Yeah, I think Dr. Dubey and Dr. Ajit both want to talk. One after the other. I think Dr. Dubey spoke first. So Dubey sir, aap boliye pehle, then Ajit can contribute.
So I just want to add that first is the loss of hypothalamic control, and second is the loss of the compensatory mechanism like vasoconstriction or shivering. They also add to this thing, hypothermia. And lastly, that we might have inadvertently infused cold fluids during the management of a potentially brain dead patient. These are all the factors. And I think Ajit will also add something more.
Sir, I just one thing I want to add, sir. Hypothermia is best avoided or prevented than the treated. So causes are many more, but you have to avoid, you have to prevent for patient. I don't want to go that patient will go into hypothermia. The prevention is more important than treatment, sir.
Absolutely, I completely agree with all of you. Excellent discussion around this. And Dr. Ajit, I think you've actually taken words out of my mouth. Hypothermia is best prevented than treated. If a patient comes to you hypothermic, you actually reflects poor management on our part as an intensivist. So I think as an intensivist, it is our duty, primary duty, to keep the patient hemodynamically stable, and temperature control remains a very important part of it. If you look at one of the sayings, it's a very crude saying, but it does make sense. You are not dead until you are warm and dead. So you should be warm. You should be normothermic when you are actually being declared brain dead or circulatory death. Cold is not associated with death at all. So you have to warm yourself. And one more thing which I would add, I don't know whether Dr. Kumar mentioned about that, is always measure a core temperature. Yes. Never ever measure a surface temperature like axillary. It does not give you a good reflection. You have to look at either a rectal temperature or a nasopharyngeal esophageal temperature, or a bladder probe is what we should be putting up and looking at that. Next case is various attempts to do apnea test. This is just again the real life scenario. We had a 43-year-old person, aspiration pneumonia. PaO2 was 264, which gives a PF ratio of around 264 on 100% FiO2. An apnea test was attempted. He desaturated. So I think Dr. Malik sort of brushed upon the various ways in which you can do. Anybody can take this question again. Whoever feels comfortable. Various ways in which you can complete an apnea test. Obviously, one is to disconnect the patient from a ventilator and do it. But if you have any other ways to sort of assist our people in apnea testing. Who wants to answer this?
Dr. Abhishek Chaudhary here.
Yes, Dr. Chaudhary. Thank you.
Yeah, we started attempting a brainstem test, depth testing, and the patient has desaturated. Yeah. So before starting the test, we have to oxygenate the person with 100% FiO2. And we have done that. And even after disconnecting from the ventilator, we are still oxygenating through a tube, and still the patient has desaturated. So that time we cease the testing and we connect them back to the ventilator and we wait it out. We check the other parameters, we check what was the cause, and we do an ABG and we check it. And then we may reattempt the test at a later time, maybe 2 hours, 1 hour, 2 hours later.
Okay, so just pushing it a little bit more, sir. In 2 hours, exactly the same thing happens. Anything else you could do, sir?
Adding some CPAP, because the catchword is aspiration pneumonitis.
So what you can do is you can use a Mapleson E circuit, or Mapleson E is a bit difficult to get. So you can just use a normal Bain circuit, use 15 liters of oxygen. With that, mind you, the CO2 will take some longer time to go up because 15 liters is a large amount of flow. You can keep the valve half open and observe for the bag movement to happen. And you could complete the test successfully. Again, I have done it on several occasions. It's a very common scenario to have a head injury patient who is aspirated, even a stroke patient who has aspirated. And we find it difficult that even with a PF ratio of 200 plus, sometimes the patients rapidly desaturate as soon as you disconnect from the ventilator and put a small catheter to give 6 to 8 liters of oxygen supplemental. So Bain circuit actually comes into handy quite well. Obviously, if you fail this, then there is no other way in which you can do. Connecting them to a CPAP circuit on a ventilator quite often gives the ventilator sometimes the abdominal wall oscillations which happen because of the aortic oscillations or the heart oscillations, because the body has no tone and the heart beating actually oscillates the diaphragm as well, and the body sometimes, the ventilator sometimes actually identifies that as a breathing attempt, and then you will start getting some breathing seen on even on CPAP with that. So you need to obviously change the sensitivity of that circuit before you attempt it. But the Bain circuit helps you very, very well to conduct this test successfully without connecting them on a ventilator. And the bag gives you a very good conduit to look for movement of the respiration. So you don't have to worry about chest and abdomen. You can just keep on looking at the bag, whether the bag is breathing or not. So this is just one of the things which we can do.
Dr. Rahul, is not keeping partially open valve of Bain circuit something like CPAP?
It is, sir. Exactly right, sir. You're right. That's what I said. Mapleson E to give CPAP, but because E is not available, you use a partially open valve. Absolutely correct, sir. You are absolutely correct.
In this way, you can give some PEEP also.
It's like a continuous CPAP, continuous PEEP, which you are giving, rather than giving it to the ventilator, which has got a disadvantage that you will actually have sometimes the ventilator might trigger a breath, which will then spoil your entire interpretation. So this is a better way to do it, sir. So this is a patient who was reported to Roto as brain dead for distribution of organs. And here are the two ABGs. The one on the left of the screen is the pre-ABG, and one on the right of the screen is the post-ABG, sir. So I would like you to comment on this. The important aspect is the PCO2. On the pre-ABG, the PCO2 is 26.8, and on the post-test ABG, the PCO2 is 51. Dr. Malik again sort of talked about the rise in 20. This is where the rise in 20 is. Would you take this rise in 20 argument in this case, or would you insist on the patient being done with a normal PCO2 and then wait for the CO2 to rise above 60? Then the rest of the parameters are okay. Don't worry about the rest of the parameters. I'm just wanting to highlight the CO2 here.
Here, POCT is increased by more than 20. So this is in favor of the just towards the bed dead condition. So on the basis of all these things, but we have to also rule out all the metabolic cause and all these things.
Yeah, so provided these are all ruled out, let's just assume that everything else is in place. It is just the CO2 which is the question right now.
Hi, Dr. Rahul.
Hi.
So yes, so if my take would be that if the patient was stable throughout the apnea test, I would probably continue more than 10 minutes, repeat at 15 minutes, and then see the CO2 again, because this doesn't seem to be a patient of doesn't seem to be a chronic CO2 retainer. So chronically hypercarbic patient, for the cutoff of 20 increase would be for those cases. So they can either be a COPD patient or an OSA patient, an obstructive sleep apnea patient. Probably not for this patient where a CO2 we started off with 26. Unless the patient were really, because the patient is not normocarbic, the patient must have been hyperventilated.
Perfect. Absolutely spot on, Dr. Malik. This is exactly the argument which one has to do, that this patient is not a CO2 retainer. He's got a CO2 of 26.8. They have to optimize the patient and wait for the CO2 to come up to around 35 to 45 before they start doing the apnea test. And or wait for another 7-8 minutes, 5-7 minutes for the CO2 to rise above 60. Either would be fine. But this is not an acceptable ABG as a post-test ABG. I completely agree with you. For people who are not from intensive care and who are not from anesthesia, 1 minute of apnea will give rise to a CO2 of around 3 millimeters of mercury. So if you have 51 here, another 3 to 4 minutes, your CO2 would rise above 60 in this case. So either you have an option of continuing it till another 3-4 minutes, or you sort of connect the patient back, optimize the patient, bring the CO2 to 45, and then wait for it to go above 60, which is what basically the idea to keep this case is. The argument of 20 is fine where you have a CO2 which is retained normally by the patient, and not for patients ABGs which have got a CO2 of 26. Another case, and this is one of the very common problems. Here I would like you to look at the sodium, just the sodium. The sodium in the pre-test on the left side is 181. Sodium on the post-test is 183. Would you accept this test? And how would you address the problem of hypernatremia? This is a very important part of donor maintenance. Anybody?
So since in the brain dead condition, the posterior pituitary function is about to lost. So in that condition, there is the polyuria and the patient is going to the hypernatremic state. So for that, we have to resuscitate through the fluid, either the ring rotate or just half normal saline along with the dextrose and some other low sodium content crystalloid like Plasmalites A and others such type of the fluids are available in market. So this way we can correct the sodium and then we have to decide. So the primary goal is to have to correct through the fluid replacement.
Excellent, sir. Dr. Sanjeev, can you add anything more to that? Anybody else can add anything more to that, please?
Apart from this, we have to also add the arginine, vasopressin or the desmopressin so that you can just correct all these things also.
Correct. So most of the times it's actually a very high output of urine output because of diabetes insipidus, and you replace the posterior pituitary hormone by giving either vasopressin or desmopressin to the patient. Anything else, sir? Anybody else would like to add anything else? A few more points here.
Sir, for organ donation, the maximum limit of sodium should be less than 155 milliequivalent, because some study shows that it rejects the liver transplant and other patients. So it should always focus on this. It should not be such high like this.
Again, Dr. Ajit, these are two mixing points. So I agree that if the sodium is very high, the outcome from liver transplants are questionable. That's completely acceptable. And in the crowd, there would be a lot of liver surgeons and liver specialists who would be vouching for this. But here for organ donation, I agree that we need to bring the sodium back to as close to physiology as possible. In Maharashtra with ZTCC and Roto, we have cut off a margin of 160. Anything below 160, we accept for conducting a patient for brain death, and organ donation is something which we discuss afterwards. But brainstem death testing, we accept up to 160, not more than that. The other point is that if it is 183, like what we have right now, you need to bring it down And some of the intensivists or anesthetists have got a thought process, or neurologists have a thought process that don't correct it more than 10 millimoles per 24 hours. Well, this is not the cause. This is an effect. So this sodium has gone up because the patient became brain dead and became polyuric. To compound that, many of these patients continue to be given 3% saline or mannitol until they are declared dead. So that sort of compromises the sodium level further, because the 3% gives you a large sodium burden, and mannitol keeps on giving a lot of dehydration because of high urine output. And that further rises the sodium to astronomical levels like this. So we need to realize that we need to stop those things. We need to correct the sodium quickly. As Dr. Kumar said, half strength saline, 5% dextrose, free water through nasogastric tube. You can literally bring down the sodium within 2 to 4 hours down to below 160, and then conduct the testing. This is not an acceptable test, which either pre or post ABGs are not acceptable for us. I think this generalized tonic-clonic seizure has been discussed. I will sort of skip this. This is a very important one. This is again a real thing which happened with me. High-ranking civil services gentleman, his 26-year-old person who was his son, attempted hanging at home. When by the time he was brought to us, he had significant hypoxic brain injury. We followed the protocol. We declared the patient brain dead. Initially, the father actually was very inclined for talking about organ donation, and then he refused. And he refused. That's fine. We continued with the we did not go across and disconnect the ventilator, because I always feel that there has to be an assent and understanding and acceptance of brain death as a diagnosis. If brain death as a diagnosis has not been understood by family, there is no point in even talking about next steps. So we continued. Ultimately, the heart stopped in few days' time. And then the patient was obviously disconnected from the ventilator, and because it was a hanging, we referred to the postmortem. Now, in the notes, when would you put the time of death? The second apnea test, because legally you have actually declared him as dead, second apnea test, but there was no acceptance of brainstem death by the family. So the cardiac death, obviously, which was 4 days later, became the time of death. So legally, what do you do? These are some of the tricky questions. One could obviously one could sort of say we took a back seat as well, and we just put the time of death as a cardiac standstill as the time of death. But strictly speaking, the patient was dead 4 days ago. And when I tried to explain this to the police, they could not understand a word of what I was saying. That why did you inform us 4 days later that the patient is dead? Why did you not inform 4 days ago? That if you're telling that you did the brainstem death 4 days ago, 4 दिन क्या कर रहे थे आप? So these are some of the practical issues, and I just want some discussion around this. Maybe somebody from the crowd as well can talk about. Maybe Dr. Shroff and me we've discussed this. I mean, it's very clear in my mind.
We can't hear you, sir. Dr. Rahul, we can't hear you.
You can't hear me. Can you hear me now? Hello? Hello?
You are audible.
Hello? Can you hear me? Hello?
Not audible, sir.
Can you hear me now? Can you hear me now?
But this is a very common one.
You are audible on what, sir?
I totally agree with him. It was deja vu for me.
Hello, can you hear me now?
So they don't even accept. They don't even accept.
They continued for 48 hours. When they reached the cremation ground, there was an objection that why where the body was put. Even one time the police had reached us. After that, we counseled them that why this was removed. That is also an issue. That what
We are also mentioned that when after the second apnea test and then CO2 is rise more than 20 in that. Yeah.
Because this scenario is very common. We know as medical people that the time of second apnea test is the time of death, but we've had to backtrack and continue and accept circulatory death as well.
Can you hear me now?
Yeah, Dr. Rahul, we are hearing you with the
Thank you. Yeah, so I think these are some of the practical points. Dr. Shroff, are you there? If you can just throw some light on this as well. These are some of the problems which occur, and once in a while they can put an intensivist or a doctor in a difficult situation. Anybody else who would like to answer or add on to it, I'm happy.
Hey, Rahul, I think the concept of brain death is still new in this country. Whatever said, although we have a law for 25 years, we are still evolving. Our thought process is still evolving. And these kind of problems will happen. And, each state, goes through this. Some states have more and some states were starting with even more. But I think, we as clinicians, if we are on the right path, if we are doing things ethically, we shouldn't worry too much. And earlier also, there was a question about, how do we switch off ventilators and so on. And as Rahul said, that we need to build a trust with the family. It's very important. Communication has been said many times. Right from the time the patient is admitted in intensive care, if you have somebody to support the family, then they will have some trust on that person. The communication in intensive care is very poor in this country because they're very busy. So you need to establish this communication line. And if constantly you keep giving your feedback to the patient's relatives that, look, patient is very critical, we're not going to be able to do much. Now this is brain death. And then you sit down and explain about brain death, what brain death exactly is. Take a diagram and show them. Take some pictures and show them. So ये बहुत जरूरी है कि हम समझाते रहें उनको क्या है. Then when you come to actually when it happens, कि आपको switch off करना है ventilator and all that, क्योंकि the first stage of grief is anger, denial, and then only acceptance comes. And and all we go through these different stages of grief. The time taken for accepting, is sometimes short and sometimes very long. So you have to give families enough time to understand this. And building trust is very important in this program. Half the time we fail because there is no trust between the doctor and the patient relatives.
Absolutely. I think before even you talk about brain death or organ donation, several hours of communication has to go in. Several hours. I'm not talking one meeting or two meetings. We spend days together. And only then the trust builds up. And we like it to be so transparent. I've got only one last slide, which I would like, this video, which I would like to show. Look at this spinal reflex. Yeah, I'm done after this. And then even the patient like this, after a couple of days of talking, and the spinal reflex obviously disappeared by that time, the family consented for organ donation. So I think we need to be very, very, what I want to show is that we need to be very, very communicative with the family. It is communication, which helps, nothing else.
That's what matters.
Thank you very much.
Thank you.
Thank you, sir. I'm done.
Thanks a lot, sir. Thanks a lot for the very interactive session. And one more thing I would like to add, according to what the US guidelines say, the transplant team is totally separate, and the one treating the physician and brainstem certification team is totally separate. So that is very, very important. The transplant team comes into play when everything has been decided and patient has been declared brain dead, and the attenders have been counseled clearly. So this is a very, very important aspect.
Thank you.
Absolutely.
Thank you for the wonderful interaction. Thank you, Dr. Rahul, and all the panel members. Thank you so much.
Thank you.
Thank you.
So we move on to the next session. And to chair the session, I would like to call Dr. Rajiv Ranjan. He's the Nodal Officer, SOTO, Jharkhand. And to moderate the session, I would welcome Dr. Bhanu Kumar.
So good afternoon, everyone. Now the next session is about the management of brain dead donor and interactive discussion on 3 to 4 real life cases. And this one, no, no. Oh, okay. Second, this is Breaking Bad. The session is about breaking bad news and approaching the family for organ donation. And this is an interactive session. And we will discussing this two case scenario by this video presentation. This will be discussed by Mr. Jaspal Singh, which is the transplant coordinator here at IGMS Patna, and by Shishir Kumar and
Mr. Shishir, transplant coordinator at Big Apollo Spectra, and Mr. Sudhir Kumar, transplant coordinator at Paras HMRI Hospital.
So, the way we started the morning was with law. And then we talked about brain death. So we've structurally, kind of gone on from the law to declaring brain death. And now we need to speak to the family. So how do we break the bad news? We've had some discussion, ongoing discussion. So how do you break the barrier and speak to the family and tell them about organ donation in a time of extreme grief? Talking about organ donation when your loved one is dead is an extremely difficult subject. So this is a very important part of this whole exercise, this workshop. And some of you are transplant coordinators here who do this job. We have Dr. Bhanu Kumar from Mohan Foundation in Hyderabad. And he's a very senior coordinator. He must have done close to, I think, 300 to 400 donations now. Most of the donations which are happening in Telangana, in many, many donations, Bhanu is involved with Jivan Dan. He works for Jivan Dan. He's he's been working with Mohan Foundation for the last 20, almost 15 years now. So Bhanu is going to present, and then he's going to show you short videos, simulation videos on how to break bad news. At Mohan Foundation, one thing which we've done over the last 25 years now is we have built a lot of resources, educational resources, and that's why our training programs are so popular. But we have so much of resources, very excellent videos. We have created more than 60 video modules on different aspects of organ donation. And that's what works. So I'll invite Bhanu. Bhanu, are you there?
Yes, sir. I'm in, sir. I'm in.
Please, you're on. Thank you.
Yes, sir. I'm in.
And can you introduce you already introduced our panelists, right?
No, sir. After this video, I'll take over the session and I'll go with my presentation.
Thank you, Bhanu.
Thank you, sir. Thank you.
So Bhanu, you're going to do a presentation or a video first?
Video first, sir. Yeah, video is going to be played. Starting now.
So this video has been done on a storyline which we took from NHSBT on sound, please. A good approach and a bad approach. First the bad approach and then a good approach in organ donation. Please put the sound for the video.
पेशेंट की परिवार से अंगदान की बातचीत एक बहुत ही नाजुक विषय है और अगर इसकी प्लानिंग सही तरीके से नहीं हुई तो उचित परिणाम मिलना मुश्किल है। इस फिल्म का उद्देश्य यह दिखाना है कि पेशेंट के परिवार से सही तरीके से बातचीत कैसे होती है। इस बातचीत की प्रक्रिया को हम 3 अलग स्टेजेस में बांट सकते हैं। सबसे पहले परिवार से क्या चर्चा की जाएगी उसकी प्लानिंग करना। उसके बाद अंगदान पे किसी भी चर्चा से पहले यह बहुत ज़रूरी है कि पूरा समय देते हुए पेशेंट के परिवार को उनकी क्लिनिकल सिचुएशन के बारे में अच्छी तरह से समझाना। अंत में परिवार को किसी भी निर्णय पे पहुंचने से पहले उनको अंगदान की पूरी जानकारी दें। अब हम गलत और सही तरीकों के उदाहरण देखेंगे।
कम इन।
मैडम, बेड नंबर 5 के पेशेंट की फैमिली आपसे बात करना चाहते हैं। वो कई घंटों से वेट कर रहे हैं। क्या मैंने बुला लूं?
हाँ, अभी थोड़ी देर में बात करती हूँ। अच्छा, बुलाओ।
ओके मैम।
इस तरह जल्दबाजी और बिना प्लानिंग की अप्रोच से परिवार को एक सोचे समझे निर्णय लेने का मौका नहीं मिलता। इस उदाहरण में डॉक्टर और नर्स के बीच में ऐसी कोई बातचीत नहीं दिखी कि वो परिवार के साथ क्या बात करेंगे। उनके पास ऐसा कोई मीनिंगफुल प्रस्ताव नहीं था जो वे परिवार के सामने रख सकते थे। ट्रांसप्लांट कोऑर्डिनेटर या सोशल वर्कर मौजूद नहीं था। क्लिनिकल या पारिवारिक स्थिति पर कोई चर्चा नहीं की गई और ना ही कोई अंगदान की बात हुई।
मैडम, वो पेशेंट की फैमिली हमसे मिलना चाहते हैं। पेशेंट की कंडीशन के बारे में कुछ जानना चाहते हैं। क्या मैं उनको बुला लूँ?
हाँ, मैं उनसे अभी मिलती हूँ। ज्योति को तुम जानती होगी, हमारी ट्रांसप्लांट कोऑर्डिनेटर, जो पेशेंट से, फैमिली से ऑर्गन डोनेशन की बात करती है। तो ज़रा हम पहले डिस्कस कर लें कि हमने फैमिली से कैसे बात करनी है। तो फॉर आवर अंडरस्टैंडिंग, राजीव इज़ अ 44-year-old मेल जो 2 दिन पहले हमारे आईसीयू में सबअरेक्नोइड हेमरेज के बाद एडमिट हुआ है। उसके सारे टेस्ट हो चुके हैं और ये कंफर्म है कि वो ब्रेन स्टेम डेड है। जैसी, थोड़ा फैमिली के बारे में बताओ।
पिछले 2 दिनों से फैमिली आईसीयू के बाहर ही खड़ी है। उसकी वाइफ काफ़ी अपसेट है। उनके 2 बच्चे हैं, एक 12 साल का लड़का और एक 15 साल की लड़की। पेशेंट के पिताजी और उनके बड़े भाई यहीं पर हैं और पेशेंट की माँ बच्चे को लेकर घर गई हुई है। फैमिली काफ़ी परेशान है और अभी जानना चाहते हैं कि पेशेंट के साथ क्या हो रहा है।
ज्योति, तुमने पेशेंट के नोट्स पढ़ लिए होंगे। पेशेंट ऑर्गन डोनेशन के लिए सूटेबल है और अब हम उनकी फैमिली से बात कर सकते हैं। हमें ये सोचना होगा कि उनसे बात कैसे की जाए। मुझे लगता है कि हमें कुछ समय बिताना होगा उनको ये समझाने के लिए कि हमने सारे टेस्ट कर लिए हैं, उन टेस्ट का मतलब क्या है और वाकई में राजीव मर चुका है। जब मैं फैमिली से बात कर रही होंगी, अगर तुम्हें लगा कि कुछ मिस हो रहा है तो तुम ऐड कर सकती हो। हम दोनों एक साथ ये समझ पाएंगे कि उन्होंने पेशेंट की डेथ को एक्सेप्ट कर लिया है कि नहीं और उस हिसाब से हम लोग आगे बढ़ेंगे। अगर मुझे लगता है कि उन्होंने सब कुछ ठीक ठाक एक्सेप्ट कर लिया है, दे अंडरस्टैंड एवरीथिंग, तो मैं ऑर्गन डोनेशन की बात को शुरू करूँगी और तुम फिर उसको आगे ले चलना।
और अगर मुझे लगा कि फैमिली काफ़ी परेशान लग रही है और शायद पेशेंट की कंडीशन को ठीक से नहीं समझ पा रही है, तो क्या ये ठीक रहेगा कि हम उस समय एक ब्रेक ले लें और फैमिली से थोड़ी समय के बाद बातचीत करें?
हाँ, मुझे लगता है यही सही रहेगा।
एंड डिपेंडिंग अपॉन द सिचुएशन एट दैट टाइम हम डिसाइड कर सकते हैं कि ऑर्गन डोनेशन की बात उठाएं या नहीं।
मैम, मुझे लगता है कि फैमिली को अभी ब्रेन स्टेम डेथ के बारे में समझने में थोड़ी मुश्किल होगी।
आइए हम इस गुड प्रैक्टिस के कुछ महत्वपूर्ण पहलुओं के बारे में बात करें। जैसे कि हमने इस उदाहरण में देखा, कौन कौन मौजूद था। ये पूरी प्रक्रिया ट्रीटिंग डॉक्टर के नेतृत्व में होनी चाहिए और शुरू से ही नर्स और ट्रांसप्लांट कोऑर्डिनेटर इस चर्चा में शामिल होने चाहिए। इस तरह की प्लानिंग का मेन उद्देश्य क्या है? ये प्रक्रिया एक टीम वर्क है और हमारे बीच ये स्पष्ट हो कि हम फैमिली से कैसे चर्चा करेंगे। बातचीत के प्रमुख तत्वों को कौन किस समय उठाएगा और परिवार और पेशेंट से संबंधित मुद्दों के लिए कौन रिस्पॉन्सिबल होगा। इस उदाहरण के की एलिमेंट्स क्या हैं? डॉक्टर द्वारा क्लिनिकल स्थिति का स्पष्टीकरण करना, नर्स का परिवार के बारे में बताना, ट्रांसप्लांट कोऑर्डिनेटर का ये स्पष्ट करना कि अंगदान की बातचीत कैसे की जाए, परिवार के साथ अंगदान पर चर्चा करने से पहले उन्हें ब्रेन स्टेम डेथ की अच्छी समझ देना।
हाँ नमस्ते, बैठिए बैठिए। नमस्ते मिस्टर अरोरा, राहुल, मिसेस अरोरा। मुझे आने में थोड़ी देर हो गई, आई एम सॉरी। मुझे पता है आप काफ़ी समय से मेरा इंतज़ार कर रहे हैं। एनीवे, नर्स जैसी को तो आप जानते ही हैं, ये ज्योति हैं। तो जैसे मैंने सुबह आपसे बात की थी कि हम राजीव पे कुछ टेस्ट करेंगे उनका बचा कुचा ब्रेन फंक्शन को असेस करने के लिए, तो वो जांच हो गए हैं और मैंने उनके परिणाम देख लिए हैं, मैंने डिस्कस कर लिए हैं अपने सीनियर से, अपने कोलीग से, और मुझे आपसे कहना है कि उनके ब्रेन ने काम करना बंद कर दिया है। आई एम वेरी सॉरी।
ब्रेन ने काम करना बंद कर दिया? ये आप क्या कह रही हैं डॉक्टर साहब? मुझे तो कुछ समझ में नहीं आ रहा।
इसका मतलब है वो ब्रेन डेड है।
मुझे तो विश्वास ही नहीं हो रहा।
एक मिनट रुको बेटा, मुझे नहीं लगता कि वो किसी भी दर्द में है। ऐसा लगता है कि जैसे वो अभी सो रहा है।
You're right, पापा। यहाँ तक कि नर्स ने कहा सब कुछ ठीक है, और अब आप हमें कह रहे हैं कि वो नहीं रहा। और इस ब्रेन डेड से आपका क्या मतलब है?
मुझे पता है ये समझना मुश्किल है। राजीव का दिल धड़क रहा है, वो वेंटिलेटर पे है, पर कानूनी तौर से वो ब्रेन डेड हैं और वो बच नहीं सकता है।
मैं इसके बारे में कुछ नहीं जानता और मुझे कुछ समझ में नहीं आ रहा।
इस सिचुएशन में मुझे एक बात और आपसे करनी पड़ेगी। हमारे हॉस्पिटल की पॉलिसी है कि ब्रेन डेड पेशेंट की स्थिति में हम फैमिली से अंगदान की बात उठाएं।
अंगदान?
मैं अब वो नहीं सुन सकता। बस बहुत हुआ।
इस उदाहरण में आपको क्या गलतियां होती हुई दिखाई दी? क्या आप अपने स्वयं के एक्सपीरियंस से इनमें से किसी भी गलती को पहचानते हैं? सबसे पहले रूम की सेटिंग पर ध्यान नहीं दिया गया। चेयर कम है और दरवाज़ा खुला हुआ है। ट्रांसप्लांट कोऑर्डिनेटर को नाम से इंट्रोड्यूस तो किया, पर एक नए व्यक्ति के वहाँ उपस्थित होने के कारण को फैमिली को एक्सप्लेन नहीं किया गया। डॉक्टर परिवार की अभी की स्थिति को समझाने में असफल रहती हैं और ब्रेन स्टेम डेथ के टेस्ट के रिजल्ट्स में सीधा आ जाती हैं, लेकिन जल्दबाजी में और एक गलत तरीके से ऐसा करती हैं। इससे परिवार के दिमाग में संदेह पैदा हो जाते हैं। ये ज़रूरी है कि डॉक्टर सही शब्दों का इस्तेमाल करें, जैसे कि राजीव मर चुका है या राजीव की मृत्यु हो गई है। ब्रेन डेड या कानूनी रूप से मृत आदि शब्द सही स्थिति को नहीं दर्शाते और फैमिली को और कंफ्यूज करते हैं। अंगदान की बात बहुत ही जल्दी उठाई गई, इससे कहीं पहले कि परिवार पूरी तरह से समझ पाएँ कि उनके रिश्तेदार की मृत्यु हो गई है। इस वजह से फैमिली काफ़ी शॉक्ड दिखाई देती हैं और नेगेटिवली रिस्पॉन्ड करती हैं। आखिरकार अंगदान ही बहुत जल्दी नहीं उठाया गया, लेकिन ऐसा करने में डॉक्टर ने नकारात्मक और एपोलॉजेटिक भाषा का प्रयोग किया। तो आइए देखते हैं हम इसे कैसे बेहतर कर सकते हैं।
नमस्ते मिसेस अरोड़ा, राहुल, मिस्टर अरोड़ा। आप सब मुझे जानते हैं, जैसी से भी मिले हुए हैं। मैं आपको ज्योति से मिलवाना चाहती हूँ।
हेलो मिसेस अरोड़ा। हेलो।
ज्योति हमारे डिपार्टमेंट में काम करती हैं और ऐसे समय में परिवारों की सहायता करती हैं। सुबह मैंने आपसे कहा था कि हम कुछ टेस्ट करेंगे, वो हो चुके हैं। मैं ये जानना चाहती हूँ कि अभी तक की स्थिति को आप कितना समझते हैं। मुझे पता है कि आपने कई लोगों से डिस्कशन की हुई है।
मुझे पता है डॉक्टर कि राजीव के ब्रेन में बहुत ब्लीडिंग हुई है और अब कुछ टेस्ट भी करने जा रहे थे ये देखने के लिए कि उसका दिमाग अभी भी काम कर रहा है या नहीं। क्या ये सही है?
हाँ, ये बिल्कुल सही है।
तो क्या हो रहा है डॉक्टर? टेस्ट कैसे हुए? वो ठीक तो हो जाएगा ना?
तो मैं आपको इन टेस्ट के बारे में थोड़ा बताती हूँ। असल में इसका मतलब क्या है। दरअसल हमने बहुत ध्यान से राजीव के दिमाग की हरकतों की जांच की है, लेकिन अनफॉर्चुनेटली हमें कोई भी प्रतिक्रिया नहीं मिल रही है उनकी तरफ से। यहाँ तक कि गहरी स्टिमुलस देने पर भी नहीं। हमने 10 मिनट के लिए वेंटिलेटर को डिस्कनेक्ट किया, लेकिन इस दौरान उन्होंने सांस लेने का बिल्कुल भी प्रयास नहीं किया। आखिर में हमें ये पता चलता है कि उनके ब्रेन के फंक्शंस हमेशा के लिए चले गए हैं। वो कभी सांस नहीं लेंगे, वो कभी कॉन्शियस नहीं होंगे। मुझे बहुत दुख है, लेकिन राजीव की मृत्यु हो चुकी है। ही हैज़ डाइड।
उनकी मृत्यु हो गई है? मैं इस बात पे विश्वास नहीं करती।
मुझे समझ में नहीं आ रहा, इसका कोई मतलब नहीं बनता।
सही कहा पापा, यहां तक कि नर्स ने कहा सब कुछ ठीक लग रहा है, और अब आप हमें कह रहे हैं वो नहीं रहे, वो मर गए।
आई एम सो सॉरी, राजीव मर चुके हैं। देयर इज़ नो ब्रेन फंक्शन। इस स्थिति को पलटाया नहीं जा सकता। वो कभी वापस नहीं आएंगे।
ये आप क्या कह रही हैं डॉक्टर साहब? उन्हें कभी होश नहीं आएगा और आप कुछ भी नहीं कर सकती।
कुछ तो तरीका होगा आपके पास, आप कुछ तो कर सकते हैं। उसको आप ऐसे नहीं छोड़ सकते।
देखिए, हम जानते हैं कि जब दिमाग में खून का बहाव नहीं होता है, इवन फॉर अ फ्यू मिनट्स, तो इंसान बहुत जल्दी मर जाता है। ऐसे में राजीव के दिमाग में भी खून का बहाव नहीं है, और वो भी कुछ घंटों से। उनका दिमाग मर चुका है, राजीव मर चुके हैं। वो सिर्फ वेंटिलेटर से कनेक्टेड हैं, और इसीलिए समझना और मानना बहुत मुश्किल है, क्योंकि उनका शरीर अभी भी गर्म है, उनका दिल धड़क रहा है। बट इट इज़ वेरी क्लियर कि राजीव मर चुके हैं।
ये क्या कह रहे हैं डॉक्टर साहब? मैं ये नहीं मान सकता कि आप कुछ नहीं कर सकते।
हे भगवान, मैं बच्चों को क्या बोलूँगी?
मुझे समझ आ रहा है कि ये सभी के लिए बहुत ही मुश्किल है, और मुझे लगता है कि आप सबको आपस में कुछ समय साथ बिताना चाहिए, और हम कुछ समय बाद फिर मिलते हैं।
परिवार के सभी सदस्यों को डॉक्टर शुरू में ही सबका परिचय देती हैं। ट्रांसप्लांट कोऑर्डिनेटर को एक फैमिली काउंसलर के रूप में इंट्रोड्यूस किया जाता है, जो टीम के साथ काम करती हैं। फैमिली को इस समय उसके असली रोल के बारे में ना बताना उनको धोखा देना नहीं है, परंतु ये स्वीकार करना है कि फैमिली अभी तक अंगदान की बात करने के लिए तैयार नहीं है। उसकी ये भूमिका तब स्पष्ट की जाएगी जब फैमिली को ये समझ आ जाएगा कि उनके प्रियजन की मृत्यु हो गई है और वे अंगदान के बारे में जानकारी लेने के लिए तैयार हैं। डॉक्टर परिवार की वर्तमान स्थिति की समझ का असेसमेंट करती हैं और उसके आधार पर ब्रेन स्टेम डेथ की बातचीत शुरू करती हैं। उनकी बातचीत में कोई जल्दबाजी नहीं है और वो सरल और स्पष्ट भाषा का प्रयोग करती हैं। ऐसा करते हुए वे सुनिश्चित करती हैं कि परिवार को भरोसा हो गया है कि अब उनके प्रियजन ना ही ब्रेन डैमेज्ड है और ना ही कोमा में है, पर उनकी मृत्यु हो चुकी है। और अंगदान की बात तब तक नहीं होनी चाहिए जब तक परिवार को पूरी तरह से इस बात का भरोसा नहीं हो जाए। हमारे उदाहरण में हालांकि हमें लगता है कि मृतक की पत्नी ये समझ चुकी है, पर परिवार के दूसरे सदस्यों में इस बात की पूरी समझ और स्वीकृति नहीं है। ट्रांसप्लांट कोऑर्डिनेटर इस सिचुएशन को समझती हैं और ये सुझाव देती हैं कि परिवार के साथ और समय बिताया जाए ताकि उन्हें अपने प्रियजन की स्थिति को समझने और स्वीकार करने के लिए और समय मिले। इस उदाहरण में अंगदान की चर्चा शुरुआत में नहीं की जाएगी। कुछ परिवार इस स्थिति को ज़्यादा आसानी से समझ लेते हैं और उनके साथ अंगदान की बातचीत एक स्वाभाविक रूप से उठाई जा सकती है। सबसे ज़रूरी बात यह है कि जब तक परिवार स्थिति को समझ ना लें और अपने प्रियजन की मृत्यु को स्वीकार ना कर लें, तब तक अंगदान की बातचीत शुरू नहीं की जानी चाहिए।
और डॉक्टर हम सब काफ़ी देर से बातचीत कर रहे हैं, और मिसेस अरोड़ा, राहुल और उनके पापा अब आपके द्वारा किए हुए जो टेस्ट थे उनको काफ़ी अच्छी तरीके से समझ गए हैं, और ये भी समझ गए हैं कि अब राजीव नहीं रहे।
आई एम सो सॉरी। मैं समझती हूँ कि ये आपकी फैमिली के लिए बहुत ही मुश्किल समय है, स्पेशली इन अ सिचुएशन जहाँ राजीव का दिल धड़क रहा है पर वास्तव में उसकी डेथ हो चुकी है। ये एक्सेप्ट करना बहुत ही मुश्किल है, पर मुझे विश्वास है कि आप लोगों को पूरा एहसास है कि राजीव की मृत्यु हो चुकी है। अब आगे क्या करना है, हमें इस पर विचार करना होगा। मैं आपसे कुछ बात करना चाहती हूँ, शायद आप एक्सपेक्ट नहीं कर रहे होंगे, और वो है अंगदान। ज्योति इसके बारे में आपको और जानकारी देंगी।
अंगदान? बस बहुत हो गया।
हम जानते हैं और हम समझते हैं कि आप सब एक बहुत ही मुश्किल समय से गुजर रहे हैं, पर आपको ये याद रखना है कि राजीव अब कुछ भी महसूस नहीं कर सकते। वो कोई दर्द महसूस नहीं कर सकते क्योंकि अब उनकी मृत्यु हो चुकी है।
नहीं, मुझे लगता है हम सब वैसे ही बहुत मुश्किल दौर से गुजर रहे हैं।
मैं समझ सकती हूँ राहुल, एंड आई एम रियली वेरी सॉरी, पर राजीव एक ऐसी स्थिति में है जहाँ वो कई लोगों की जानें बचा सकते हैं और कई परिवारों की ज़िंदगियाँ बदल सकते हैं। मैं आप लोगों को कुछ जानकारी देना चाहती हूँ और आपकी मदद करना चाहती हूँ एक ऐसा डिसीजन लेने के लिए जो आप सबके लिए सही है।
हमने देखा कि ट्रांसप्लांट कोऑर्डिनेटर फैमिली के साथ कुछ समय बिता चुकी है, जहां वो फैमिली को पेशेंट की स्थिति के बारे में समझाती है। डॉक्टर परिवार से एक बार फिर बात करती हैं और जब पूरी तरह से संतुष्ट होती हैं तब अंगदान का टॉपिक उठाती हैं और बहुत ही स्वाभाविक रूप से ट्रांसप्लांट कोऑर्डिनेटर को डिस्कशन में इन्वॉल्व करती हैं। ट्रांसप्लांट कोऑर्डिनेटर पेशेंट के पिता के नेगेटिव रिएक्शन के साथ बहुत ही संवेदनशीलता से पेश आती हुई दिखाई देती हैं। वो एक पॉजिटिव भाषा में अंगदान की चर्चा करती हैं। ऐसा करने की अच्छाई पर सोचने के लिए फैमिली को प्रेरित करती हैं। वो ये बताती हैं कि उसका रोल इन्फॉर्मेशन देना है और डिसीजन लेने के लिए परिवार की सहायता करना है। ट्रांसप्लांट कोऑर्डिनेटर्स को परिवारों की इच्छाओं का पता लगाने के लिए ओपन क्वेश्चंस के प्रयोग की स्पेशल ट्रेनिंग दी जाती है। इस तरह की फैमिलीज़ के ग्रीफ को समझने और हैंडल करने की भी ट्रेनिंग मिलती है। ऐसा देखा गया है कि कई परिवार शुरुआत में ही मना कर देते हैं। एक ट्रेन ट्रांसप्लांट कोऑर्डिनेटर इस सिचुएशन को भी संवेदनशीलता और धीरज से हैंडल करती हैं। महत्वपूर्ण बात यह है कि ऐसे मामलों में जहां पेशेंट की इच्छा नहीं पता होती है, कानून करीबी रिश्तेदारों को निर्णय लेने की जिम्मेदारी सौंपता है और ऐसे ही परिवारों को इस तरह के समर्थन और जानकारी की ज़रूरत है। जो अप्रोच हमने देखी उससे दो उद्देश्य पूरे होते हैं। सबसे पहले ये अप्रोच परिवार को एक ऐसे समय समर्थन और देखभाल प्रदान करता है जो कि शायद उनके जीवन का सबसे कठिन समय है। दूसरा, इस अप्रोच में फैमिली को पर्याप्त समय दिया जा रहा है, पूरी जानकारी दी जा रही है और इस बात की पुष्टि की जा रही है कि फैमिली ने सिचुएशन को पूरी तरह से एक्सेप्ट कर लिया है। ऐसा करने से हम अंगदान की स्वीकृति के चांसेस को बढ़ा रहे हैं। शुरुआत से ही ट्रांसप्लांट कोऑर्डिनेटर की भागीदारी प्रस्ताव विधि के सभी स्टेप्स में होना काफ़ी लाभदायक साबित होता है। इन कार्यों के लिए उनकी ट्रेनिंग और परिवारों के साथ उनका रोज़ाना संपर्क उनका कौशल और अनुभव बढ़ाता है, जो कि डॉक्टर से कहीं ज़्यादा है, क्योंकि डॉक्टर बहुत कम परिवारों को रिक्वेस्ट करने में शामिल होते हैं। अंगदान के लिए हमारे परिवारों के इनकार के करंट हाई रेट्स में सुधार लाना यकीनन ही सबसे बड़ा योगदान होगा, जो भारत में ट्रांसप्लांट की संख्या को और बढ़ाएगा। ऐसा करने से कम लोगों की ट्रांसप्लांट की प्रतीक्षा में मृत्यु होगी या ट्रांसप्लांट वेटिंग लिस्ट में प्रतिबंधित या सीमित जीवन व्यतीत करना पड़ेगा। हमें यकीन है कि आप इस बात से सहमत होंगे कि ये ऐसा लक्ष्य है जिसके लिए प्रयास करना महत्वपूर्ण ही नहीं, सार्थक है।
Yeah. Bhanu, you're on. Bhanu?
Oh, yes, sir. I'm sharing my screen, sir.
Why are you appearing so dark?
I'm having so down, sir. 1 minute, sir.
And it seems like you're traveling in a train or what? Or bus?
No, sir. No, sir. I'm sitting in a car, sir. So
No wonder.
maybe that may be the reason.
You're doing it from your mobile, is it?
No, sir. A laptop. I'm using my laptop.
This is what happens after COVID. Eh? We all seem to be everywhere. Bhanu, you're not able to share your screen?
Yes, sir. Little difficulty.
If you don't need, I don't think that you need to see your slides. You can just talk if you want otherwise.
Let me try once.
Let's not waste time because we only have about 15 minutes and then there are 4 of our coordinators who'd like to say something.
Okay, no issue, sir. I'll go with my talk. Yeah, very good afternoon, all. I'm Dr. Banachandra, Senior Transplant Coordinator from Telangana. As our head Dr. Shroff said, I'm associated with Mohan Foundation from past 12 years. And here, in fact, the whole video what I have screened for you is it have A to Z information about breaking the bad news, and also it much involved about organ donation counseling. But here I want to mainly talk about how we can break the bad news before approaching the family members for organ donation. But I am not talking much about organ donation counseling in this session. I'm concentrating on breaking the bad news, especially to the family members when their beloved person is no more. So, who should break the bad news? This is very important. Not a security guard, not a any other staff from the hospital. The first and utmost important role is treating doctor, because treating doctor have all the concern about his patient, and if he breaks the bad news, then it will be good, and the communication between the family members and treating doctor will be very well than any other employee in the hospital. And the second place is for the transplant coordinator. Maintain a rapport with the
It's.
and also and
Bhanu, your connectivity is very poor. Yeah, I know. Bhanu, your connectivity is very poor. If you're not able to connect, we have 4 coordinators here. They will take over. Do you want to take over?
Yes, sir. It is clear for me, and I have only 3 more slides
You
to
have to be in
discuss.
one place. You can't be traveling the car and doing this presentation.
No, sir. Is it okay, sir?
No, we can't. You are breaking. And there's 100 people in this audience. You know, we can't wait for you.
Okay. Then the next speaker can take over the session, sir.
Take over here, yeah.
Sure, sir. Please go ahead.
So you've seen, you know, the key elements of breaking bad news is planning the whole procedure with the doctors, with the coordinators. I think that is the essence of this whole discussion, that you can't just do it ad hoc, randomly. One thing is, right from word go, you have to be associated with the family and you should know the family. So the person who is going to do counseling should know the family right from words when their patient gets admitted in the ICU. That's the key. And then you need to build rapport with the family. उनको समझाना हर every half an hour, 1 घंटे में उनको कुछ ना कुछ आपको बताना पड़ेगा कि अभी ये हो रहा है, अभी ये हो रहा है एंड सो ऑन, अभी ये ब्लड प्रेशर है, ब्लड प्रेशर फॉल हो रहा है, हम दवाई दे रहे हैं, अब रेस्पिरेशन थोड़ा सा गड़बड़ा गया है। एंड कभी कभी एक आदमी को नहीं, बहुत सारी फैमिली मेंबर्स होते हैं, सबको एक साथ रख के आपको आगे चलना है। यस, प्रेजेंटेशन है क्या आपका?
सर, आई विल
हाँ,
जस्ट ब्रीफ इट आउट।
श्योर। So Jaspal is from IGMS, and he wants to do a short presentation for 2 minutes. Very important to understand stages of grief. When you have grief, what are the different stages we go through in our mind? So first is denial, कि नहीं ये हो नहीं सकता है, and उसके बाद the stage is anger, कि मेरे साथ क्यों हुआ ये. And grief and जो होता है ना, denial and anger is a very very difficult stage. And उस stage में अगर हम बात करते हैं फैमिली के साथ तो हमेशा आपको नो ही मिलेगा, और उसके बाद ही एक्सेप्टेंस होता है जिसमें वो बार्गेन करता है आपके साथ. तो ये 3 स्टेज समझना बहुत जरूरी है when you speak to someone. Yeah, sorry, Jaspal.
Basically, I mean, like whenever there is for this topic, I want to just divide into 2 parts: breaking the bad news and approaching for the organ donation. So basically, breaking bad news, it has some responses, and there are some phases which we face while giving the bad news to the attendants or the family members who all are present during that period. So in that one, there are some, I mean, like theories given by some different authors, some researchers, like Kubler, and Kubler was the researcher, so she gave her theory, and in her theory, she gave like there are some 4 or 5 phases which comes in the family members who all, I mean, like receive the bad news. Like initially they deny the news, that they don't want to accept, and later on they come up with the and they may show the symptoms, they are angry, they may start bargaining, after that they may go into a depression, and finally they may accept and they may not accept. But most of the cases, I mean, like as per the research says, like they may accept, that we have to pick whether they have accepted it or not. There are some other theories also, like Parker also stated the same thing. In that also he said, like the process itself says that initially they are in some kind of shock when they receive the news, and later on they come in depression, and finally they accept the news that okay, I'm going to donate. Even in my situation, like when I was when I was trying to convince the families of the brain-dead patient. At that time also, I found that these DABDA principles, that that is very much applicable, and it has a very positive result. So in my institution, there were 22 brain-dead patients for which I tried to approach and get the donation. Out of that, 20 times I was not successful, but 2 times I was successful. And the first case, when I approached the family for organ donation, at that time, what I found, like there was a specially able boy who had a fall from the 2nd floor when he was when he ran to receive his father, who came back from the work in the evening, and he had some severe head injuries, and he was admitted in some different hospital in Patna. And through some local network, I should not say local network, because I got this news from a doctor from our hospital only. He told me that there is a patient who is not responding to the treatment, and he is having a very poor GCS. So you should go and try there. At that hospital, when I reached there, and I requested them, I mean, like in the same process, in the same way what we have been taught during the transplant coordination training workshops, and what I found, like when I approached, the patient's mother and father, they were aware of organ donation, and they wanted to donate the organ. So it was not that like every time we should approach the families with negative thing that they may not agree for organ donation and all. What happened exactly is like the mother of the disease, she agreed. She said like, I want my son's organ to be alive in someone's body, so I want to donate the organ, and please do whatever formality is required, do it immediately so that this transplant can take, and this can happen immediately. All the protocols were done. We took permission from Roto, and the organs were allocated. The heart was allocated to Calcutta, and the liver was allocated to Delhi. Then the same thing, FM protocols were done. We did. We gave appreciation letter to the family members and handed over the body. Records we maintained, and this was the first scenario we did. The second thing, just before 3 days before the lockdown in 2020. I came to know about a family where there were some 11 members in the family. Out of the 10 members died on the spot in a road traffic accident, and one only boy left was admitted in IGIMS. And suddenly I got a call from Dr. Sanjeev sir, who is also here present here. He told me that there is a boy, and he is a potential. I should not say potential. He said like he is not responding properly to the treatment, and you should approach the family. I stayed with that family for 3 days in the hospital, and finally, after 3 days, the family gave consent for organ donation from that boy. On 18th of March 2020, that organ retrieval took place, and we did this first liver transplant in IGMS on that same day. The heart was again allocated to Calcutta with the permission from Roto East, and the other, protocols were also done. In this case also, what I have seen, that if you approach the family with the proper methodology, that methodology means when you are you are approaching the patient party to get organ donation, you must follow the protocols. You should not go directly say that I want your organ and all. It's not going to work. What we have to do, we have to go through the methods, what methods has been given in the theories which has been researched and proved. So these are the two cases what we have seen here, and we are trying to do some more. Organ donations from here with the help of our hospital and Roto East. Thank you, madam. Thank you for your help always, ma'am.
Thank you, Jasbar, for such a nice presentation. And one thing which is, I think should be there should be some structured protocol for that. SOP that we call it. So who should approach the family after the first apnea test, then when the transplant coordinator to be involved, and how to approach further. There should be a structured SOP, though it is an emotional one, but we should be the one who should be the one consolidated, structured. So there should be that. That's all. Thank you.
And when they will break the news, proceed further. That is that.
So I think, you guys are doing a tremendous job. I know Jaspal said ki 22 donations you have pros and you got yes in 2. It's not bad. 1 in 10, अच्छा है. It'll become 2, it'll become 3. जैसे जैसे experience बढ़ेगा. शुरू में क्या कठिनाइयां आती हैं, And there are small things, the system needs to get better oiled, basically. Just as you said, कि take standard operating procedure बन जाएगा ना, कि हमको ऐसे करना है, then it will help. So I think, a big round of applause to all these 4 people, because they are the ones who work the maximum. They work the hardest. आप लोगों को क्या भूख लग रही है क्या? जरा जोर से ताली बजाइए भाई. Better, thank you. Well done, guys. Excellent.
Thank you, sir. Thank you all for the wonderful session. The next session is going to be moderated by Professor Sunil Shroff. That is the experience from Bihar and Jharkhand on brain death. And one more important announcement, that we would be having parallel lunch. So after 10 minutes, you can
no, not
proceed.
10 minutes, exactly 20 minutes. Give me 20 minutes.
20 minutes.
40 minutes में lunch खाएंगे हम लोग,
Okay,
ऊपर आ
sir.
जाएंगे.
Okay, sir. Okay, sir.
Nobody's going to go out
Okay,
from
sir.
here. So this is an open house, no slides for a change. And Dr. Arpita is here. Dr. Arpita, please come on stage, madam. And all the people involved with transplants in Jharkhand and in Bihar, please be in the front row. पीछे से नहीं, आगे आइए आप लोग. ये आप लोग का सेशन है 20 मिनट का. कहाँ गए वो कोऑर्डिनेटर्स जो अभी स्टेज पे थे? आप लोग सब आगे आइए. और डॉक्टर राजीव रंजन, आप कहाँ हैं? और मनीष मंडल तो नहीं है शायद. He is busy because he's got to take a flight. राजीव, where are you? यहाँ स्टेज पे आ जाइए. So Rajiv has come from Ranchi. He is in charge of the SOTO in Jharkhand. Arpita ji, you already know, she is our ROTO head, and she is in Calcutta. So you have done 2 donations. You have given some organs, liver, heart, kidney. ये सब किया आपने, which is remarkable. तो कारवां तो चालू हो गया है, अब उसको आगे बढ़ाना है. And organ donation should not be an unusual event. अभी तो unusual event है. This should be a usual event in a hospital, hopefully in the next 2-3 years. Yes, Dr. Arpita?
Come.
It should not be an unusual event. But it is an unusual event, everybody is confused. When it's an usual event, सबको मालूम है उसका क्या role है. And ये बड़ा complicated इसलिए होता है कि everybody has a role, right from the ambulance driver to the mortuary guy who is doing the postmortem, to the ward boy, to the top transplant surgeon, nurses. Everybody has a role. And एक आदमी वो अपना रोल ठीक से नहीं किया तो पूरा प्रोग्राम ठप हो जाता है. यही दिक्कत है इस प्रोग्राम में कि हम उसको कैसे कोऑर्डिनेट करें. And should run like a machine, one after the other. तभी जाके ये प्रोग्राम आगे बढ़ेगा. और हम ये चीज पटना में, रांची में कर सकते हैं जरूर से. एंड इतने अच्छे लोग हैं. हाँ हाँ, एकदम. So माइक टू डॉक्टर अर्पिता. हमको और भी अपॉर्चुनिटीज मिलेगी आफ्टरनून में डिस्कस करने की इसके बारे में कि कैसे हम इस प्रोग्राम को आगे बढ़ाएं हैं बिहार में. डॉक्टर अर्पिता, आपका क्या, व्हाट डू यू थिंक, व्हाट शुड वी डू?
One important thing that
ये आप ऑफ कर सकते हैं screen.
That Rajiv was asking, that whether there is a need for SOP. The thing that Professor Shroff has shown in counseling steps, that is final. We can make that SOP in Bihar. We have made that SOP in West Bengal too. But the SOP is required in changing this baton process, because in a hospital there are multiple work schedule going on simultaneously. So what we had done with the administrative people, with the nursing people attached to nephrology, urology department, and in the CCU too, we have given them that this part is yours. After that, the patient moves to CCU people do their lot. The transplant coordinator remains attached throughout the process, because they have their job is done only when the body is respectfully delivered to the family. And they have to check a lot of things, that the family is always in hurry, na? They want to go back. And in accident cases, in India, still the trauma victims are the highest donors. So there is always a MLC, forensic requirement. So if your hospital does not have an attachment with a forensic person, how we will do that? Whether the FSM person, faculty will be with the OT team That may be one form. In our hospital, he doesn't remain throughout the OT, but by the time the retrieval is complete, he comes in and he signs physically. Even in the dead of the night, the PM is done. So two persons, two Group D helping persons from the department has to join him or her. Now we are having a lady FSM professor over there. She comes in the dead of the night. I'm so thankful to her that she comes in the dead of the night, and always due to some reason the retrieval goes on to the later half of the day. सबका सब काम हो जाता है तो retrieval होता है. तो retrieval spills हाँ वो delayed होते होते जाते जाते वो 3 के पहले नहीं है और 10 के पहले किडनी घुसती नहीं है. तो इसीलिए it is done by the day by 3 p.m., 4 p.m., 4 a.m., 3 a.m., 4 a.m. of the night. So this happens. Absolutely a clear thing has to be there. By 6 a.m. when the body is delivered, the nurses and the बाकी लोग थोड़ा फुल का भी इंतजाम होता है कि उसको थोड़ा सा रिस्पेक्ट दिखा के जाते हैं. जो नया शुरू होता है उनके लिए ये सब बहुत जरूरी है. Because you have to give the impression that in the whole event, who is the hero? The donor and the donor family. Unless this thing is there in their mind, वो लोग आगे नहीं आएंगे.
Very true. Madam,
so ये आपको एक हॉस्पिटल का SOP बनाना है.
मैं एक चीज बोलना चाहूंगा यहाँ पे कि जैसे आंध्र प्रदेश में हैदराबाद में रिट्रीवल और पोस्टमार्टम, देखिए रोड ट्रैफिक एक्सीडेंट में इंटेंट टू डेथ, पोस्टमार्टम इज अबाउट डिफाइनिंग कि if intent to death में if something was done which was intentionally to cause death. Whereas in a road traffic accident where you have a CT scan and where there's a very clear-cut case of trauma, the intent was not something which was to commit some crime. So to only rule out that, only a postmortem becomes very essential. So in those cases, why can't a postmortem happen in operation theater itself, called the forensic person, and that is accepted in Hyderabad now. And we are trying to do that in many states. So I would request ki West Bengal and in Patna, if the postmortem can be done together, very easy, or do it in adjoining theater.
Yeah, we do it in adjoining theater.
So kya hai na ki you don't have to cut up the body twice. And that becomes very traumatic to the family ki ek baar donation kar diya, fir postmortem ke liye gaya, fir se body cut up hua. That's where everything goes wrong. Family gets really very upset कि हम तो donate भी कर दिए, उसके बाद भी आप postmortem कर रहे हैं, फिर खोल रहे हैं, and that delay जो होता है ना, उसके कारण lot of things go wrong. So my one request which I have to the government is
यही होता है
कि even in Patna for that matter, जब आप IGMS, PMCH कहीं भी करेंगे, तो you must get a forensic person to agree. Forensics play, there are very few forensic people because we are staff very short on forensics. So, and they are very busy. So you must request a forensic person कि भाई या तो जो हमने लिखा है वो accept कर लीजिए आप, या नहीं तो ऑपरेशन थिएटर में आके देख लीजिए, या हम दूसरा थिएटर दे देंगे, तो डिले नहीं होगा. क्योंकि 75% of your brain deaths are coming from trauma today in this country because of road traffic accident. तो ये define करना बहुत जरूरी है आपके SOP में to prevent delays in organ donation and to cause trauma.
Sessions with the police also.
Yes, I know.
Yeah,
that's very important.
This make them primed to do that without hassle. पहले जब होती थी तो हम लोग को प्रॉब्लम होता था पुलिस को समझाने में कि actually what we do want. Even the MLC no objection that they have to write, the inquest officer, they used to fumble in that because perhaps the accident had happened miles away, and from that Thana, from that police station, some information would reach this person where the referral hospital, tertiary hospital is situated. Now the things happen quite smoothly because we have done many sessions of organ donation.
Absolutely, with the police.
Things with the police in different, even in the highest, with the highest authority, as well as with the in police academy, that the police academy is situated in Barakpur close to Kolkata. Our team went there and
sensitized them. So
3 sessions with different batches.
I will tell you one more thing which may help you also in West Bengal and in Patna. We used to have this constant problem with the police in Chennai, in Tamil Nadu. And the reason we used to have the problem was, when we say that we are going to take out the organs, kidney, is a bad word. and they would straight away think ये जरूर कुछ stealing हो रहा है या कुछ हो रहा है. So constantly we used to have fight with the police. So what we did was we appointed a nodal officer in the police department. We requested the DIG of police. There is a DIG for welfare in police. You may not know this. For welfare of the police, there is a DIG. So we found out that in our advisory board in Tamil Nadu, we have a police DIG for welfare. And then we requested him. So when we had this problem, I went to the highest authority and I said, we are having this problem. What do we do? So he was a very bright police officer. He said, I'll appoint a nodal officer for organ donation from the police for the state of Tamil Nadu. And we got a nodal officer appointed for organ donation. So any problem, we pick up the phone, bring the nodal officer. Green corridor create करना है, sir, we have an organ donation happening. Nodal officer said, ठीक है, तुरंत काम हो जाता है. उसके बाद things have become much easier.
Point taken, sir. I will talk to police commissioner.
So talk to the highest and get a nodal officer for organ donation. So you have one-to-one contact. Otherwise, you don't know who to contact in the state. And when it comes to the highest authority, to the Thana, many times it so happens in our Andhra Pradesh is very close. Karnataka is very close. The accident will happen in Andhra Pradesh. Postmortem will happen in Chennai. Death has happened in Chennai. So interstate becomes even a big problem. But when it comes from the highest authority, suspicion is a lot less. So that is another suggestion I have. Another suggestion. And this police sensitization is very important. There's also a police training academy. So in fact, we do training academy mein police sensitization. And one more thing we have done. The whole organ donation procedure, we have made a flow chart. And in Tamil, we have put it in all police stations. कि ये organ donation होता है and ये contact करना है आपको. So everybody knows about it. So we have done over the years various these small things which has helped the process in medical legal case.
Offshoots भी बहुत है ना कि you have to call your HLA person in the middle of the night. Suppose that
HLA हम नहीं करते हैं मैडम, हम लोग खाली क्रॉस मैच करते हैं अभी.
अच्छा.
हम लोग कडावर में अभी HLA कर डाल नहीं.
HLA नहीं, T cell cross match तो होना होगा ना. तो वही HLA lab खुलेगा. तो T cell cross match होगा. तो you have to ask because if it is beyond 4, usually they do not stay in the department.
True.
4, 5, 6, they go away. So you have to call them again and you have to arrange some transport and all. So one administrative officer, sort of assistant super posting in IPGMER, he takes this responsibility of arranging everything for.
And then, you need to actually, to be honest, you should, in your SOP, you should write that if you come in the middle of night, you get paid. You can't expect free services always, believe me. And in government, there's a tendency everything should have it free. But I think is it now time to recognize that if you're doing a brain death certification in the middle of night, those services, I don't know what you feel about it.
Yeah, I am absolutely unanimous with you. And I'm trying to make my authority understand this issue, that at least give them some.
So Arpita ji, I'll tell you, what you need to do is you should say that in Maharashtra mein 5,000 rupees dete hain. Government gives. So that way what happens West Bengal वाले फिर convince हो जाएंगे कि government को दे सकते हैं. तो ये आप quote करिए example कि कर्नाटका में देते हैं, तमिलनाडु में नहीं देते हैं अभी तक, पर कर्नाटका में देते हैं, आपके महाराष्ट्र में देते हैं. तो you quote this example and then they'll get convinced, believe me. I also want to ask the coordinators, आपका postmortem किए थे क्या donation के बाद? उसमें problem हुई थी क्या आपको? हाँ. तो फैमिली का क्या रिएक्शन था जब पोस्टमार्टम के लिए बोला गया? माइक ले लो, माइक बस.
सर, जब पहली बार पहले केस में जब पोस्टमार्टम के लिए हम बॉडी लेके गए, तो द फादर हु वाज वेरी स्ट्रांग ऑफ दैट गाय एंड द मदर, शी वाज द विलिंग डोनर. आई मीन शी वांटेड टू donate her son's organ. एंड जब मैं हम पोस्टमार्टम लेके गए एंड इट वाज अ डिले. Around 1 hour, the father broke up, sir, and he started crying. He started crying like anything.
Crying.
What do you want to do me now?
See, this is a distraught of the family. Donation कर दिया, उसके बाद आप पोस्टमार्टम के लिए उसको बुला रहे हैं, डिले हो रहा है. एंड हमारे यहाँ ये भी होता है कि शनिवार को हमको नहीं चाहिए बॉडी भाई, हमको फ्राइडे ही चाहिए. अगर आपका ब्रेन डेथ सैटरडे डिक्लेयर हुआ है तो बाई फ्राइडे हमको बॉडी दे दीजिए, हम शनिवार को क्रियाक्रम नहीं करेंगे, हम मंगलवार को नहीं करेंगे. ये भी हमारे बहुत सारे इसमें प्रॉब्लम है. These kind of encounters you'll have. In fact, we have had situations where they say कि अगर आप सब चीज खत्म कर देते हैं, आज शुक्रवार है, तो हम आपका ऑर्गन डोनेशन ले लीजिए, कल आप लोग करते हैं तो हम नहीं करेंगे. हाँ में हाँ मिला के उसको आपको डिलीवर करना है। ऐसा नहीं कि फिर आप शनिवार को दे दें, फिर नहीं तो आपको पिटाई होगी। Anyway,
See, one scenario I have seen that if you just like you are telling that if you plan for the postmortem in the OT, in this situation you can do more and more donation. Recently, we last donation, the patient attendant has just their only demand is that we don't want postmortem and so like delays.
इसलिए मैंने ये कहा।
So if you in that time if you permit that during the after the
so you agree with her, right?
Yeah.
So yeah. So इसमें क्या है ना, उसने मैं बोला ना, there are multiple stakeholders in this program and सब stakeholder का रोल है। अगर आपका forensic आपसे नाराज है तो had it, कुछ नहीं होगा।
That is the policy decision because they have the fixed mindset that we have to take body and that
और वो हम सांझ को ना सूर्यास्त के बाद हम नहीं करेंगे पोस्टमार्टम, इतनी लाइट होने के बाद भी।
So it should be taken a higher level decision.
Absolutely. तो ये
exceptional situation where postmortem occurs after sunset. Usually postmortem is not done.
You know, this is British days में जब लाइट नहीं थी तो बोलते थे सनसेट के बाद पोस्टमार्टम नहीं होना। हम तो ब्रिटिश को फॉलो कर रहे हैं बेवकूफी जैसे, लॉ को चेंज नहीं करना है हमको। You know, so now of course things are changing. Many hospitals will do postmortem.
And one thing is also required that if patient is agreed for the donation, I think all fees should be just.
So that is a very important point you brought up.
Because already patient has exhausted, we cannot give financial support, but at least we.
Okay, fine. Okay. Sorry, finish कर दीजिए।
So if you just give support, like if whatever you expenses on this patient, that can be that could be just refunded. Right. So it will be a great.
So
help
when you
for
come
the,
to money after declaration of brain death, money is waived off, not before declaration of brain death. So there should be no organ commerce. We only have 5 minutes left, so I will give the opportunity first to Rajiv and then to Dr. Vaidya to talk about. Rajiv from Ranchi, Jharkhand.
Sir, the fee, what is getting wiped off?
Huh?
The fee.
Yes. After the brain death is declared, you waive off all the fees for donor maintenance.
Is it be possible the person who has been declared brain dead,
yes,
his whole like bill can be
whole bill cannot be waived off as per the law. It can after the only brain death, and that money of maintenance of brain death can be passed on to different hospitals which are taking organs. Rajiv.
Thank you, sir. I think I would like to add this, the issue of MLC or the forensic. I think this should be an administrative decision where the institution is involved. The institution should take up this matter. The administration should take up this matter, and they should ask this forensic to do that forensic examination in the operation theater itself.
तो आप जब रांची में चालू करोगे प्रोग्राम तो शुरू से ही ऐसे ही रखना।
जी
बहुत जरूरी है।
सेकेंड थिंग जो आपने बोला ये वाली चीजें ऐड करनी है कि सर जो हम लोग बोलते हैं एक्चुअली दिस पार्ट इज वेरी लेस, नॉन वर्बल कम्युनिकेशन इज द बिगर पार्ट, सो वी शुड पुट some in these places where we are expecting the potential donor, like in the portion of neurosurgery or neurology, or in case of this trauma center that we have, we should put these pictures, or we should like if we have this LCD screen or LED screen, we should have this organ donation portion in there, so they are subconsciously they are being sensitized to that.
Definitely.
So that
तो बहुत सी चीजें छोटी-छोटी कर सकते हैं हम लोग।
Yes, non-verbal part is there, na sir. So that will be easier for us, for the transplant coordinator everywhere.
Sure, absolutely. There is Dr. Vaidya from Ranchi. I wish he was here physically, but virtually he is there. So Dr. Vaidya, please, your comments.
Yeah, good afternoon, sir. So Tamil Nadu and Kerala, both of you are team leader in deceased donor or transplantation program. And we have not yet started any transplant program in our state. But I would like to say that you people are doing a lot of work, especially one foundation is doing a lot of work in Tamil Nadu. But we need to educate the society. That is very important. Education, encouragement, motivation to the young people. That is very important part. And this should be included in high school course. In the high school, this should be taught to the people that organ donation is a novel kind of thing, and one should be prepared for that. And donor card should be available with the patient in their wallet. That is another important aspect that should be done. Thank you.
Thank you. Yes, Taji.
Dr. Bhatia, whatever you do, you cannot educate the society
En masse.
completely en masse and and what your society is, Tamil Nadu 10 years back had the same society. So if Tamil Nadu could be leader, not that Jharkhand cannot be the leader.
Absolutely.
So what is
I was born in
required
Jharkhand, in fact.
is to keep on working, keeping it as a passion. Somebody and some people in Tamil Nadu decided some years back that they will work on this issue unitedly and they will devote their time and passion.
Absolutely.
Now it is time for East Zone to take this decision and to move forward. Time has become little easier, I would say.
Much easier.
Much easier than when they had started after the scam and all in early, in late 2000, in past decade of this century. But I think the time is better now, and we should together simultaneously we do all these things, inclusion in the school syllabus, inclusion in medical syllabus, so that we used to do breathing from long before in physiology lab. And after that, my colleague in 2012 told me, oh, the ECG tracing is being shown. I don't accept the patient is there. We used to do it by hand in
I know.
physiology lab. And 30 years back, we studied in almost 30 years back. So the thing is that you cannot expect the whole society will be educated. We have to do simultaneously.
Absolutely. And you should do, I mean, I have some in the afternoon also we'll be discussing in our panel discussion, but to be honest, to me, before I educate the society, I want to educate the doctors, the paramedical.
Yes.
I again and again say that our knowledge in the medical field about brain death and organ donation is abysmal.
Even
very, very little.
Educate
ourselves. Now, coming back to Amit, your turn is coming now. You're the last person, nephrologist from Ranchi. Your comments quick. You have 1 minute to give, and then we break for lunch.
Yes, sir. Thank you, sir. Adding to Dr. Vaidya's comment, we meet here to our local policymaker, you can say administrative office, we go there, but even convincing to those are sometimes we feel difficult. We met, I think, 2 or 3 meetings to start these things locally at RIMS or making some committee. Sometimes it becomes difficult. So educating them is also important so that they should know actually what is the gap between a transplant and organ, and what is the requirement, what is going on other parts of India. That is also something we need to add, sir.
Thank you, Amit. Yes, I totally agree. Yes,
Sir.
Sanjay, very quickly because you are getting late for lunch. Otherwise, you can't have lunch.
Just
Straight
15
go to 2 o'clock
Just
meeting.
15 seconds. I'm Sanjay Kolte, Secretary of ZTCC Nagpur. I very wholeheartedly congratulate this East Zone for the work they have done in the last 2 years. And I very people are very fortunate to have a dynamic Madam Chaudhary at the helm in Roto. And she is very right when she said that there's no reason why East cannot take over from
East. The sun rises from East, boys.
Yes.
Girls. So,
and I would like to exemplify this. Tamil Nadu was at the helm, was at the forefront.
now it is Maharashtra.
Last 2 years, Maharashtra, we have taken it up from them, and we have outscored
So Sanjay
their
is one of the
numbers.
champions, from Nagpur. He's not no more emerging. And he's organizing the Indian Society of Organ Transplant meeting in Nagpur. So you all have to come there.
Just one point, as Dr. Amit was saying, that non-verbal communication is probably a very important tool. And probably your example also replicates out of the 20 that he counseled, 2 probably consented. One of them was already well aware about what organ donation concept is. तो यदि उनको पहले से मालूमात है तो आपको करने की जरूरत नहीं रहती. And I'm sure of the 18, उनमें से आधे लोग ऐसे हुए होंगे कि पहले कन्विंस हो गए और 2 घंटे बाद 3 घंटे बाद वो पलट गए. So unless they are themselves convinced, it usually doesn't materialize into. So Roto East should take it up, that it is advertised very well. All examples are of conversion into donation are exemplified and published in the media, so that the common public also realizes these things. And once they are themselves motivated, then the things become very easy for you.
Thank you very
sir.
much, all of you, and thank you, Sanjay. Yes.
You're talking about this post-mortem. I think it's easier in teaching hospitals because
Yes, it
there
is
is
easier in teaching
PSM
hospital,
involved,
definitely,
you know.
definitely.
What about the private sector, and do we have to talk to the PSM?
So if
teaching
your
hospital?
forensic person from government sector can come into your place and do it, it is being done. It is being done in some places. It all depends on your rapport with the forensic people and with the SOTO. SOTO has to request, and there has to be some kind of compensation, according to me, for the services.
My experience is that when patient goes out of our hospital for postmortem,
Yeah,
it is
that's
the
it.
next 30 hours later.
Yeah, gone.
Yeah, so
Gone.
Teaching hospital to the declaring hospital.
It's a very, very pertinent question. Very, very pertinent question, and it needs to be answered, and an SOP needs to be created. That post-mortem needs to be recognized, because at the moment, post-mortems are only recognized in government institutions in this country, in medical colleges. So for organ donation, there needs to be an exception. That should be accepted in the court of law if something goes wrong. So that is the key. Anyway, we can keep talking about it. We have more opportunities. Yeah.
There is a group of
Absolutely.
faculties
Yeah.
under SOTO who
Who?
willingly accept.
Yeah. So thank you very much. Time for lunch. But what I want to do is think about all these issues as we go forward. Sometimes we just listen to all this and then forget about it. But organ donation should be an ongoing exercise, and we should all, try and champion it, help the community, help our patients who are suffering from organ failure. So thank you, and we'll meet again at 2:00. Thank you, Dr. Arpita. Thank you, Dr. Rajeev.
So just a small request, please be here as soon as possible, because we'll start the first session at around 1:45. Thank you. The lunch is at Azara Hall on 7th floor.
हाँ बोलो. हाँ कोई भी ले लो. हाँ 5 जो मिल रहा है वही ले लो.
तो नहीं जाते ट्रॉमा में तो ऐसी जगह नहीं है कि वो लोग आराम से बैठ सकते जैसे जैसे ये काम अपने मन से दिमाग से करते हमारे आसपास नहीं आएंगे बोल दिए कुछ नाश्ता मंगवा जिसके पैसे चाय पानी का पैसा आता है उससे पैसे दो ऐसे कुछ मान है में एक जब नहीं है बट रहने रह सकते हैं ऐसा भी का मरीज का भी आके रह सकते हैं चीज कभी कभी ट्रांसप्लांट वाले लोग मर जाते हैं नेक्स्ट टाइम बाय स्पेशल ऑर्डर उन लोग की पैसे लिख आपको करते रहो दे वक्त हो सके अपना हिसाब से करना तब मेरा पैसा जो डोनर का भी डोनर आया है that's 8,000 for the donor family support वो आ गया ये में आया है देखिए न्यू आया है उसका उसे 2,000 रुपया मतलब लोग की इसको जो इस टाइम जो स्टे के लिए इतना आपको जरूरी पूरा रहने का इंतजाम करना कितना जरूरी होगा एक तो जगह बोल के आपको अपना हर एक चीज जगह जहाँ पे वो लोग रात को जाके पैसे देखो वो पैसे वाला आप लोग हाँ तो बहुत बहुत कोशिश कर रही हूँ ये चिट्ठी लिख चुकी हूँ सबका गलत तरीका से कैसे लोग लिखा पुराना लोग जो अच्छा काम कर रहे हैं उन लोग की कैसे नहीं पड़ेगा इनसे समझ में नहीं आता है बहुत समय गवर्नमेंट के चीज में समझ में नहीं आता है आई एम वेरी मच अ पार्ट ऑफ गवर्नमेंट ऑर्गेनाइजेशन यहाँ पे समझ में नहीं आता है मैं कोशिश करती हूँ अपने तरीका से आज करने का जब तक शर्मश हो जाने से पूरा काम बिगड़ जाने का संभावना तो नहीं कर पाएंगे वो तो मेडिकल कॉलेज को कर रहे थे ये खत्म किया कल लास्ट 18 मेडिकल कॉलेज सब क्रिटिकल केयर फैकल्टी चुने भी इंडिया एक पूरा उसका व्यवस्थित लिंक दे देंगे और उसका बाद इंस्टीट्यूट अलग से दिखा शॉप से बात करके ह्यूमन कंडीशन की आप तो आप रिट्रीवल आप रिट्रीवल 2 साल करो सब जगह ऑर्गन यूटिलाइज हो रही हो सेंट्रल मिनिस्ट्री अपने आप उनको पैसे देंगे और सब इंफ्रास्ट्रक्चर करवा देंगे और आईएसओटी के मैं तो 2-3 साल रहूंगी दो तीन साल ठीक रहूंगी तो अगर मैं रहूंगी तो ये आप रिट्रीवल चालू करो और रिट्रीवल अगर नहीं चालू करो एक स्टेप होता है ना गवर्नमेंट हॉस्पिटल में इंफ्रास्ट्रक्चर भी बट आपका रांची से कलकत्ता बहुत सारे फ्लाइट्स हैं आप रिट्रीवल चालू करने से ये होगा आपको महीना में आईसीयू से डॉक्टर प्रदीप भट्टाचार्य से बात करना चाह रहे हैं। राधिया और डॉक्टर भट्टाचार्य तीनों आपके आपस में बैठे कि आपको क्या क्या क्वेश्चन है, आपको क्या क्या जानने का, आप पूरा मुझे एक प्रोडक्ट पेपर या मेरा पर्सनल पेपर दे इसके आधार पे क्या क्या साथ में बच्चा आपका बात करना अनिल कुमार से चिट्ठी लिखा उसका बाद वापसी सब जगह से दिक्कत हो रहा है, सब जगह पे कोई अच्छा नहीं लग रहा है। चलो नाश्ता नहीं खाना नहीं लंच नहीं मिलेगा चलो हाँ
ꯃꯣꯏ ꯉꯁꯥꯏꯒꯤ ꯅꯨꯄꯤ ꯑꯃ ꯀꯩꯅꯣ ꯌꯣꯡꯆꯥꯛꯀ ꯍꯥꯏꯕꯗꯨ ꯁꯨꯝ ꯊꯅꯝꯖꯥꯠꯂꯣ ꯀꯣꯚꯤꯗ 19ꯒꯤ ꯀꯩꯅꯣꯗꯣ
하여튼 하고 줘라.
근데 ꯂꯩꯇ꯭ꯔꯦ ꯌꯦꯡꯉꯣ ꯂꯩꯇ꯭ꯔꯗꯤ ꯁ꯭ꯇꯥꯐ ꯅꯠꯇ꯭ꯔꯣ ꯍꯪꯍꯜꯂꯒ ꯑꯥꯗ ꯂꯩꯕ ꯃꯤ ꯃꯦꯜꯒꯤꯗꯒ ꯆꯦꯞꯄꯤꯗꯤ ꯄꯦꯁꯦꯟ ꯂꯩꯇ꯭ꯔꯣ ꯃꯣꯏ ꯖꯦꯅꯦꯔꯦꯜꯗ ꯐꯣꯟ ꯇꯧꯔꯒ ꯍꯪꯍꯟꯕ ꯌꯥꯏ ꯀꯩꯅꯣ ꯇꯧꯗꯣꯏ ꯁꯤꯗ
नेक्स्ट नेक्स्ट स्टार्ट होने वाला है तो उस टाइम कर लेंगे 15 मिनट पहले चलता है बस और क्या है ना नहीं तो उसको ये लाइव चल रहा है तो हम छोड़ भी सकते हैं कोई इशू नहीं है किसी और का सेशन चल रहा है वो कंटिन्यू हम देख भी सकते हैं बैटरी कितनी है
Hello. It is my great pleasure to invite Dr. R.K. Sharma
who is my best friend, and we had worked together at the institute. He has brilliant clinical, academic, and research career. He is a living legend in the field of nephrology and transplantation. He is going to tell us the basic and practical facts about setting up an immunological laboratory for transplantation program, the stepping stone. Dr. R.P. Sharma, please.
Good afternoon, ladies and gentlemen. When we are planning to start transplantation program, okay. One of the important steps is setting up of HLA laboratory. And I'm going to touch upon this important aspect. Okay. The immunological evaluation, these are the major components. We look at blood group of the donor and recipient, the HLA typing, and screening for the anti-HLA antibody, and cross-matching. This is an overview what samples you really need. For HLA typing of the donor and recipient, you need whole blood in EDTA. This is basically for DNA extraction. The screening of class 1 and class 2 antibodies by panel-reactive antibody screening, this is done only in the recipient, and you need serum. Looking at donor-specific antibody, both for class 1 and class 2, for the recipient and the donor. In this, you need blood for getting serum from the recipient, and from the donor, you need to get the heparinized blood to separate the cells and the DNA. The cross-patching, we know basically this is the basic test which we have used is flow cross-match and CDC, the complement-dependent cytotoxicity, for which you need blood both from the donor and the recipient. And from the recipient, you need serum, so it's a clotted blood. And from the donor, you need heparinized blood to separate lymphocytes. This is for the cross-matching. Then we do single antigen bead assay, which is essentially the looking at the antibody, anti-HLA antibody in the recipient, and for which you need serum from the recipient. The antigen typing, which is done today, is by molecular methods, which is DNA-based HLA typing. But we have done HLA typing initially by serological methods, which are no longer used. This is again using the complement-dependent cytotoxicity, which is what we do in cross-matching, that methodology, which could be made more sensitive by using anti-human globulin. But now, as we know, HLA typing is DNA-based. You extract the DNA from the lymphocytes, and then you do HLA typing both in the recipient and the donor by SSP, which is a sequence-specific primer, and SSO, which is a sequence-specific oligonucleotide probe hybridization. This is the method which is used most commonly on the Luminex platform. And then the sequencing-based typing. The serological method, I'm only apprising you because it is used for cross-patching also. And it was used for HLA typing. This is the plate which you should know. This is a plastic plate which was devised by Paul Terasaki. And this Terasaki's plate, which was miniaturized, was used initially for HLA typing, and now it is continued to be used for CDC crossmatch. These are wells which are there for these serological HLA typing. These wells used to have well-typed sera having known anti-HLA sera, which were used for HLA typing of the patient and the donor. What essentially it involves is mixing that serum for cross-patching with the donor cells, adding complement. So it's a complement-dependent killing of the lymphocytes, which you pick up in the inverted phase contrast microscope. This is not working. Yeah, okay. Yeah. So you try to differentiate the killing of these cells by adding a dye. When the cells die, they take up the dye, and the dye enters the cells because the cell wall is not able to keep the dye out. And that's how you identify that there is cell killing. This is a method which is done by the operator under the microscope, but experience tells the operator very easily whether this killing is significant or not. And then you finally conclude. The molecular methods, as I mentioned, are sequence-specific primers being used, or sequence-specific oligonucleotide, and the sequence-based using an NGS platform. I will not go into the detail for because to save the time. The SSP method includes using a gel-based system. In the gel, the primers, in the SSP method, you look at the amplification and then try to identify. Now we have, you can photograph the gel and then run it in a software which will give you much more easily the typing in SSP. In SSO, which is the one which is used more commonly using the Luminex platform, this is the Luminex machine, and you use Luminex beads and use laser. So by laser, you are identifying the target and also trying to quantify the target. So both these things, when they are run through the program, it gives you, it reads up and then tells you the what are the after the primer, after the amplification, the typing could be concluded. The anti-HLA antibodies are very important because, as we were having discussion in the morning, in India, for brain dead organ use in kidney transplant, you're only doing a cross-patching. Cross-patching means you're only taking the serum from the recipient and the cells from the donor and going through a CDC system, as I showed you, in a Terasaki plate. So that is what is done, and that is a very basic test. If that cross-match is negative, you go ahead and do the transplant. But that is not ideal. But the problem is, in view of the time frame, this is the one which is used most commonly. The other is you can make the CDC platform much more sensitive by adding anti-human globulin. ASG makes the test much more sensitive. The solid phase platforms include using a Luminex and a flow cytometer. Flow cytometer can also be used, which is much more sensitive than CDC crossmatch. In the CDC, as I mentioned, basically you are using the dye to identify the cell killing. And like in the inverted phase contrast microscope, you look at by adding the eosin dye. If the cells are dyed, they take up the eosin and their color changes. And then you grade the killing and then say whether it's significant or not. So the cross match, if it is negative, means there are no antibodies picked up by the technique which we're using in the recipient. It rules out the possibility of a hyperacute rejection. This was one of the very important testing methodology which reduced the accelerated or hyperacute rejections to a great extent. And it was pioneered by Paul Terasaki. The positive cross-match and amount of positivity is actually an important risk factor for hyperacute rejection. A word about PRA. We all talk about PRA, which is a panel reactive antibody. It is essentially telling you about broad sensitization. It gives an indicator, it's an indicator of spectrum of antibodies against HLA in the recipient. Initially, when serological methods were only used, what was being done for PRA is that you used 100 target cells and tested the serum of a prospective recipient by CDC crossmatch and tried to come to a point that against how many cells the killing is there. If you're using 100 target cells from 100 different individuals collected from the pool which you have, if 20 of those cells show the killing, you used to say 20% killing. So PRA is 20%. If all the lymphocyte from 100 donors, they show the significant killing, that is 100% PRA. But that is all changed now. Now we do calculated PRA. Calculated PRA essentially means is you do a single antigen bead assay in the serum of the recipient and try to find out the antibody specificity which is present in the serum of an individual. I'll tell you how it would change. Suppose if you have a cell-based old PRA technique and only 5 beads which you were using were actually showing you an antibody against HLA-A2, your percentage will be 5%, because 5 out of 100 target lymphocyte, they showed the killing. But actually, if you see the A2 in the normal individuals, you find that it is very common. It is seen almost in 40 to 48% of individuals. It varies. So by the calculated PRA, if you have A2 antibody, the PRA shoots up to 48%, which really means that the possibility of this individual having a positive cross match has increased from 0% to 48%. So that is how the calculated PRA is a much better indicator. It gives you the broadness of the spectrum of sensitization. The PRA, as I mentioned, tells you both the degree and the broadness. If you have very strong PRAs, which you can get an idea by MFIs, and if you have PRAs against a high percentage, then you have the high degree and a high broadness. So it is only telling you about this aspect. This doesn't mean that a person with high PRA will also have a cross-match positive. You may still get a donor against which the cross-match would be negative. So we have to understand the whole concept. Those solid phase assays, though they are expensive, has made all these things, despite drawbacks in the technology, much more sensitive and specific. Cost remains a factor. These are the three tests which I mentioned, the cytotoxic CDC, which can be enhanced by AHG, anti-human globulin, and flow cytometry, which are used for cross-matching. The SAB test actually uses the HLA, which have been purified and attached on the beads. It's an artificial biotechnology-driven method. You can get in the whole process sometimes changes in the beads. So it is not that always what the test results you get, it is not 100% specific and 100% sensitive. So there are drawbacks in this technology as well. You must be reading about virtual cross-match. The virtual cross-match is now actually the pillar of organ sharing. It essentially means that you do the antibody specificity in a prospective recipient, which you do in the patient who are waiting. And then as the donor comes in, you do their HLA typing. And then if there is no antibody, the virtual cross-match is negative. And the actual wet cross-match is also likely to be negative. So sharing becomes much more easier. So I think Flow uses these methods using the donor cells. And then, as I mentioned to you, the concept of looking at the breadth of sensitization, which is by PRA, and the titers of MFI, which you get by the single antigen bead assay. Luminex platform gives you some idea of the strength. The positive DSA is telling you anti-HLA antibodies, whether they are there or not. It doesn't rule out the non-HLA. The cross-match can also include non-HLA antibody and also sometimes the autoantibody. You can go through these guidelines. These are a little old, but they have not been upgraded, but they will give you a very comprehensive summary of different techniques being used. Essentially, it says that even for deceased organ transplant, especially for living donor transplant, if you have a fully typed donor and recipient, and if you're doing a single antigen bead assay, you would be able to rule out the presence of donor-specific antibody. And the risk assessment against anti-HLA antibody-driven is very specifically looked for. So that's what they recommend. And you can even actually get away without doing a CDC or a flow cross-match, which are at present the gold standards and much more economical from the Indian point of view. They sometimes get stuck. Can you, somebody have? Okay. So if the DSA is present and a cross-match is negative, you do not rule out a transplant, but you should understand that this could be immunologically a different or a high-risk situation. So all those things are becoming much more objective and being clarified once you have all these battery of tests. ABO incompatibility is no longer an absolute contraindication, as we know now that these patients can also undergo transplant, though it is much more expensive. A word about liver transplant. Most people believe that in liver transplant, we don't need to do HLA typing. We don't need to do antibody screening. But what I would like to tell you, if you go exactly, I'm talking of living donor liver transplant, by the HOTA, for the donor and recipient, the same rules apply as for kidney transplant, number one. Second, even for liver transplant, if a cross match is positive, it's a high risk situation. So my gut feeling is, even in liver transplant, you should do a CDC cross match. And if a CDC cross match is positive, it is a situation where you may need a different immunosuppression protocol. This will affect your long-term outcomes. The post-transplant screening, also these guidelines mentioned, I would just skip. And lastly, I would like to acknowledge, because this topic was the HLA establishing an HLA lab. My journey started way back in actually in 84 or 82, when these two pioneers who really helped me, and I could understand from a plain simple nephrologist, Dr. H.L. Trivedi and John Dossiter, and both of them have institution by their name. This is the Dr. H.L. Trivedi's Institute of Kidney Diseases, and John Dossiter, who was in Edmonton, he has institute after his name of bioethics. This is the technologist Sue Sedgman, who went on to become the director in Harvard Medical School of HLA lab. So these were the initial stages when I got introduced into this area, and then established a setup in SCPGI, which is now I moved to Medanta, Lucknow, where it is going on. So I would like to acknowledge that the HLA typing, when cyclosporin came, was considered to be redundant. Actually, the transplanters started saying there's no need for HLA, there's no need for looking at antibody. Now we have a wonderful cyclosporin, because the number of transplant centers increased from 6 to 1,000. The outcome became so good, but we have moved a long way. Cyclosporin is now replaced by tacrolimus, and these are the two gentlemen, Stargell and Roy Kahn. Roy Kahn is actually painted this picture, and this is one of the Rome meeting of Transplantation Society, where the religion is also coming forward to mention that organ donation is actually approved and permitted and recommended by all religions. So thank you very much for giving me this opportunity. If there are any questions, I will be glad to take.
So nice presentation of the topic. Now the topic is open for the discussion. Any question from the audience?
On small volume government centers, how do they go about establishing the HLA lab?
See, the HLA lab establishment should only be done in a setup where you are going to cater to significant number of patients. The other important thing is you have to maintain the quality of your results. Now with the machines being available, the quality is much easier to monitor. So I would not recommend for centers who are doing less than 50 transplants to go for HLA setups full blown. CDC cross-match is something which is very basic, which can be started. But I can tell you, for CDC cross-match also, you have to have a lot of experience. It's an easier test in a way, but I would tell you it's much more complicated than a machine-based testing method. Like abroad in USA, the labs will have an individual who is doing 100 CDCs in a day. From morning, evening, the gentleman, though he knows all the tests, but he will only be doing CDC cross-match. So for smaller setups, I would not recommend to start a full-fledged lab. But from the clinician aspect, you should understand what actually all these techniques mean, how to use them optimally. You should go for, now we have labs which are actually centralized labs which are doing the testing. But I would say that even the transplant programs, the National Transplant Program is emphasizing that for one city or one area, there should be a HLA setup available. So that should suffice, which is going to accept the samples and process them.
What do you say about the training of nephrologists in this segment of reporting? I mean, many nephrologists are not trained to read those reports.
Oh, nephrologists don't need to read the reports. In a way, for reporting, I'm talking. They need to be trained, or during their education or DM, they have to understand what those things mean. Because if you really want to do the test yourself, nephrologists can do. I'm not saying, like John Dossiter was a plain simple nephrologist. He established one of the good labs in Edmonton. So you don't worry about establishing the lab yourself. For that, you will need some actual training for at least 2 years. Because I spent 2 years in Edmonton. That was mainly serological at that time before we could start. But you should understand the different results and how to interpret them. That is important. That should be a part of your curriculum.
With this session comes to an end, and we had a very nice discussion on this topic by Professor Dr. R.K. Sharma, and he deserves a standing ovation on this. So I request all of you to stand up and give him a standing ovation. Thank you very much.
Thank you, chairpersons, for conducting the session excellently. And as said, this was a very nice session by Dr. R.K. Sharma, sir. Moving on to the next session. This session is about the pre-transplant immunological workup, especially in a resource-limited setting. And for this session, I'd like to call upon the chairpersons, Dr. Professor Hemant Kumar, sir. Sir is the former professor and head department of nephrology at IGMS, also the former professor and head department of nephrology at PMCH, and a senior consultant practicing nephrologist in Patna. Then we have Dr. Ashray Singhare. He is a consultant nephrologist from Mumbai. He will be joining online. And Dr. Vivek Ruhela. He is the consultant nephrologist from Dehradun. And Dr. Deshraj Gurjar, who is the consultant nephrologist from Kanpur. So I'll request the chairperson to introduce the speaker and carry on the session.
Good afternoon, one and all. In this postprandial session, it's my pleasure to invite Dr. Professor Narayan Prasad. Dr. Professor Narayan Prasad, as all of you know, he is the professor and HOD of nephrology at SGPGIMS Lucknow. And he is one of the youngest icons of nephrology, not in the country, rather internationally. So we must applaud his contribution in the field of nephrology. Professor Prasad will be talking on pre-transplant immunological workup, how to proceed at a resource-limited setting. Dr. Narayan, please.
At the outset, I would like to thank Scientific Committee of the Midterm ISOT, the team of IGMS Patna, Dr. Om Kumar, Dr. Pritpal, and Dr. Harshvardhan, Dr. Amresh, for considering me for this topic. I really becomes very much nostalgic when come back to Patna. I have been graduated and post-graduated from this place, from Patna Medical College, and subsequently moved to SGPGI, where I have been trained up for the postdoctorate DM degree in nephrology, and then I am faculty there, professor and head of the department. And I have taken over from Professor Amit Gupta. And just coming back to what Professor Sharma has set up as a lab immunological lab at SGPJ. That was a recommendable job. And there was a great challenge to take over this charge and to move forward. And I'm just coming on my topic, how it is important and why any immunological tests are important. One of the important thing is to avoid hyperacute rejections to the knee that we have already achieved with CDC. Almost CDC has made this knee. No severe antibody mediated rejection. That was not possible with the CDC only. Minimum T-cell mediated rejection, prolong the short and long-term graft survival, and help in balancing the rejection and infection. That is another motto, because majority of the patients in India are dying because of infection, not because of rejection now. So there are two important rejections, cellular and humoral. Humoral is now becoming more problematic than the cellular rejection that is coming down day by day. So two theories started. One was, you can see here, this great stalwarts, Peter Medawar, who has given the concept of the cellular theory of the rejection. Every one of us know about him. And there was markers of the cellular injury there in the graft biopsy. That was the beautiful, and that was the advantage of at that point. You can see the lymphocyte infiltrates in the interstitium. You might have the tubulitis. You can diagnose this is the cellular rejection. But major theory comes when we have the humoral theory. And that was more problematic because initially there was no good markers for the humoral rejections. Only when the C4D came, and that was covalently bound to the basement membrane of the glomerulars, and then they came as one of the histological marker of the rejections. Humoral theory, Paul Terasaki, we all understand about him. We all know him. He died in November 2016 now, but he had given the great concept of how to take care of this humoral rejection. So whenever we work about transplantation, we have heard we have to do tissue typing, we have to do HLA-A, B, D, R, and we have to do some of the CDC, flow cytometric cross match, single antigen bead assay. These are on the horizon. But the situation here is low resource setting. When you have the low resource setting, what you can do? If there is no resource, is the limited resource is not the limitation, then you have to do the full class A, B, C, and class 2 DP, DQ, DR. But at present, most of this low resource setting, we only do A, B, and DR from the class 2. Again, further, don't think low resource, find donor specific antibody, Luminex cross match, and single antigen bead test. So we have no battery of tests. When you think of how this happens, I am not going to talk in detail. Professor Sharma has already talked about the CDC cross match, flow cytometric cross match, and Luminex cross match based on lysates. But this was not only the one part. As this was improving, at the same time, you had the good immunosuppression also. And you can see here, as soon as the tacrolimus and mycophenolate mofetil has been introduced, your rejections came down here. And graft life improved dramatically. So both things were happening in parallel. So both are important. I'm giving you some example how we can work out in low resource setting and avoiding more severe, at least humoral rejection. Here we can have one case. What we have seen initially, he is a wife donor, no HLA match. What we have seen, flow cytometric cross match was negative, and DSA, which has been done with this Luminex flow cross match, what we talk about, that was negative for class 1, but borderline positive for class 2. MFI was. So now there was a situation what to do next. In low resource setting, what I used to do, whenever we see this class 2, we order for the single antigen bead of the class 2 only. And we have seen some of the MFI was here of the class 2, like DBQ was in the range of 3340, significantly high. Then whether this is the donor specific, initially we have not done DP, DQ, DR, and then only we are getting done of the donors HLA for class 2, DPDQ. And what we have seen, this was a donor specific antibody is likely to cause problem. So you have selected this, not allowing every test to be done. You have not to get for the DPDQ of the recipient. You are going test cost is dramatically different. I am coming to the back to this. This patient has been desensitized. We have done the transplantation. Here the patient has little problems. We have done the biopsy. Little milder kind of the humoral rejection was going on. We have given the 2 flex. The patient improved dramatically. So we were knowing that this patient is highly sensitized. We have taken the adequate care. Outcome is better. Second patient, again the donor was wife. There was no match. CDC cross match was negative. And here you can see flow cytometric cross match was also negative, class 2. Here we can see MFI was 1873. It's not looking that high. But anything more than 1000, we think it might be problematic. Again, we have done the same thing. What we have seen, DQB102, this was the donor specific antibody. It is likely that this patient will cause problem. So again, we have taken the care. We have desensitized. This patient has a lot of comorbidity also. So we don't want it to have the risk because diabetic, coronary artery disease, PTCA done a few months before, and excellent outcome. This patient was a little more complicated. Here we can see there was mother was the donor. What we can see here, haploidentical mismatch. What we can see here, flow cytometric cross match was negative. At that point of the time, this patient had came with a cross match from elsewhere. This was negative. But DSA Lyset was showing borderline positive for class 1 and negative for class 2. What we have seen here, CDC cross match turned out to be positive. So this was really a positive and highly sensitized patient. If CDC is positive, we have no confusion. What we have to do from where is the problem? Then we have got the single antigen bead assay where we can see here HLA-C is showing 3121 of the MFI pattern. That was looking quite significant. Then we have got the patients, not all HLA, only done is HLA-C. Here we can see this was the donor specific antibody. And then it was looking like probably this patient would also be a problematic patient. Subsequently, we have done desensitization with rituximab and Plex. Got that again, test repeat. MFI of this donor specific antibody came below 1000. We decided to go ahead with the transplantation. CDC became negative. There was no too much of the problems. Desensitized, got the transplant done. You can see the excellent result. Patient is still in follow-up, doing fine. So tacrolimus level, this is what we maintain, that is all. So what happens when method of DSA detection is your sensitivity of detection of the antibody go up as you move towards the Luminex single gene antibody test, and actually the DSA level, detections level of accordingly test also go down. So what is more important? You have to guess which is important and what you have to get it done if your resource is limited. Otherwise, if you have money, you can go for everything. Interpretation of the test, when you have the battery of tests, then it becomes a little confusing also. In the bottom, if everything is negative, no chance of any rejection, you can go ahead. At upper level, all tests, flow cytometric and cytometric cross match, both are positive. Don't go for any transplantation. So that is fine. But sometimes comes the situation where you might have the one like the B cell only positives. Sometimes you might have the autoantibody causing problems. So that kind of things interpretation we should understand. And because of the lack of the time, I'm not going into the detail, but I'm just going to sensitize you what happens with this new test. This was one landmark study which has been published in 2009. Here, 3,300 patients negative CDC cross match. Here we can see there was only antibody mediated rejection was seen in 6%. What we can see out of this 67 has some anti-HLA DSA positive. Out of these 67, when they underwent transfer, 55% has acute antibody mediated rejection, but you can see at the same time 40% do not have also. So when you will see this Lysate based class 1 or class 2 cross match positivity, it is not always. So what is important becomes important. You have to go for the single antigen BDS. See the strength of the antibody, that is more important. And then because you have the tool, you know how to desensitize this patient, how you can get the best result by desensitization and transplantation. So here again, this you can see few studies, CDC all negative, flow once negative, and pre-transplant single antigen being negative. You can percentage of the positive pre-formed DSA, you can see can vary from 18% to 24-25%, and antibody mediated rejections will go down if you are doing the pre-transplant single antigen BDSA to 15% rather than 35 or 55%. So it is possible that as much as sugar you will add, that much sweeter would be the result. But optimally, what we need to understand how we can optimize our resources, that is very important. Just coming to this study which we have recently published, this is a review of our experiences from 2000 to 2020. We have two groups of the patient. Initially, every year we used to face some of this graft cortical necrosis because of rejection. What you can see when we have started doing CDC, along with the CDC, flow cytometric cross match and DSA, there was no graft cortical necrosis. Single graft cortical necrosis happens after that. That happens because of mucormycosis of the vessel. And before that, every year we have some severe rejection, cortical necrosis. So that gives you the confidence. Adopting this kind of the test in your day-to-day practice helps out in your best result. Here we can see this was the part of the same publication. Total of the 37 cortical graft necrosis, what we can see here. There was a role of the tacrolimus also. Tacrolimus with the use of the introduction, we can see here only 11 cortical necrosis in the tacrolimus based regime, while the 26 in the cyclosporine based regimes. And again, no induction. Induction has no role in giving this severe antibody mediated rejection and cortical necrosis if you have CDC and other cross match also there. So induction was not proven in this study, but here we can see this was the tacrolimus based regimes and other was the flow cytometric cross match and your single antigen BDSA helps out. So our protocol is to identify the patient whether it is a high risk or low risk. If there is low risk, DSA Lysate based flow cytometric cross match we used to do. If negative, only CDC, go for the transplantation. If any of the class 1 or class 2 on Lysate turns out to be positive, we go for, this is the last slide, sir. This is the last slide, probably we will have 14 seconds. Sir. So single antigen bead assay, complement dependent toxicity. If CDC, a strong positive, more than MF5, more than 5,000, we do not go for desensitization. We do not, if less than 5,000, we can proceed with the desensitization. Why I am trying to show this? Because the cost difference with the Lysate based assay detection is only 3,000 versus 30,000. So cost difference is 10 times. So doing in every patient single antigen bead, I feel I'm not feeling that much comfortable because this is costly. So you can screen with this. So thank you, ladies and gentlemen. Thank you for your attention. Probably this is the last slide. So and there are many other options also. You can choose when you have sensitized patient. You can go for exchange program, paired exchange programs, and you can opt for desensitization. But working on sensitization is very important to reduce rejection.
Over to other co-chairmen, if they are virtually present. If they have any comment or any question? We have constraint of time, so possibly we will not be able to take any question for this session.
Sir, 5 minutes time still we have. I have done 15 minutes only. We have 20 minutes time.
Let us say, in fact, evening time, we are going to have a chief guest. We will be here with us only for 30 minutes. So as communicated by him, so we are trying to curtail 5 minutes in every session. Yes,
Is there in role of the PRA? This is Dr. Tiwari speaking.
Ma'am, I understand about the DSLIZ. We are using as a screening for this. Whenever I get any class 1 or class 2 MFI of more than 1000, we take is a borderline positive. And then we go for only in that group of the patient, we are going for single antigen bead. Because at the same time, we have flow cytometric cross match in every patient and CDC cross match in every patient. So we have already a base that this patient is not looking like that sensitive, only fear of this antibody mediated rejection. So
many times DSLIZ doesn't have the representation of HLA-B and HLA-B.
I agree, ma'am. So because to avoid that going to the test of the single antigen bead in every patient, so we are doing in selective patients.
Rather, what you have proposed, one solid phase followed by flow cytometry followed by CDC. Why not? Why won't you stick to that?
Yeah, ma'am, actually the cost difference of this is very huge. When we are going for the class 1 and class 2, at least 30,000 in my lab. In others lab, it is going to cost about 45,000, 50,000. So cost difference is huge. And we have on the baseline CDC and flow cytometric cross match. And we are happy with the results. Our acute antibody mediated rejection is less than 5%. Rarely see. More of the patient have problem of infection, no rejection.
Even with CDC, we are having almost similar 8% acute antibody mediated rejection.
Yeah,
only with
I understand. CDC is always a baseline. Definitely, this gives you dealing with. I have shown the 3 cases how the donor specific antibody you can deal with in some of the patient. You can go safe transplantation.
Thank you, Professor Narayan Prasad, for your elucidative talk. Let us give him a big clap for an excellent talk by Professor Narayan. Thank you very much.
Thank you, chairpersons, for conducting the session. And Dr. Narayan Prasad, as expected, an excellent speaker, has given us a very excellent lecture. With this, we will move to the induction therapy. We already discussed about the immunological workup. Next, moving to the induction therapy. For this session, the chairpersons, I'd like to call upon the chairpersons, Dr. Professor Vinod Kumar Singh, sir, former professor and head Department of Nephrology at PMCH. Dr. N.C. Prasad, sir, who is the former Director General Health Services, Government of Bihar, and a senior practicing nephrologist in Patna. And Dr. Jitendra Kumar, who is the senior consultant nephrologist from Accord Hospital, Faridabad. I'll request the chairpersons to introduce the speaker who is online, and let's proceed with the session.
So, welcome to this important session of transplantation. Induction is a very interesting subject for the transplant medicine, but it is also very complex. So, Dr. Shyam Bihari Pansal, who is present Director Nephrology Society of Delhi Nephrology Society and executive member of ISN. Presently, he is affiliated with Medanta Medicity Gurgaon, and he will talk about induction therapy in transplantation.
Thank you. Are my slides visible? Am I audible?
You are visible. You are visible.
Okay. Thank you. Thank you very much for Congratulations to organizer ISOT Patna and the scientific committee of ISOT for this giving me this opportunity for to talk about this topic on induction in kidney transplant recipient. We all know that induction is a contentious issue in the present day condition in transplant recipients. And just I'll give a brief about the induction therapies which we use currently and which have been used previously. So there are two types of the induction therapies which have been used. Or one is the depleting antibodies. Depleting antibodies are the potent therapies, and they deplete the T cells for a period of 3 to 6 months, even longer sometimes if the higher doses are given. And there are two types. One is the monoclonal antibodies. Monoclonal antibodies previously OKT3 was used, but nowadays it has been discontinued because of the better therapies and because of its side effect. Another is alemtuzumab, which is the anti-CD52 antibody, but it is not available in India. The available depleting antibodies in India are the polyclonal antibody, that is the rabbit anti-thymocytic globulin, which is one by the Sanofi by the name of thymoglobulin, and one by the Fresenius by the name of Grafilon. And then there are non-depleting antibodies who do not deplete the T cells, but they inhibit the T cell proliferation by the blockage of the IL-2 receptors. And nowadays only basiliximab is available in the market for the use. So there are some basic difference because these are the two major induction agent which we use currently. So just a brief about these. As I mentioned, this ATG is a stronger or the more potent antibody, and you can try to give it in the steroid withdrawal patients, but the chances of infection are slightly higher with this antibodies as compared to the basiliximab. There are some reports of higher malignancy, but that was previous when the use of the higher doses were used. And then there are side effects like leukopenia, thrombocytopenia, serum sickness, and rarely basiliximab can cause hypersensitivity reactions. So we see how these antibodies and the immunosuppression regimen has evolved in transplant. In the 90s, cyclosporin was the main CNI which was used, but nowadays more than 90% of the centers throughout the world, they use tacrolimus as immunosuppression. Antimetabolite, previously it was azathioprine, nowadays it is completely replaced by mycophenolate. mTOR inhibitors, they were more uses in between in the 2000, but now they have again gone down. Some centers outside in the US use steroid free, and there are very few centers in India who would use steroid free. We have used steroid free initially in some of our patients, but nowadays we don't use. And you can see the use of the induction agent, which is a very important thing. As you can see, the induction agents are used more and more often nowadays, and the people who are not receiving induction are less than 20%, and the depleting antibody, that is the thymoglobulin use, is going up in the transplant as such as compared to the IL-2 receptors blocker. So with that, you can see that previously the rejection rate in the 90s, the Professor Sharma and the other senior people can see that rejection was almost half of the patient. They used to have some rejection because double or triple immunosuppression with cyclosporin, AZA or steroid was used. It reduced with the introduction of MMF to 25 to 30%. And nowadays we see in the current last decade, the acute rejection in most of these centers have reduced to 10 to 15%, even less than 10% in many centers. And that is why, because of the higher use of the induction agent, but because of the use of the tacrolimus and mycophenolate and steroid, you can see even in the no induction, the rejection rate has come down to around 10% to 12% nowadays. So it has become very difficult to justify the use of the induction in some of the class at least. Our KDIGO guideline 2009, they recommended that induction agent should be used in all the patients who are going for the kidney transplant. because there are higher chances of acute rejection and the graft loss. And this was based on one of the meta-analysis which used 24 studies of interleukin-2 receptor antibodies versus placebo, and they found that the risk of graft loss reduces by 25% and rejection by 28% in the first year of the transplant. But most of these studies, they were done with cyclosporin-based immunosuppression, and we know that TAC and MMF-based immunosuppression is a better immunosuppression, and the risk of acute rejection was very in the placebo arm, as it was 38 to 40%. And at that time, it was justified to give induction in all the patients, even the low risk, because you need to treat 9 patients to prevent 1 episode of acute rejection. But then we are talking about, if we talk about the TAC and MMF-based immunosuppression, this was an analysis of the data from the USRDS, and you can see that the acute rejection rate in induction was 11.6%. IL-2 and 13% in no induction. So the difference has shortened considerably, although it was significant, but the effect was much less. So you needed to treat 70 patients to prevent 1 episode of acute rejection. And they then identify the groups who had higher chances of the rejection. As you can see that the patients who were younger, if the recipients were older or African American or high PRA or more HLA mismatches, these are all risk factors for the rejection. In these patients, there were higher chances of rejection. So one thing is sure that if we have to taken into the consideration the various risk factor for the acute rejection, and the effect was more in the living donors. So I would just discuss about some of the studies in the low risk recipient and the high risk recipients. So as I already mentioned, that the low risk are the patients who are the first transplant recipient, living donors, good HLA match, and less than 10% or even 0% PRA. High risk recipients are the sensitized recipient who had multiple pregnancies, transfusions, young age, African American, ABO incompatible. So these are the high risk recipient. But if you see the trend in US, I don't know the trend in the India, but many centers use induction in even the low risk patient. You can see that even in the low risk patient, the 80% approximately people, they received induction therapy, and only 20% they do not receive induction, and the ATU is slightly more than the IL-2 receptor blocker in this agent. So this is a very year study this published this year only, and they seen the effect of the induction in the patients who were low risk. So about 3,000 patients, 57% were treated with T-cell depleting antibody, 28% with IL-2 receptor blockers, and 15% without induction. And as you can see, the upper two are the no induction and the IL-2 induction. You can see the graft time to graft loss was shorter, more in the T-cell depleting antibodies as compared to no induction or IL-2 induction. And graft loss censored for that was also higher in the patient on T-cell depleting antibodies, but death with functioning graft was not significantly different. So this data clearly shows that patients who are low risk, if they are treated with T-cell depleting antibody, they are higher hazard ratio for graft loss, censored for that, and there was no advantage. They then further did subgroup analysis also, that in the patients who were blacks, patients who were deceased donor, and patients who were living donor. In the deceased donor, there was no difference. So they mixed the group of IL-2 and no induction and compared with the T-cell depleting antibodies. And they found that there was no advantage of using T-cell depleting antibodies or even induction in the low risk. But you should understand that these patients, they were very low risk, and there was full HLA, 0, A, B, or DRA mismatch. And the acute rejection incidence was similar, 4 to 5% in all the group. So in low risk recipient, if there are well matched first transplant, there is no use of probably induction using any sort of induction therapy. This is a data of a larger data of the registry in which actually more than 25,000 patients were enrolled between 2000 and 2012, and they divided into the two groups, steroids and the non-steroid, no steroid group, and there were three subgroups: IL-2 receptor antibody, ATG, and no induction therapy. See outcome by the acute rejection at 1 year and graft loss. So you can see that there was acute rejection was less than 15% in patient, whether you use induction with IL-2 or no induction or ATG. But the rejection was less with the ATG as compared to the no induction. But there was no difference between IL-2 and no induction. In steroid-free, however, there was higher chances of rejection with IL-2 as compared to ATG and alemtuzumab. So you can see that if you do propensity-based analysis, you find that there was no difference in acute rejection in the steroid group with IL-2 and no induction, but the rejection was lower with the ATG group. In the steroid-free, rejection was lower with ATG and alemtuzumab group. So this is, but there was no difference in the graft survival. There was higher graft loss in the patient who received alemtuzumab in the no steroid groups. So the conclusion is that living renal transplant recipient, those who are maintained on TAC, MMF, and steroid are at low risk of acute rejection and graft loss, and advantage of using IL-2 may be too small. However, it was a retrospective and observational data. Coming to high-risk group. So high-risk group, as we already mentioned, these are the deceased donor transplant, and the best data came from the study by Brennan et al., which he used Revit ATG versus basiliximab in transplantation. They used 4 doses, means 6 milligram of ATG and 2 doses of the basiliximab, and they found that acute rejection rates were lower with ATG in this group, and the antibody mediated rejection was also less in this group. However, there was no difference in the graft survival, and the infection was slightly more common in the ATG group. So this is again a large data of the deceased donor transplant, which is the last study which I am quoting from 2000 to 2012. And as you can see, this is data in the deceased donor transplant. The acute rejection rate is less than 15% in all the patients. However, the rejection are less in the ATG group. Even the PS propensity-based match also rejection is less, but and in the steroid-free group, the rejection is less with the ATG and alemtuzumab as compared to interleukin-2 receptor antibodies level. But the graft survival was not different in these groups. So I will just, before finishing, I will show our data over a period of time, because we started collecting our data from 2010 onwards. So you can see that initially the rejection rate from, this is a data from 2010 to 2014, retrospective data, 600 patient in induction group and mainly interleukin-2 based induction immunosuppression. We did not use ATG at that time. And our acute rejection rate were 20% versus 26%, quite high, almost reaching significance. And graft loss was more in the non-induction group. But much of this was because we did not used to do a very extensive immunological workup at that time. Another reason for the higher rejection in the induction in the IL-2 group was that 20% of our patients were steroid-free at that time, and the rejection rates were higher in those patients. Then we published a prospective study in Indian Journal of Transplant in 2014 to 16 data, and we did not find any difference in the induction with IL-2 versus no induction. The rejection rate was 20% and 17%, but it was not significant. The only problem of this study was that the patients who were HLA mismatch, which is spousal and all that, they preferably got basiliximab. So the groups were, you can say, the matching was not so good because this was not a randomized study. And the numbers of the no induction group were less. Then the Grafron, this is another type of the ATG who came to picture in 2017. So we also compared the Grafron versus thymoglobulin, and we published this in Indian Journal of Nephrology. And because this was the dose which was actually advised, 6 milligram versus 3 milligram of thymoglobulin. And we found that the incidence of the acute rejection were higher in the Grafron group, 12.8% versus 5% in the thymoglobulin group. So it shows that the Grafron 6 milligram was not equal to thymoglobulin in our patient population. However, the overall acute rejection had come down significantly. And now coming to the recent data for last 3 years, because there is much improvement in our rejection rates, you can see that most of our induction is now ATG based induction. However, we use no induction in 20% and IL-2 in 20% of the patients. And our recent acute rejection rates are with ATG is 5%, even with no induction, and Simulac it is 8%, and slightly higher with Graflon. So just to summarize that, it is very difficult to see a randomized trial because these numbers, the incidence of the acute rejection has gone down, and even to reduce a small number, you need to treat a lot of patients and without any effect on the long-term survival. So how you should choose your induction based on the risk. So you have to see where your patient stands, what is the HLA match, living donor, PRA, DSA, blood group compatibility, cold ischemia, first transplant versus high risk. So on basis of that, you should decide about your induction, and many of these patients, you actually do not need any sort of the induction treatment in kidney transplant recipient. As I have shown, that rejection rates are less than 10%.
Please.
Thank you. It is done. I think I am on time. I finished in on 15 minutes.
Thank you. Thank you, Dr. Bansal. Yes. Dr. Jitender has connected with us. Dr. Jitender.
Hello, am I audible, sir?
Your comment. Yes, yes.
Yeah, that was really a wonderful discussion by Dr. Shyam. And just a question to start the discussion. Shyam, recently there has been trend of using very, very low dosage of ATG in India. Do you think that is justified because in this tacrolimus era, whether you are using a small dosage of ATG, whether the effect was evident or not? And by giving low dose, are we subjecting to long-term risk? Can you highlight on this issue, Shyam?
Yeah, Dr. Jiten, this is a very good and pertinent question. See, it has been proven scientifically that if you use dose of thymoglobulin less than 3 milligram, it is actually of no use. So we are discussing whether 3 to 4.5 milligram is probably the adequate dose for the most of the Indian patient, but less than 3, there is no. It is very difficult to prove. So if somebody is advocating less than 3 milligram, you should do some randomized trial or at least a prospective trial to see whether what is the difference between the patient in induction and no induction group. So we do not practice it. At least 3 milligram per kg of thymoglobulin that is required, that should be given.
Okay, thank you, Shyam, and over to the audience for any questions.
Any question? Yes, Jitender.
Dr. Shyam. Yes, I could not get it. Pardon, what was the question?
Nowadays, ATG is not available in the market. So
no. So if ATG is not available, so what we do that because we don't have any choice of Graflon we give, but now the doses of Graflon we have increased to 9 mg, 8 to 9 mg per kg, because we have shown and we have shown it, and that if you use 6 milligram, that is not sufficient, not as good as 3 milligram of thymo. So you have to use higher doses.
Thank you, Dr. Bansal, Dr. Jitender, and thank you all.
Thank you very much.
Thank you very much.
Thank you, chairpersons and the speaker, for a nice interactive session. With this, we will move to the next section, which is mainly focusing on the deceased donor transplantation. Now this session is a purely virtual session. The chairpersons as well as the speaker are virtual. So the chairpersons, I'd like to invite them online. Dr. D.S. Rana, sir, doesn't need any introduction. Sir is the senior consultant nephrologist at Sir Gangaram Hospital and also the vice chairman of Sir Gangaram Hospital, New Delhi. Then we have Dr. A.K. Baidia, sir, who also joined in the morning. Sir is the senior consultant nephrologist from Ranchi. And then we have Dr. P.K. Dubey, who is the professor and head Department of Anesthesiology, IGIMS, Patna. On the Dr. D.S. Rana, sir, if you can please introduce the speaker, Dr. Avnish Seth, sir. Please unmute, sir.
Hello. Hello.
Yeah, Dr. Baidia is audible.
Hello.
Yes, sir.
Sir, please go ahead. You can introduce the speaker and we will start the session then.
Yeah, Dr. Avnish Seth is MD/DM gastroenterology from PGI Chandigarh. Right now, he is head of Manipal Organ Sharing and Transplant, member of Tax Technical Committee, NOTO, member of Advisory Board of Mohan Foundation, and he chair expert committee Angdan Yojana, Government of Haryana, formerly director of Fortis Organ Retrieval and Transplant, head Armed Forces Organ Retrieval and Transplant Authority. Please, Dr. Avnish Seth, we go ahead. Thank you.
Thank you, sir. So it's a privilege to be here. I'll try to share my screen. Khula hua hai main. Can you see my screen?
Yeah. Yeah, very well. You can go ahead, please.
I don't know. Just mute.
Can you play the thing? Start. Yeah. So my topic is promoting disease donation, where to start and how it can be done. So it's a vast topic and the audience is very learned. So I'll just be touching on a few things which I feel strongly about. Let's just change the slide. So instead of starting, I would say that we are already quite up and running and we need to just pass the baton for the next few years and make it bigger and better. Because already we are doing more than 700 disease donors in a year. And this is a chart from the GODT data and showing the number of diseased organ donors. And it's very nice to see that we figure in the top 10 of the world. We may have a disease donor rate of less than 1 per million, but we do about 700 to 800 donors and Spain does 1200. So we are not very far. We just need to develop what we are already doing in a better way. So how to increase organ donation? I think there are three basic pillars on which organ donation stands: the role of the government, the public awareness, and the role of us medical community. As far as the government is concerned, the basic health infrastructure really matters. Regarding the budget allotted, I will just pass it for now because we will worry about it later. But what we have in hand, the quality of trauma care is what we need to improve in the country. We need to get air ambulances in place because we lose 1.5 lakh people on the roads every year. We have 99,000 ICU beds. Perhaps we could increase their quality and quantity. We have 47,000 ventilators before COVID happened. and 38,000 new ventilators have been added. So something good for organ donation may happen because of COVID. We have critical care specialists, which we need to be much more, and there should be a lot more training in this area. As far as transplant services are concerned, 70% are in the private sector. And we would love to see this happening more and more in the government sector. At least a kidney transplant in every state in a government hospital should happen. So let's go through this one by one. What about the government and the transplant law? So if you see on the right side, the map, we haven't really adopted the Transplantation Act in letter and spirit in quite a few of our states. And the states in green are actually the ones who are doing plenty of organ donation work. So we need to spread this to the rest of the country. Regarding the definition of death in the country, unfortunately, brain death is defined only for organ donation in India. And we have to find a way out to have a uniform diagnosis of death, which includes brain death and circulatory death, because that is one thing which concerns quite a few of our critical care specialists. Governments like Kerala and Gujarat have already taken action that if we declare brain death and the family is not willing for donation, after due counseling, we can switch off the ventilator. And that is something which other states could be looking up to. Meanwhile, what do? So while dealing with the families, don't leave the critical care people on their own to deal with them. Give them a support of the hospital administration, nursing, coordinator. They should not feel that they are dealing with families completely on their own. And also, when I was in Fortis Hospital for 10 years, we made a policy that once we start engaging with the family and we tell them that the person is no more, from that moment onwards, billing in a private hospital becomes very questionable. And if we can bear that bill for 1 or 2 days, it really, really makes a big difference in the confidence of the critical care team. So this is what we could possibly look at. Continuing in the role of the government, there are various public policy instruments, 3 of them, to change the behavior in the population. One is a change in law, by change in behavior, and by offering incentives. So let's see all 3. India has an opt-in system, and as we see on the right side, more and more countries are going for opt-out. I don't think personally, and most of us experts in the country feel that we are not yet ready for an opt-out system. We need to first spread the current system all across, get more confidence into healthcare, get more government hospitals doing organ donation. But I also feel very strongly that we should do this. We should start with opt-out for cornea donation, because that is a concept everybody would understand easily, because the heart is stopped. And once we have done opt-out for cornea or tissue donation for a few years, we could look at organ donation also. Also, organ pledging could be more meaningful, like in Israel. So if we have someone who needs an organ, possibly they should have pledged earlier to qualify for that. Or if they need an organ, some priority points could be allotted to people who have pledged to donate. In Israel, you have to have pledged 3 years before you need an organ to get any points out of it. Even if organ donation has been done, but the whole family could benefit by getting extra points if they need an organ. So we need to link our organ pledging with something more meaningful so that more and more people pledge. Public aware campaigns we have been doing for last 20 years, awareness campaigns, and I think they should continue. And incentives, let's talk about incentives, whether we should give any incentives in India for organ donation. Right now, what we are doing is basically honoring our organ donors. So in all our Fortis hospitals, we made this wall of tribute where every donor was represented by a star. We try to do other activities like an obituary in the local language of the donor. Everyone in various states is doing something like this to honor them. But the question is this enough? Can we offer some kind of incentives? So state incentives for organ donation is something we should discuss, because a lot of people feel that this could, get over some individuals who have inertia or apathy towards organ donation. The fence sitters could reconsider their options. And there is a theory which is called the Maussian gift exchange theory, which says that whatever gift we give, whether it is a gift of life or anything, it has two components, giving and receiving. And there is always a hidden obligation of a return gift whenever we give a gift to anyone. And organ donation so far is a unidirectional act, which may be incomplete. So a lot of people feel that something should be done for the donor family because they get nothing out of it. So what can we do? There are three types of incentives: direct financial, indirect financial, and non-financial. All of us will agree that direct financial are an ethical issue because it almost amounts to a sale of organs. And we could be influencing the decision-making of the poor and coercing them into organ donation. So offering money is not an option. But indirect finances are being done in a lot of countries. Tax benefits, if we can have tax benefits for donating to a charity or an NGO, why can't we have tax benefits for being an organ donor? Why can't we have discount in our annual premium for health insurance? Countries like Spain and some states in the US, like Pennsylvania, they pay for the funeral expenses. And why can't we do something like that? And in the funeral, we could provide some dignity to the departed by placing a wreath on behalf of NATO at the hospital where this happened. So we need to do more and more. Allocation policy I've already discussed. But I think the more we talk about incentives, the indirect financial incentives are a possibility for the country. Getting further after the role of government, public awareness, I think all of us do at various levels, and we should continue. And instead of celebrating just one organ donation day or one organ donation week, somehow we need to manage round the year awareness campaigns. And we had this beautiful memorial on organ donation made in Jaipur. And what we need is something like this. We spent from Fortis, when I was there, 4 crores a year for 3 years for a campaign spread, which went on and on television and on ground in so many cities. So if a lot of corporates can do something like this, I'm sure we'll have more meaningful awareness. Celebrity endorsement is very important. Film stars, we took the ex-servicemen who had been injured, cricket stars, whoever one can lay one's hand on. About religious leaders, I have to say that most of them say that they are not against donation. But what I would like to see is them holding a mic and asking people to donate. I think this is where we go wrong. Everybody says every religion is okay with donation, but that is not enough. We should actually go ahead and say that please donate. So look at these beautiful examples, the kite flying festival in Surat, Jaipur all lit up. So beautiful things we do. And we should continue to do that without expecting immediate results, because ultimately we would reach the tipping point, and at some point of time we will see results. Awareness drives don't show us, it takes generations to show results. So let's be patient on that. Let's see what we can do as a medical community. A slightly complicated figure, but if you focus in the center, this is what is happening day to day when we look at a brain death. And now just come down towards the last bit of the slide. What are the problems we face in the bottom? Failure to identify donors, failure to refer them for formal testing, suboptimal donor maintenance, family refusal. We need more experts to talk to the family. Sometimes we don't get medical legal clearance from the police, conditional directed donation. We don't have a DCD protocol in case the heart stops. So these are the issues we all need to address. So the question is, how often do we have brain death in a hospital? So this is the first study that we published from India a long time ago. And if you see this chart here, in 2000 ICU admissions, 700 odd people on ventilator, 40 brain deaths. And now look to the right lower, 29.5% of the time in patients with head injury or stroke, before the heart stopped, we could diagnose brain death. So if we actively look for brain death, we can pick up brain death in 30% of patients with head injury or stroke before they die. So this required request, which is required by the government of India to be placed outside each ICU, is not being followed in letter and spirit. And we would love to see a mechanism somehow where all critical care people get involved with this and understand that this is their baby that they need to carry forward. There are various ways of early identification of brain death that I recommend. And one of them is this. I think the Fortis hospitals where I worked for 10 years were the only chain where, if you see the right lower corner, the daily report talks about possible brain deaths, declared brain deaths, organ donors, counsel for cornea donation, cornea donation. We need to talk about these things on a daily basis to, get this promoted. Also, whenever there's an awareness event, the critical care teams need to be promoted, not the transplant surgeons, because we are talking about disease donation. Send your critical care experts for television, let them cut the ribbon for walkathons. And in return from the critical care, what we should get is they have a professional obligation to do organ donation, and organ donation should be a part of end-of-life care and not done as something which is difficult for them. We made a little score which is quite easy to use. It has 20 points on various aspects of organ donation, which each hospital should be building on. They are the best practices. I won't spend much detail on this, but this is available freely on the net. 20 points, each scored as 2, 1, and 0. So every hospital could be scored from 0 to 40. And this is what we found, that if your score is above 30, then the hospital does very well. We had 18 hospitals and one hospital did a lot of donations with a score above 30. But look at the last part. If the score was below 15, then none of the hospitals actually ended up doing a donation. So there's an objective way to assess a hospital's preparedness for disease donation. And we need to get audits and best practices in place in every hospital to make sure that this is happening. DCD donation is happening all over. And I'm happy to report that now in India also, we are making a little move. We all know that there are 5 types of DCD categories, and category 1 and 2 won't apply much to India. These are more for states which have a opt-out system. In India, category 4, which is brain death, people having a cardiac arrest is what we should be looking at, and category 5, and now category 3 also. Very recently, we have come out with a joint...
Dr. Avnish,
yes.
Kindly finish your talk in 1 minute, please.
Yes, we will do that. Yes. So we now have lots of inputs and experts, and this paper will soon be available to everybody on how to do a DCD in India. So to sum up, the difference between DBD and DCD, which everybody would possibly like to understand, that here the heart is beating, in DCD the heart has stopped. And what we have proposed for DCD, that we should have 3 doctors from the hospital and a 5-minute no-touch period when we declare a person dead, and we go ahead. But for DCD program, kidney transplant is possible in India, as shown by PGI Chandigarh and our colleagues, Dr. in Ahmedabad. But what we need for DCD is an organ care system, so that the lung, heart, liver, etc. can be put on this system. We understand how good the organ is, and only then use it for a DCD. And we look forward to some low-cost, made in India organ care systems. So to summarize, we have reasonable progress in DBD over the last 10 years. More infrastructure and transplant facilities are required to be built in government hospitals. And we need to spread the organ donation to all parts of the country. Necessary government orders by each state, like done by Kerala, Tamil Nadu, Gujarat, may be done to facilitate organ donation. But the critical care teams have to carry this program forward, and we need more in number, more trained critical care people. We may start with cornea donation after every death as an opt-out system. Awareness drives may continue, and it's time now to look at DCD in our country. So basically now, from passing the baton, before we reach the end of the race, There's lots of work to be done, but we are well on the way. Thank you, everybody.
Thank you, Dr. Avnish, for a wonderful deliberation. No questions. If there are no more questions, we can go ahead with the next session. Thank you.
We'll move to this. We're running slightly short of time, so we'll try to make up. The next session will be about the campaigning the cause of organ donation. For this session, I'd like to call upon the chairpersons, Dr. Wahid Ali Khan, consultant nephrologist from Jamshedpur, Jharkhand. And we have other chairpersons joining online, Dr. Manjuri Sharma ma'am, professor and head department of nephrology of the Guwahati Medical College. We have Dr. Sukant Das, senior consultant nephrologist of the AMRI Bhubaneswar. I'll request chairpersons to kindly introduce the speaker and carry forward the session.
Good afternoon, everyone. We are running short of the time, so we will be directly going. Fortunately, I am the only physically present here. Other two chairpersons are online, and I think the speaker is also online. This next topic, obviously, there is a big disparity between the demand and available donation of organ in India. So it's a multifactorial thing. Everyone has to contribute, including the general population and NGOs. So next topic is regarding the championing the cause of organ donation and the role of NGOs. Speaker is Ms. Lalita Raghuram, and she is country director, Mohan Foundation, Master in Social Work and Master in Hospital Management, and she is PG Diploma in Community Eye Health also. Has been the country director of Mohan Foundation for past 20 years. Was the executive director of Eye Bank Association of India for 10 years. And she started her career as an administrator of LV Prasad Eye Hospital, Hyderabad. I welcome her and I request her to start the speech.
The video. Good evening, all of you. I think I'll do it right from myself. Good evening, all of you. Some technical errors. I'm so sorry. Just getting on to my screen sharing. Yes. So today I'm going to talk to you about the champions in organ donation, the role of NGOs. I have spent my whole life working for NGOs. And as all of you know, what is an NGO? In common parlance, non-governmental organizations or NGOs are organizations that are involved in a wide range of activities that work for the society at large, especially for the economically underprivileged. On paper, in India, we have 3.3 million NGOs, and about 10,000 only are verified NGOs according to the GuideStar India, which is a credentialing agency. As far as organ donation is concerned, there are several NGOs in India. But it all started in 1993 with Narmada Kidney Foundation being established by Dr. Bharat Shah. And after that, in 1995, FORTE started, Foundation for Organ Retrieval and Transplant Education, under the leadership of Dr. Phadke. Mohan Foundation was established in 1997. So when you look at the NGOs between then and now, from the time the Transplantation of Human Organs Act was passed until now, you see so many NGOs in the country, and everyone has a certain USP. Organ India in Delhi, IOTA by the Army, OBO by the All India Institute of Medical Sciences, FORT under the leadership of Dr. Seth, and Bhopal Organ Donation Society, Muskan, Shine India Foundation, all of these, which is the most recent one, Manipal Organ Sharing and Transplant. In the South India, several organizations working in different areas of organ donation. In the East, we have Ganadarpan, Mother, and Zubli Foundation, which is there in Assam and Arunachal Pradesh. In West, like I mentioned, Narmada Kidney Foundation, Donate Life in Surat is doing very good work. Amar Gandhi Foundation, Transplant Help the Poor Foundation are some of them. Narmada Kidney Foundation has spearheaded the transplant games very well. And Fortis Hospital has the wall of tribute for the organ donors. Zubli Foundation is working for, pictures are coming? I'm not getting, okay. So, the Zubli Foundation is working in Guwahati and Arunachal Pradesh. Recently, the governor of Arunachal Pradesh pledged for organ donation. Now comes Mohan Foundation. Mohan Foundation was started in 1997 as a registered charitable trust by Dr. Sunil Shroff, our managing trustee, Dr. Georgie Abraham, all of you know as the senior nephrologist, Dr. Parthasarathi, who is the pro-chancellor and professor emeritus of the Ramchandra Medical University. Well, we have been engaged with a lot of presentations, public education programs among the cross-section of the population. We have made thousands of presentations all over the country. And we also have a special module where we have for police, you know, because 60% of our organ donors are road traffic accident victims and the police has to be involved in this. So we have a training module for police and we have trained more than 12,000 police personnel across the country. And we have initiated several student initiatives. We have a program called Organ Donation Ambassador Program, which is an online program. And we have students, teachers, and several NGOs that are part of this Organ Donation Ambassador Program, and thousands of them have been trained. And some of them have actually started NGOs by themselves to spread the message about organ donation. We have had flash mobs by students, and they have taken great interest and produced flash mobs. We have conducted short film competitions all over the country, and we have several short films which you can find on our website. We have, every year we do walkathons and marathons, and we have, like Dr. Seth said, have several celebrity endorsements. Several celebrities have endorsed for organ donation and have spoken about organ donation in public forum. And every year we also have organ donor family felicitation programs. We normally have it with the governor. Yeah, with the, I don't know why we are not getting the pictures. Yeah.
Try switching to this.
Yeah. Stop. Let me see. Are you all able to see my picture slides?
No, ma'am.
Can I have your response, please?
No, ma'am, we are not.
This is scratching.
We're not able to see any pictures, ma'am.
Yeah, the slides are there, but we don't see anything.
In your full screen, you can't see anything. You can start it quickly.
Just give me a minute. I'm continuing. Yeah. I'm using Dr. Seth's laptop, so I request the IT people to also allow me to use my video. Again, I'm not able to see here. Yeah.
This one is your PPT. That's the one.
Yeah. So I spoke about student initiatives. Yeah, flash mobs and like the short films that I mentioned, and also the walkathons and marathons, celebrity endorsements, organ donor family felicitation programs. And we have been very innovative also. Prominent monuments in the country like the Qutub Minar, the Mumbai CST station, all of these have been, they were lit into green to signify the message about organ donation. Monuments in Jaipur were also lit into green. And for the first time in the country, we have this Angadata Smarak in Jaipur. It's a donor memorial, a first of its kind in the country. And all the names of the organ donors of Rajasthan are engraved in this donor memorial. And this is in the middle of Jaipur and has become a tourist spot. And this is an exhibition, and these organs are made from the human ashes mixed with mud and made in the form of a heart, kidney, liver, and eyes to signify that we want to drive home the point that the organs have been wasted. If these have become human ashes, only if these organs were allowed to be donated. So these exhibitions were carried all over the country, and it got very, very good response and got several awards. We are also having an organ donation helpline, responded in 8 languages. In fact, this helpline works around the clock, and we have done several eye donations and organ donations. In fact, we did one organ donation in Dubai also, because the family contacted us on the helpline, and we've been able to coordinate organ donation through this helpline. We also have a very new initiative, which is about a year old, which is called Anudan, making transplants affordable. We are helping the economically underprivileged transplant patients by part funding their transplant. So far, we have helped more than 20 patients, as most of them being young children. The first one was Aradhya, who is a 6-year-old who underwent a liver transplant 1 year ago. She's leading absolutely normal lives. So we have been supporting through the funding that we have received from several donors, economically underprivileged patients through Anudan program. At Mohan Foundation, we always believe in partnership. Partnership and collaboration is what will take us to greater heights. And NOTO, we partner with NOTO and several government, several state governments, right from government of Tamil Nadu to government of Andhra Pradesh. We have memorandum of understanding. We also have with private institutions and corporates, the collaborations. Internationally also, we have collaboration with NHSBT, the Gift of Life Institute in Philadelphia, and other institutions. We are also the United Nations consultative. We have the status, consultative status under the ECOSOC, UN ECOSOC. We are also part of the Commonwealth Tribute to Life, where the best practices are shared among 54 Commonwealth nations. And Dr. Shroff is the Asia Regional Director. So the impact of our work, this year we celebrate 25 years. We have touched more than 25 million people through our public education program, through our transplant coordinators program, through our intensivist program and surgeons programs. We have trained more than 34,900 healthcare professionals. As I said, I make this presentation. I'm actually making this presentation from Manipal Hospital in Delhi. We did our 70th transplant coordinators training program, and we have trained more than 3,000 transplant coordinators so far. And more than 70% of the deceased organ donations that have been effected in this country are through the transplant coordinators trained by Mohan Foundation. And all of this has been achieved only because of the partnership and the support that we have received from every well-meaning citizen, corporates, funding agencies, government of India, NOTO, SOTO, all of you, all the professionals. And we have a long way to go. We have touched about 1,000 organ donations so far. With everyone's support, I'm sure we will be able to save several millions of lives by the gift of organ donation. Thank you all so much.
Thank you, Ms. Lalita, for a nice and very informative lecture. Our co-chairperson, Professor Manjuri Sharma, is there. I'd like to have a few words with us.
Can't hear him. Okay, shall we leave?
Dr. Santu Das.
Are there any?
Yes, Dr. Y, thank you very much. And thank you, Madam Lalita, for such an excellent presentation. I believe I have a slight different take on this entire issue. I do appreciate the wonderful euphoria, enthusiasm, and excitement we have in related to cadaveric transplantations. But as spoken by the distinguished speaker before this session, Dr. Avnish Sheth, and Madam, you yourself have a lot of experience in the field of cadaveric transplantation. But in last 15 years of my working in the field of nephrology, I haven't seen the least amount of botheration, least amount of consideration or kindness being extended to live donors. It's wonderful that we have a lot of sympathy for the family members of cadaveric donors, but a live donor at the age of 20 or 30 is giving a donation of a kidney. Are we really doing enough for them? It's okay, we do not extend direct cash transfer, but there has to be some provision of giving them some sort of insurance benefit, some sort of reservation in jobs for them and for their children, so that certain kind of security in their life has to be done. So essentially, thinking about the demographics of this country, we have a 1.54 billion population. So not today, not 5 years from now, not 10 years from now, cadaver transplantation is not going to solve the overwhelming organ shortage of India. We have to think out of the box, do something, take the legal provisions, take the experts from various quarters, and of course, you yourself included. We have to do something for live donors in a legal way so that more and more organ donation can be encouraged. Thank you.
Thank you, Shukran, for the nice idea. Obviously, a lot has been done, a lot has to be done. There's always we have the opportunities to move forward. Dr. Manjuri Sharma, your take on this?
Thank you, Lalita ma'am, for your very good presentation. Mohan Foundation is the pioneer in disease organ donation, right? And I hope your voice is heard in every nook and corner of the country so that we can go ahead with disease donation program. In my part of the country, yes, we are lacking behind in disease organ donation. So in the future, I may require some of your suggestions and advice to start off with the disease organ donation over here. And I also do agree with Dr. Sukant. Yes, we should do something for the organ donation, both donors, both live and disease, so that, we can, there's a lot of controversy right now over the live donation in certain parts of the country. So we have to legalize donation actually.
Where are you from, Dr. Mayuri Sharma? Where are you?
I'm from Assam, Guwahati, ma'am.
Okay.
Yeah.
Certainly, we are always there. We would certainly like to work with you. We'll definitely collaborate, Dr. Sharma.
Thank you, and thank you for your thought-provoking presentation.
Thank you, Dr. Lalita, Ms. Lalita. And thanks a lot, all of you, for a peaceful hearing. Because of the short of time, we won't be taking any question. And with this, we end this session. Thank you.
Thank you so much.
Thank you, Chairpersons, for this excellent session. Moving to the next session. Again, this is a purely virtual session. So this COVID has shown us some very new ideas where the audience is real, but the presentation and chairperson, everything is virtual. So for the next session, the chairpersons are Dr. Professor K.L. Gupta, sir, former professor and head Department of Nephrology of PGI Chandigarh. We have Dr. Professor Amit Gupta, sir, former professor and head department of nephrology, SGPGI Lucknow, and currently the senior consultant nephrologist, Apollo Hospitals, Lucknow. And we have Dr. Jigar Sharmali, consultant nephrologist, Shalby Hospital, Ahmedabad. I'd request Amit Gupta, sir, or the chairpersons to kindly introduce the speaker and then carry forward the session.
Hello, yes, I would like to thank.
Yes, sir, you are audible.
I'm Dr. K. Gupta here. I'm audible? Okay. I would like to thank the organizing committee, Dr. Om Kumar, Dr. Amrish, and Dr. Harsh, as well as the scientific committee to have given us an opportunity to come and chair this session. I wish I was personally there to listen to the excellent talks since morning. It has been wonderful. On behalf of my co-chairperson, Dr. Amit and Dr. Jigar Sharmali, I would like to welcome you. And first, I'd like to introduce Dr. Rajesh Nair. He's professor and head of nephrology and transplantation at the Amrita Institute of Medicine, Kochi. He has been the co-organizers of the ISOT 2021. And he has a lot of interest in the areas of transplantation, bronchonephritis, and dialysis, and is published widely. Over to you, Dr. Rajesh. You are going to talk to us on a topic very interesting. This morning we have been hearing about the brain death, the deceased donor transplantation, and all that. And now he's going to talk on setting up a deceased donor transplant in a new state. I would say we should not have state. We should make a new center or a new district. States, there are in 29 states, no new state is going to come. I mean, we have to, how to develop, and Dr. Rajesh has done good work in his own area in Kochi as well as the contributed state of Kerala. I'm sure he will tell us how to set up the program. But it was wonderful listening to different talks since morning, right from the brain death definition and the last talk and the Mohan Foundation. Wonderful job you're doing. Dr. Amit, you want to say anything?
No, I think this is a very important area that essentially because deceased donor organ transplantation in many parts of our country have not yet developed, particularly in a state like UP. And Rajesh can help us in telling us how one can achieve that, and one can do that where the role of both the government and the private hospitals can be are extremely important. So over to you, Rajesh, and then we'll have questions at the end.
Good evening, one and all. Am I audible?
Yes, yes.
Shall I share my screen now? Is it visible now?
Screen not visible yet.
Is it visible now?
Oh, yes, okay. Put on the slideshow.
Yes.
Okay.
Thank you, Gupta sir and Dr. Amit Gupta sir for that kind introduction. Yes, we have had an overwhelming information regarding the various aspects of cadaver transplant. I will probably try to highlight what was the picture in Kerala in the last maybe 10 years or so. So, following the path-breaking GO from the Tamil Nadu government, the cadaver transplant in the south actually has actually skyrocketed. The disease donation rate went up to almost 4 times in the last 6 years, from maybe in the last 2012 to 17. You can see the chart showing the upward going, steadily upward going graphs of the kidney transplant is concerned. But unfortunately, as we know, the deceased donation program has been very active only in the southern states and the western states, and of late it is coming up in a big way in the eastern states also. So what are the issues and challenges we face while starting up a deceased donor program? Of course, the high burden demand versus supply does not require much discussion now. Poor infrastructure in the government sector hospital is really an issue. Lack of awareness of the brainstem concept, even among the stakeholders, poor rate of brainstem certification by the hospitals, poor awareness and attitudes towards organ donation, and lack of organized systems for organ procurement, along with prevention and control of organ trading. That is also an issue, and high cost, especially for uninsured or poor patients. So what are the steps in this order? First, I will probably look at the resource allocation. It is very important to understand that the public sector hospitals need to consider allocating greater resources
to the organ transplantation, so that the transplant happens smoothly in an affordable fashion in the government setup. So unless the transplants are happening regularly, I mean deceased organ donor transplants are happening regularly in the public sector, there is always an issue of trust. There is always a feeling among the public. There's something happening in the private hospital, but not happening regularly in the public hospital is likely to be unethical. This is a very, very glaring issue which, as Keralites, we have faced in the last 10 years. This is a very important thing. So, commencement of organ transplant programs in the public sector would definitely help to promote and facilitate the deceased donor program. Of course, we need to have well-equipped ICUs with ventilator support, organized critical care, dedicated ICU team, donor maintenance till organ harvesting takes place. So this is the GO which has been issued by the government of Kerala in 2012, where they kick-started the program of cadaver transplant way back in 2012. This actually has clearly laid down the criteria and the ways to go ahead with the brain death declaration. That means we need, as discussed early in the earlier sessions, we need 4 doctors, as highlighted here, with 6 hours interval, two examinations to confirm that patient is brain dead. And following this order, a lot of enthusiasm for brain death declaration happened all over the state. But the issue is that following then there is some issue at around 2018. There is the robustness of testing of brainstem death has been challenged in Kerala in the High Court. That means there is an issue raised that probably there is the brain deaths are being declared prematurely. There is a lot of confusion, and even the government went to the extent of putting forward a GO telling that you should videograph the brainstem declaration testing process, actually which is unnecessary and which is cumbersome. So such a thing happened in Kerala, and actually the latest GO actually has done amends, and this is the path-breaking GO which has been discussed far and wide in the last maybe so many hours. The set guidelines confirm that brain death declaration has to be mandatorily done by all the government and private hospitals, and this has to be irrespective of whether there is a question for organ donation or not. So even if you are not considering an organ donation, we have to early find out a person who is brain dead, and probably the brain death declaration has to be done. Now the question is, if the patient is willing for brain death organ donation after brain death declaration, it is easy. But we have declared brain death and the patient is not willing for organ donation, what do we do? There is no clarity so far as even in the latest acts as to what to be done for that. But this GO clearly says that the termination of care can be done if the patient is practically, clinically, and legally brain dead. So the brain death declaration has to be done mandatorily in all hospitals. So this is a very important step actually, which has actually given a revival to the Mrida Sanjeevana, the cadaver program in Kerala. This has already been discussed. The non-transplant organ retrieval centers. This has to be promoted in a big way, because a lot of brain deaths happen in peripheral hospitals where there are operation theaters and ICUs. The government should come forward and probably certify or register these hospitals as non-transplant organ retrieving centers, so that the organ donor pool can be improved. And this has actually given a significant impetus, especially in central Kerala, to improve the donor pool. Now, this is the network of this is the website of Kerala Network of Organ Sharing, otherwise called Mrida Sanjeevani. You can see the donors. There are close to 1,000 transplants has been undertaken in the last close to 10 years, and you can see the wait list statistics of the kidneys here, the approved hospital for transplant, the various GOs, the various amendments, and as we all know, the waiting list starts in a kidney patient when the patient is started on dialysis. That is how it is. And for convenience, this since our state is a small state, we have actually the KNOS, the Kerala Network of Organ Sharing, has divided the state into 3 zones: the north zone, the central zone, and the south zone. The advantage of this, that actually, it is very important to understand, when you start a program, let's not be over ambitious. Probably you need to share within a local area, so that the advantage of Kerala is that each zones can be from one end to other can be covered in a matter of few hours. So it is better to have a local sharing, and if the local sharing is not working, then go ahead and you can cross the zone. So usually the zone is not crossed unless there is an issue. You can, even if you cross the zone from one end of Kerala to reach the other end, it may take maybe 8 to 9 hours by road. So this is what has worked out advantages for Kerala. And now coming to organ sharing, as I told, there are 3 zones. So the retrieving hospital always gets 1 kidney, heart and liver if they have the recipient, and the other kidney goes to the common pool. Especially, it is very important in the respective zone, so that the transport logistics can be well arranged and there is a minimum delay in transporting the organ. The next organ, there are 2 kidneys. The second kidney goes to the government hospital within the zone. That is something which has raised some eyebrows. That is actually creating some problems of late. I will come to that. And if there is no organ taker there, then you go to combined private hospital list again within the zone. That hospital will get the priority. If the organ is retrieved from a non-transplant center, then all the organs will come to the common pool. So that is how the sharing is. So 1 kidney goes to the retrieving hospital, but the other kidney compulsorily goes to the government hospital in that zone. So I'm not going into the details of the matching and all, but these were the issues which we have encountered in our program. Because see, there is a significant displeasure from the hospitals that gives more organs and receive less from the other participant hospitals. That is not a very viable option to maintain a program in a smooth way. So that is very important. It should be give and take. This should not be take alone. So it should be give and take, and it should be an equitable distribution between private and public hospitals. That is very, very important. Retrieving, sharing marginal, expanded criteria donors. Probably see a patient who has a terminal creatinine of 2. The participating hospital who is supposed to get the organ may not be keen to take the organ. The recipient who is called in, the recipient may decline, telling that there is an issue with the organ already. So the organ may again, there will be a significant delay in making a decision if there is an expanded criteria donors. So these are all certain things which probably we can look into to probably put down certain guidelines so that the organ allocation will be easy. And timely alert is very important. All the transplant coordinators in the zones and the areas should be alerted. Data should be honest, and there should be simultaneous communication of the participating hospitals. There should not be any delay, because there should not be any concern that telling that, okay, I was informed, this hospital was not informed, and we were informed a few hours later, so we couldn't call the recipient on time. So this is very important. Timely alert, honest data sharing, and simultaneous communication of the participant authorities is very crucial. Then lack of uniformity in the process and method of retrieval. Actually, this has been solved to a significant extent. And the last and but not the least, cost sharing. Cost sharing, of course, the recipient family, the hospital has to share the cost, and there can be some delay in settling the bills between the sharing hospitals. These are all administrative losses which can be sorted out. So these are the problems which are likely to creep up when the program is kick-started and is underway. Now let us look at the issue which I have highlighted. Look at the organ donation activity in Kerala in the last 4 years. You can see the 5 medical colleges there. Predominantly doing the 4 medical colleges there, predominantly doing cadaver disease transplant, starting from south to north. You look at the donation from 2018 to 2021. It's hard, very high. It's only a handful. Look at the transplants they have done. Actually, it is significantly high. That means the government hospitals are basically going ahead as takers, not givers. So this is an issue which has produced significant displeasure, which has to be solved over a period of time. Now, again, you look at the last 10 years of the cadaver transplant program which has happened. Donor from the government hospitals, it is 39, whereas the donor from the private hospitals is a whopping 290. So it's a huge gap. So what is happening? Is there an infrastructure issue? Are there enough support staff to declare blind death? Is there a complacency or a lack of enthusiasm? All this has to be clearly looked into so that we can increase the donor pool from the public sector. Unless the donor pool from the public sector improves, the cadaver program can't go ahead in an active and a smooth fashion with significant public trust. Public trust occurs only if the program happens in private and public sector simultaneously in almost the same fashion. Now look at this. Again, I'm just highlighting the generated donors in the medical colleges on the left side and the transplants they have done on the right side. Again, there's a huge gap between the generation they have done and the transplants finally they have done. So yes, it is a success story from our state, but there are a lot of ifs and buts which need to be tackled over a period of time. So this movie, I think this has been remade in probably almost all languages. This actually based on a true event in Tamil Nadu, where an ambulance driver took the challenge of taking the organ across braving all the traffic. And this has been picturized in the movie. And this actually movie gave significant impact or significant positive boost to the cadaver program once we started the program. Now, what are the suggestions from our model? It is always better to have a transplant procurement manager. This is actually the Spain model, the deceased organ transplant, the Spanish model. We have collaborated with them. The KNOs have collaborated with them, and the transplant procurement managers are basically healthcare professionals, and they are mostly ICU doctors who dedicate their part-time to deceased donation process, and they can monitor and follow up a possible brain donor, carry out all the clinical and non-clinical tasks relating to converting the deceased donors into actual donors. And this can be a organ donation unit. So organ donation unit can function in private and public hospitals, and it will be headed by a transplant procurement manager. And transplant procurement manager is composed of nobody else, ICU doctors, nurses, the transplant counselors, and with clear-cut roles and responsibilities within the donation process. So I understand that if more and more TPMs and more ODUs are being trained and are utilized for the purpose, the organ pool goes up. So just to share the data from my hospital, Amrita Institute of Medical Sciences. Actually, you can look at since 2004 to 2012, we have done few transplants. The whole credit I would like to place on record the contribution from an NGO, Society of Organ Retrieval and Transplant, called ISOT. They helped. It is working in Cochin. And we could do close to around 8 to 10 transplants till 2009-2011 time with the help of ISOT. Following that, the government of Kerala launched the KNOS, the Kerala Network of Organ Sharing, and then the process of zones, the zonal allocation, the private-public partnership all came into the picture. The picture down there shows the hand transplants done, because we are the first to do hand transplants in India. And these are the first 3 recipients who underwent the hand transplant in our hospital. A few multi-organ transplants, SPKs, simultaneous liver kidney transplant, and we had one done simultaneous heart kidney transplant also. So all this need, especially multi-organ transplants, needs a lot of coordination between the ICU staff, doctors, nurses, transport logistics. All these need to be looked into. So just a flow chart. Once there is a donor detection, there is a potential brain dead donor. You have to confirm it. It is mandatory. It is better to. I think the other government, the states, other state governments should come up with GOs telling that, insisting that probably brain death has to be mandatorily declared, and the termination of care can be done even if the patient is not willing for organ donation. And after that, the option should discuss with the family. And if they are willing for organ donation, yes, go ahead. If they are not, then probably think of termination of care. And then the public misconception, the issues relating social and cultural beliefs, all I'm not going to the details, has to be taken care of. The transplant counselor or the grief counselor will be able to take care of that. Organ donation consent is obtained. Then again, the donor evaluation and maintenance again by the TPM team. Allocation is of course done by the KNOs. Priority by waiting list. Of course, very important, equitable sharing between public and private hospitals. I've already emphasized. Organ retrieval and transport has to be uniformly streamlined, and mortal remains handed over to the family. This is very important. A grieving family, we should not delay the funeral. So that has to be clearly taken care of, because that adds a lot to the emotional content. So the mortal remains has to be handed over to the family on time for the funeral. So just to summarize what I have told, a well-coordinated public-private interface is very important for any deceased organ transplant program to be viable. Having good trauma centers in private sector and public sector with very good ICU facility, so that the conversion to from a potential donor to an actual donor is possible. I emphasize both in public and private sectors. Brain death declaration has to be mandatory and has to be delinked from organ donation. That is very important. Capacity building and training of ICU doctors, nurses for early identification of brain death is very important for proper certification, and training of transplant coordinators, and they should be aware of the issues, the cultural values of the region, and they should be able to speak local language. In India, the conversion rate of a trained coordinators is close to 65%, thanks to all the groups, including Mohan Foundation, for taking the responsibility of training the transplant coordinators. The suggestion of a hospital-based organ procurement with transplant procurement managers and organ donation units, and local networking organization under government acting as public-private provider interface. It should interface between public and private, ensuring significant transparency and equitable organ allocation between public and private hospitals. It should be a give and take strategy. It is very important. It is not take strategy alone. transparency and public trust is absolutely crucial. It is very, very important. I am re-emphasizing that, because if the public trust is lost, then the program is going to nosedive. Then, of course, public education, organ donation, donor cards, social media, movies, and television. We had actually recently a few movies. Actually, we have given negative messages against cadaver transplant. But it is very important to understand that you should have expert committees and SOPs for use of marginal donors. Marginal donors is also an issue, whether to take or not, whether to discard the organ. That is always creates a confusion sometimes. International collaboration with various groups and auditing of the process is very important, so that there is a clarity and there's a transparency of the data and the registry at regular intervals. I think that is my last slide. Thank you very much. And I will acknowledge the nodal officer and coordinators of KNOS and my transplant coordinator in my hospital. Thank you very much.
Thank you, Dr. Rajesh, for wonderfully highlighting the Kerala model of deceased donor program. It has been a great success story. And I was particularly enamored by the description of that government order compulsorily going brain death. Actually, that I think takes a lot of worries about away from the prospective donors' attendance, because whenever we pose a question, well, we suggest such problem, they will think twice whether to allow it or not. If it is already known the person is brain dead, then it will make decision much easier. And of course, there are many other positive things. Dr. Amit, you want to give comments and answer any questions, although we are in short of time?
I think Dr. Rajesh has done an excellent job in sort of covering most of the aspects.
I have to move to the extreme right, otherwise I can't see.
I think what the point that you made is extremely important, that the government hospitals and the private sector hospitals have to work hand in hand. And there should not be a feeling of competition, and there should be a feeling of trust between one another. The other problem is that, as you rightly pointed out, that the organ retrieval from many government hospitals is much less as compared to the corporate or the private sector hospitals. And that is because of a general sense of apathy which exists among many of our people working there, who are actually required to sort of initiate the process of organ donation. So I think there's a long way to go, and we need to work together, and particularly in states where deceased donor organ transplantation has not started in a big way, like a state like ours in UP. We have an extremely poor record of deceased donor organ transplantation. The other thing is to try and convince the public to agree to donate organs, which is also a difficult process. But hopefully over the years, we'll have an improvement in our organ donation rates. I'll ask my third co-chair to sort of make his comments, please.
Actually, in Gujarat, what we have seen that initially when we were going to government hospital for the organ retrieval, the patient were not in good state. They were remaining for a long time in hypertension. So by that way, the rise of creatinine and many more issues were. Over a period of time, what we did, we communicated our intensivist colleagues, and annually, whenever their conferences were there, in their workshops, one more workshop was added, and that was how to manage organ donors in a state when they are brain dead. So once this was added, it improved a lot over a period of time, the organ quality when it was harvested. So, and by that way, again, as they are intensive and they are remaining in the ICU round the clock, one more thing was done, and they were sensitized as far as the organ donation part. So that helped. So that was one thing.
Thank
to be added.
Thank you, sir.
I think we are already running late. We can hand over the session back to organizers for the next session. Thank you.
Thank you very much to the organizers for having us part of this program. Thank you very much.
Thank you. Thank you very much, sir. Thank you very much.
Thank you so much, sir. Thank you, chairpersons. So after the Kerala talk, how can Tamil Nadu be behind? So we will be having the next talk from Tamil Nadu. For this talk, the chairpersons will be Dr. Bharat Sahasar, who is the Director, Global Hospitals, Mumbai. We will have Dr. Vijay Sinha, sir, Senior Consultant Nephrologist and Additional Director Nephrology in JP Hospital, Noida. And Dr. Rajesh Kumar, sir. Sir is the Faculty in Nephrology at Safdarjung Hospital, New Delhi. I'll request chairpersons to kindly introduce our star speaker.
Thank you, organizing committee, for inviting us. Dr. Jorvi Abraham does not need an introduction. He is one of the stalwarts of nephrology in the country. He is professor and consultant, MGM Hospital, Chennai, adjunct professor, IIT Madras, founder trustee, Tanker Foundation, and president-elect ISOT. So I invite sir to start his talk.
Yes. Good afternoon, respected chairpersons and esteemed colleagues. At the outset, I want to thank the midterm ISOT organizers for giving me this opportunity. This is the hospital where I work, and this is the hospital where I work now. And here we do heart and lung transplant, liver transplant, and also kidney transplantation as a part of our transplant team. Yeah, I just want to show you the chronic kidney disease and cardiovascular disease in 6 regions of the world, a cross-sectional study. So in India, when you look at that, 17.2% of our people, general population, do have chronic kidney disease. And we all know that chronic kidney disease is a progressive disease, but many of them die before they reach end stage or during end stage without dialysis or transplantation as a result of cardiovascular disease and sepsis. And this is the chronic kidney disease registry of India. The most common cause of chronic kidney disease and end-stage renal failure is diabetic nephropathy. So cadaver donor sources, our experience since 1996, most of them are road traffic accident victims, stroke and intracranial bleed, partial hanging. Poison donors, they included cobra bite victim and suicidal and accidental poisoning, as it is portrayed in the slide as cartoons. This is I just want you to bring to your notice that in December 1995, the first multi-organ disease donation was carried out in Chennai at the Madras Medical Mission Hospital, where I was a nephrologist, where a 40-year-old road traffic accident victim donated his heart and kidneys to 3 prospective recipients. The media, which positively carried this report, facilitated further organ donation in the country, where the standard practice was live donation. So long-term outcomes of using deceased donor kidneys from cobra bite victims. This was published in Transplant in 2010. And you can see the 4 donors. And Dr. Sunil Shah, who is the current president, was involved in the transplant, retrieval of organs and transplantation. And all these organs were retrieved from the private medical college at Sri Ramachandra Medical College. One of the, I'm not sure about whether this lady is still alive, but the last count shows that 22 years after receiving kidney from a cobra bite victim, she was still alive and being followed up Madras Medical College with few immunosuppressive medication. So when you look at this map of the globe, you can see that the number of snake envenomation per year, less than 1,000, 1,001 to 10,000, 10,000 to 100,000, over 100,000. And we can see that we are in the dark area, suggesting that we have a high burden of envenomation, and these kidneys are not harvested and used because cobra bite affects the heart and the CNS, not the kidneys. So infectious disease considerations in disease donor transplantation, hepatitis B and C, CMV, IgG, and IgM. EB virus, recently, about a year ago, we transplanted a lady with who had EB virus negative, both mother the mother had EB virus positive, the daughter did not have EB virus positive, and she was not injected. And later on, we had to do an injection, and she developed an EB virus related neoplasm in the brain. So other viruses are, other infections are syphilis, toxoplasma, bacteriology, and donor sepsis has to be taken into account, especially tuberculosis in the donor, fungal infection, and poison as a cause of donor death, such as rabies. 2 people have died in Germany after receiving organs from a donor. infected with rabies in North India, and she went back to Germany and she developed brain death, not knowing what was the cause of brain death, and the organs were transplanted, and the patients and the recipients died within a week from rabies. Now, economics of transplantation, because Dr. Rajesh has given a very lucid presentation, and there are so many commonalities in both our presentations. I'm happy that I don't have to go in detail. The first is finances, costs versus charges, in private as well as in government. Then the economics of end-stage kidney disease, hemodialysis, peritoneal dialysis, transplantation, live versus disease, and the cost of immunosuppressive. In the government setup in Tamil Nadu, all these are covered by the government, and the patients do not have to pay any cost, or it is all free. Whereas in the private hospitals, because we had a second transplant in one of our patients about a week ago, and it was done in a private hospital. He was registered in that, so he had to bear the cost of transplant. So this has to be taken into consideration when you call a recipient for a transplant. They have to come upfront with the money if it is a private institution. Now, phases of transplantation include transplant, then early acute rejection, late rejection, and chronic rejection. So you need to have, do we give induction therapy? Yes, in the government hospitals in Tamil Nadu, they have the freedom to use induction therapy depending upon their own discretion, and early intense phase of immunosuppression, and all three main immunosuppressive agents are available in Tamil Nadu, the government sector, including the prednisolone, tacrolimus, and also mycophenolate mofetil. And the next is the maintenance immunosuppression. If they don't maintain their immunosuppressive medication, they can develop late rejection, and we lower the dose of immunosuppression even in deceased donor transplantation. And chronic rejection may set in any time, and biopsies are necessary for diagnosis of chronic rejections. Now, I will skip that. So the 1994 to 2011. So 1994, 1995, 28, 2011, and we have a country with 780 languages and 66 different scripts. So when you look at the ethnic groups and languages, we can see that there is a gross diversity in our country. Now, TransTran came into, so it was thought that there should be an authority and public-private partnership. There are a number of bureaucrats who took an active step in forming the TransTran, and also including Dr. Amol Pavanathan, who was a transplant and vascular surgeon at the Madras Medical. The Transplant Authority of Tamil Nadu cadaver transplant program started by GO number 287, dated 5/9/2008. TransTran started by the GO number 2396, dated 12/12/14, and also established regional organ and tissue transplantation ROTO and state organ and tissue transplantation SOTO. So this was the beginning, and after that, I'm not going into all the government GOs because it won't interest you at all. This is just some of them are by us about the Tamil Nadu program and how it can be made practical. So overcoming the challenge in deceased donor transplantation. This slide was given to me by our current president, Dr. Sunil Shah. You have a state health department, you have government hospitals, you have private hospitals, and the public at large, and the NGOs. They are the Mohan Foundation and Tanker Foundation, and I am also a trustee of Mohan Foundation, which is doing an enormous and immensely popular work in the country. The core components of deceased donor transplantation are medical, legal and ethical, grief counseling, and transplant coordination. Here, the health secretary, the current health secretary of Tamil Nadu, and myself are there at the Mohan Foundation function, where this girl who has received a heart has become a transplant coordinator, and the Mohan Foundation certificate is being given to this particular young lady. Now, total number of deceased donors from 2015 to 2020 in Tamil Nadu, it is shown in the bar graphs. So it shows on the vertical axis 0 to 800, and in the horizontal axis the states. So Tamil Nadu, Maharashtra, Telangana, Kerala, Karnataka, Andhra Pradesh, Pondicherry, and Rajasthan. So you can see that Tamil Nadu is much ahead of all the states in the country. I think this was due to the leadership and the robust support given by the government as well as the public, the private, and also the Mohan Foundation. So disease donor transplantation in Tamil Nadu, the blue graph or the blue bars show total donors from 2015 to 2020. And these are the transplant surgeries done, including all organs. You can see that 861, 10, 18, 185 are the donors. And here it is 2,760 donors and 900 transplant. In 2018, 140 donors and 845 transplants. In 2019, 127 and 768. So COVID had a major impact on organ donation for DD transplantation, as you can see here. We all know that now the momentum is picking up, and I'm sure that we will reach probably peak in the next couple of years. So this graph has been shown by Dr. Rajesh again, by Dr. Sunil Shah, 25 years of transplantation, low in India, progress and the way forward. And the red shows the Tamil Nadu, and then kidney, this is mainly the kidney, and then the deceased donor, other deceased donor organs like liver, heart, and lung. And so there is a steep increase in kidney donations and kidney transplantation. And we all know for sure kidney is much in demand compared to other organs. So I want to pay my tributes to Professor Amal J. Pavanathan, who was the Institute of Vascular Surgery, former member secretary, Transplant. And then functions of Transplant were general body to take all key decisions. They are both public and private, executive committee to oversee proper running of the program, a general body to meet at least once annually, and the executive committee to meet more frequently, organ subcommittees to meet regularly. So well-developed medical infrastructure, live transplants already an established renal replacement therapy in many parts of Tamil Nadu, government keen to stop organ commerce, a determined hospital and the special secretary, Mr. Dravidar. He was he's retired now, he was an IAS officer. And then NGOs like Tanker Foundation and Mohan Foundation, NNOs already working towards organ sharing, and the Hitendran effect. I'm sure that Lalita's son, who is late Hitendran. Way forward is keep your structure small and simple. The team must be focused and knowledgeable. Less money and less person, better. Constant interaction with the stakeholders. No structure can survive without internal democracy. Always be responsive to the needs of the population and avoid rigidity and bureaucracy and be flexible. So I just picked up this from Dr. Gopalakrishnan's Madras Medical College transparency in talking about the deceased donor donation. And this is published in Indian Journal of Transplantation. I think I wrote an editorial for that. So they have patients who had delayed graft function and also early graft function. And this is patient survival with the early graft function. This is the patient survival with the delayed graft function. As you can see that the graph is widening. And the graft survival is also shown here. This is with early graft function, and this is with delayed graft function. So this should be taken into consideration. And we need to look at very clearly what can be done to improve this, even if you have delayed graft function. So contrary to what Rajesh said, the top donations in Tamil Nadu are the government hospitals, Professor N. Gopalakrishnan, Madras Medical College, you can see him, and Professor Edwin Fernando in Stanley Medical College, and Professor Arul in So just across the border, in Kerala, it is mainly in private hospitals, but in Tamil Nadu, it is mainly in government hospitals. They are the toppers in disease donation. So achievements of Transplant: first state in the country to streamline organ allocation, first state in the country to clarify medico-legal procedures related to organ donation and brain dead donors, first state to undertake many combined transplants like pancreas, kidney, liver, kidney, heart and lungs, etc. First state to play an advisory role for many states and GOI, Government of India. GOI is Government of India. Almost all states and even the Government of India have replicated the GOs of Tamil Nadu. First state to have won the Best State Award in organ donation and transplantation 6 times in a row from the Government of India. And the first state in the country to collect and analyze 10 years post-transplant data, transplant recipients periodically, and from transplant hospital. So I want you to take this to reflection of what we did in 1997 at the Indian Society of Organ Transplant meeting in Ramachandra Medical College. And Dr. Sunil Shaw, you can see the young, handsome man. And some of these are my students. And this is Dr. Russ and also myself there. We started donating, we started giving the donor card for the patient and inauguration of the ED donor card in India, ISOT in Mohan Foundation. And you can see Professor Saunarajan here. He was my colleague, and we were planting a seed there. And over 25 years, this seed has grown into a tree, and the cadaver donation program has also gone into a tree with branches. So road traffic accidents, death in Tamil Nadu up by 42% compared to 2.9 as private vehicle prices. Indian statistics, 1% of the world automobiles, 6% of the road traffic accidents in the world, 17% of the world population, and you have to put the numbers there, 140,000 or even more than that. These are my, and you can see the Tamil Nadu in 2021, there were 14,912 deaths due to road traffic accidents. So if we utilize at least 50% of that, and we should be able to cover our needs and also surrounding states. These are the publications by us in major journals, along with my colleagues about disease donor transplantation. So this is a textbook which I edited, lessons learned, disease donor transplantation, and also the management of malnutrition in transplant patients. And this is a handbook of renal transplantation developing country, which we published about a year ago by Oxford Clinical Practice. So I would like to conclude that Mohan Foundation played an immense role and endless role in promoting disease donor transplantation in the country, and holding hands together, we should save the humanity. And thank you for your kind attention.
Thank you, sir, for your wonderful elaborate presentation. We have another chairman, Dr. Rajesh. Do you have any views or comments?
Very nice talk, sir, and really it's excellent to hear you. The great stalwart in nephrology. Hello, am I audible?
Yes.
Hello. Yeah. Thank you, sir.
You are audible.
Yes, sir. And thank you, Dr. Vijay Sinha, boss. You are moderating this, and our absence is there. The Tamil Nadu state where the mission of initiation of organ sharing, let's no any organ to be wasted. The plan has been conducted very well there, and sir, your presentation was very nice, and it should be very
Thank you, sir. Due to paucity of time, we are not taking any questions. Thank you, sir, once again for your presentation.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you. Thank you. Thank you. Thank you. Let me put the right slide.
Hello. Yeah. Thank you, Vijay sir, for conducting the session. May I request all the audience to be please seated on their seats, and you can have your cup of coffee or tea, and please be seated on the seats so that a noise is a bit less. So moving forward to another very important session, very star speaker, and very complex topic, very star speaker. May I request the chairpersons, Dr. Narayan Prasad sir, Professor and Head Department of Nephrology of SGPGI Lucknow, and the Secretary of Indian Society of Nephrology, Dr. Gopal Prasad sir, Associate Professor Nephrology, Department of Nephrology, PMCH Patna, Dr. Preeti Meena, who will be joining online. She is my colleague and Assistant Professor at AIIMS Bhubaneswar, Dr. Himatri Shankar, Consultant Nephrologist from Bhagalpur, Bihar. So, sir, please take over the session.
Good evening. And this session is by speaker is Dr. Professor Vivek Jha. He doesn't need any introduction. He is son of the soil from Bihar. He is executive director of the George Institute of Global Health, and he is also chair of Global Kidney Health Faculty of Medicine, president of the International Society of Nephrology. So I request Professor Vivek Jha.
Thank you very much, Dr. Gopal Prasad and Dr. Narayan Prasad and all the other colleagues. And I would like to also thank the organizers for inviting me to present during this meeting. And my only regret is that I'm not present in Patna in person, which is really where my alma mater is. The topic that I've been given to talk on is kidney transplantation, integrated kidney care, and health systems building block. Just to explore why kidney transplantation is not more popular than what it is right now. So we know that when you compare survival between different kidney replacement therapy modalities and looking at adjusted ratio of all-cause mortality by time periods, and here are different studies and you have this meta-analysis. In nearly all studies, survival is better with kidney transplantation compared to dialysis. And this is true for all ages, for all causes of kidney disease, and irrespective of the presence or absence of comorbidities. Now, moving on to the quality of life, once again, in this meta-analysis, you can see that quality of life in terms of cardiac events and hospitalization, and in terms of the various domains of the quality of life as measured by the SF-36, we find that kidney transplantation consistently performs better than dialysis in nearly all studies. So the quality of life is better with kidney transplantation than with dialysis, as Dr. Marcello Tonelli showed more than 10 years ago. And finally, the cost of care. We know that in the first year, transplantation costs more than dialysis for obvious reasons, but as the survival increases on treatment, the cost of transplantation definitely comes down. And you can see the ratio of the cost of hemodialysis versus the cost of transplantation in year one. It is generally high in many countries, but in some countries, actually, it may even be lower. For example, in some countries of Western Pacific and some African countries, even in first year, dialysis costs more than transplantation. But in some other countries, hemodialysis is less costly than transplantation. But when you go to long term, as I said, in all regions, hemodialysis is much more costly than maintaining a kidney transplantation, according to this systematic review by Dr. Sarah White, which came out last year. We don't know that kidney replacement therapy is a continuum, and once a person develops kidney failure, then they can go to dialysis, or they can directly receive a transplantation. They can move between dialysis and transplantation. If the graft unfortunately fails, they need to go back on dialysis. And people come and get a transplantation after varying periods of dialysis. This dialysis can be hemodialysis or peritoneal dialysis, and once again, people shift from one to the other. I would like to draw your attention to this box, which is the box of conservative kidney care, which hasn't received as much attention in India as it has in some other parts of the world. We need to start thinking more about this particular aspect of it. Gives you a snapshot of the position of dialysis in India. We know that every year between 2 lakh, according to numbers, if everyone who develops kidney failure was to receive either dialysis or kidney transplantation, we should have more than 10 lakhs, between 10 and 15 lakh people on dialysis. But unfortunately, right now, we have less than 2 lakh people receiving dialysis. And most of the dialysis is hemodialysis. And we know that dialysis is usually self-paying. And here you have on the right side, the cost of hemodialysis session, which are all the arguments that we need to do much better in transplantation. We also know that kidney failure carries a high symptom burden. On hemodialysis, an average patient has more than 9 symptoms. More than 50% of patients continue to suffer from pain all the time. They have impaired quality of life, and often they are severely depressed as well. We also know that the survival of dialysis patients is worse than that of many cancers. Here you have dialysis shown in the solid black bar, and you can see that many cancer patients actually survive better than patients on dialysis. And you can see those are the patients, those are the types of cancer which are above dialysis. Their survival is better than dialysis survival. But of course, there are a number of other conditions, other cancers and heart failure, where the survival is less than survival of dialysis patients. So in summary, between transplantation and dialysis of kidney failure, transplantation is associated with less mortality, less cardiovascular disease, better quality of life, and is less expensive for all ages, for all causes of kidney disease, and for all comorbidities. So because of all of these arguments, within all the available kidney replacement therapies, kidney transplantation should be the highest priority, as the International Society of Nephrology recommends in this pyramid, where in the top part you have people with end-stage kidney failure, and you can see the largest section of this triangle is occupied by kidney transplantation, because kidney transplantation gives the biggest value for money in terms of treatment options in patients with kidney failure. However, worldwide, less than 1 lakh kidney transplantations are performed, whereas there are more than 5 million people living with end-stage kidney failure, and most of them are dialysis. So here you can see that if each of these kidneys represents 100,000 or 1 lakh treated cases of kidney failure, this is the number of patients on dialysis, and this is the number of patients who have received a kidney transplantation. So therefore, the ratio is heavily skewed in favor of dialysis. This is the same kind of information presented in a graphical format, arranged in order of the proportion of patients treated with kidney transplantation in different countries. And you can see that the proportion of patients treated with kidney transplantation in Scandinavian countries such as Norway, Finland, Sweden, etc., is the highest, followed by United Kingdom, France, and then Qatar and Czech Republic, and so on. India doesn't even figure in this list because most of the patients with kidney failure in India are not able to receive kidney transplantation. According to the Global Kidney Health Atlas, here this map depicts the global prevalence of kidney transplantation. And again, you can see that most of the patients who have received a kidney transplantation are in high-income countries, North America, Western Europe, Australia, in some parts of Middle East region, and in Latin America is doing better than South Asia. And Africa is relatively weak in kidney transplantation. So the question is, why is transplantation not the main treatment for kidney failure in most countries worldwide? And transplantation is being practiced as the main treatment in very few countries. All right. So this takes us back to the point of the WHO health systems building blocks. And these are the health system building blocks, which are shown here on the panel on the left side. These are service delivery, health workforce, health information systems, medical products, financing, and leadership and governance. And they all determine, they all have an impact on the quality of health, how the health systems are responsive, what kind of social and financial risk protection is available to these patients, and whether the health system works efficiently. All these are also influenced by access and coverage and quality and safety of care that is available to these patients. So the underpinning principles that guide these health systems building block and how we develop our health systems are that of social solidarity. We need to act as one society, which is a just society, which takes care of all its members, and in such a way that there is universal access to all treatments, including kidney transplantation. This is possible only with multi-sectoral action, that multiple sectors of the society and the healthcare systems, they need to work together. And in this, the community also needs to participate, because ultimately whatever we do is determined by the values and preferences of the society in which we provide care. The entire health system provides care. And if we look at the diversity of the way transplantation is practiced around the world, this is once again data from the Global Kidney Health Atlas, and I have drawn this particular chart to show you how different services are available in different parts of the world, and the different bars represent the different parts of the world: Africa, Eastern and Central Europe, North America and Caribbean, Middle East, NIS and Russia region, Latin America, Oceania and Southeast Asia region, South Asia, which is where we are, and Western Europe. And here, if you look at the availability of multidisciplinary teams, where the blue section of the bar represents that these teams are generally available, the brown section represents that they are generally not available, and in the blue, in the top gray section, they are never present, and in the top section, yellow section of the bar indicates that the data was not available. So you can see the availability of multidisciplinary teams is really weak in Africa. It is somewhat intermediate in South Asia and Oceania, Southeast Asia regions, and it is also weak somewhat in Latin America as compared to North America, Middle East, and Western Europe, where multidisciplinary teams are more easily available. Similarly, immunosuppression, Africa does relatively poorly, but most other continents do reasonably well, with some degree of variation in South Asia, Latin America, and Oceania, Southeast Asia region. Funding models for transplantation, here again, there is a fair amount of diversity. Funding is universally available in Eastern and Central Europe and in the Middle Eastern regions, but you can see that funding models are very diverse in many other continents around the world. Availability of standard organ procurement frameworks. There has been a lot of discussion around deceased donor transplantation. And again, you can see the deceased donor transplantation availability is really diverse, with most parts of the world showing relatively poor performance in the availability of standard organ procurement framework. So where do we go from now? We need to focus on a number of things, which includes efforts that we must make in our country as well. In our country, we are very fortunate that we have already a very good legislation. We have a nice credentialing system. The regulatory oversight can definitely be improved. It is there, but it needs to be improved. We are not doing very well in financing, except for a few states, such as Tamil Nadu. Tamil Nadu does very well in financing, and there are other isolated, scattered models of good examples. But in most other states, financing is relatively weak. In terms of workforce, again, workforce is limited mostly to private hospitals, and a few institutions in public sector are doing extremely well. Dr. Georgie Abraham gave example of Madras Medical College, and there are many other medical institutions such as SGPGI, PGI Chandigarh, All India Institute of Medical Sciences, and many other institutions that are doing well. We need to also become better in performing interventions and procedures to make sure that these are more widely available. Laboratory services are available, but they are scarce in some locations, and people have to go to other cities to access laboratory services. Medication availability, because of availability of generic services, is quite wide, but then the cost can be a barrier. We need to develop better protocols and uniform protocols to implement, for care of our transplant patients. And we need to become better in reporting the outcomes of our transplant programs. How can we improve programs around the world? And one of the ways in which we can do this is through global cooperation. And this is already happening through the efforts of organizations like the International Society of Nephrology, and we have Dr. Narayan Prasad, who is currently the deputy chair of the International Society of Nephrology South Asia Regional Board. And India has shown really a leadership in this by providing its expertise to many other countries and centers in the South Asia region, which are looking to develop their programs. So sister renal center programs are being set up through the International Society of Nephrology in different parts of the world. That way we build capacity. And here is one example of a successful pediatric transplant program that was set up in Vietnam through the International Society of Nephrology Sister Renal Center program with Singapore, and Dr. Kar Hui Nung, who was the educational ambassador from Singapore. And she said that the biggest reward that she got from the visit was the smile on the face of the transplanted patient. And here you can see this child who had just received the transplant and is now recovering. So I am going to stop here, and this is all that it takes. In the end, I think what we need to do is that we need to become better as a community in collaborating and cooperating with each other much more, so that we can build in all the health systems building block and a resilient health system that performs very well in transplantation, which is the most optimal therapy for patients with kidney failure.
Thank you, Professor Jha, sir. Everyone remember you as a son of this soil, So we are missing you here. We are expecting that at least you would be here. Sir, always your lecture comes with some directions for Indian nephrologists at least. And there is always, this is full of the thoughts, how to implement where there in India. So thank you for that. Sir, you have talked about the building block versus sensible building block. So can you comment on, because we are making the blocks, trying to improve, but that sensitivity does not comes into function. So your comments, sir. So how to improve that?
So look, thanks, Dr. Narayan. So I think that's a very important question that you raised. So building blocks are important, but the building blocks are not exactly identical in different parts of the world. And those building blocks need to be sensitive to locally available resources. And we need to make the best use of our resources. And so, as you said, they should be sensitive. So they need to be sensitive to resources. For example, we have certain resources which we have all learned to use more efficiently compared to some other resources. In India, you have a system of central laboratory services and people access those services. What we need to do is to build them much more robustly. We need to ensure that the missing elements, such as quality control, are appropriately addressed. We don't need to replicate every single thing in every institution that wants to undertake transplantation. We do know that right now, unfortunately, the availability of transplantation is disproportionately greater in private sector as compared to public sector. We need to right that balance. And so therefore, the sensitive development of infrastructure and resources will require strengthening the public healthcare system, because that is where the average Indian patient goes. And that can happen by public-private partnership or public-private collaboration.
Thank you, sir. Thank you very much, sir. Dr. Preeti Meena is here as chair. Any comment from you, Dr. Preeti?
So thank you for the excellent and informative talk. I'm sure audience must have benefited from your talk. And I actually appreciate the part where you said that, yes, transplantation is optimal therapy, but we should also take care of other parts of life which are causing decrease in the quality of life in our dialysis patient. Like they suffer a lot from insomnia, depression, and cancer, other things. We should also focus on that part. In the places where we are not able to provide transplantation, we should also focus in these parts to enhance the quality of life in our patients. Thank you, sir. Thank you for the lecture.
Thank you, Preeti. So, any comment on behalf of all my co-chairs? Thank you, the chairs and Professor Jha, sir. Yeah. So, due to time constraint, we are limiting questions, sir. So, a lot of questions in the mind, but we can discuss all together, sir. Thank you very much.
Thank you.
Thank you, Dr. Jha. Thank you. Thank you.
Thank you, Narayan Prasad, sir, and other co-chairs for conducting the session so well. And the last session before we go for the panel discussions, another star speaker from Hyderabad. I've been fortunate to have learned a lot from Madam. And for this session, I like to call upon the chairpersons, Dr. N. Gopalakrishnan, sir. Sir is the professor and head Department of Nephrology at Madras Medical College, Chennai. Dr. Pankaj Misra, sir, is present here. He is the consultant nephrologist, Medica Hospital, Ranchi. Other chairpersons are Dr. Nitesh Kumar, associate professor of general surgery, IGIMS. Dr. Mrityunjay, who is the consultant nephrologist from Gaya, Bihar. So, chairperson, please, Dr. Gopalakrishnan, sir, if you can please introduce Madam and conduct the session, sir.
Can I be?
Yeah, sure. Good evening.
Yeah,
sure. It's my pleasure to introduce Dr. Manisha Sahe. Actually, she does not require any introduction. She's such a one of the towering personalities in the arena of Indian nephrology. Currently, she's the professor and head nephrology, Osmania Medical College, Hyderabad. And she's the editor-in-chief, Indian Journal of Transplantation. And deputy, she's holding many positions in the International Society of Nephrology as well. You all know that. She's a deputy chair, CME committee, ISN, and president, Hyderabad Nephrology Forum. And the recent credential is she's the vice president, women in nephrology. This women in nephrology is really making a mark in the international fora as well. And she's the executive committee member of ISOT, vice president of Indian Society of Nephrology, council member of International Society of Nephrology, chairman South Asia Regional Board. She has so many publications to her credit. More than anything, she's a very eloquent speaker. She knows the knack of putting the audience enthralled. Over to you, Manisha.
Can I share my screen?
Yes, sure.
Yeah, so thank you very much for the words. My be planted on the ground and I know where I am, but thank you for all the Indian Society of Nephrology and thanks for this opportunity. I'll be talking about amendments to the Organ Transplant Act. We know transplantation of human organs is undoubtedly one of the greatest medical breakthroughs of 20th century. And some cases, the only way to keep somebody alive. We know that India needs 2 lakh kidney transplants per year. We do around 15,000, both living and deceased donor combined. And we have almost 90% from living donors as compared to the West where they do 25,000 transplants per year, 85% from deceased donors. In India, we have living donor transplants, but limitations are again older age of living donors, diabetes, smaller families, and then risk to the living donor. So we all know that deceased donor is the way to go and needs to be encouraged. About 1.5 lakh deaths happen annually in road traffic accidents in India, and number of them can be harvested for organs. We know that Spain, the organ donation rate is 35 per million population. Britain 27, USA 26, Canada 14. In India, it was meager 0.26 per million population, and now it's gone up happily, but still nowhere near these countries. And in a publication by Dr. Shroff, he mentioned that mere increase to 2 million, 2 per million population, only 2 per million population would take care of all of our patients. So why this organ donation is not happening? We talk about many problems. Lack of awareness, we all know. We also talk about myths associated with organ donation. But very infrequently, we talk about, is our act, the Organ Donation Act, too restrictive? And today's talk, I'll be focusing only on that. We know kidney transplant started in India in 1970. No laws were there till 1991 and a lot of organ trafficking was there. Then 94, we had the Human Organ Transplant Act. And then we had evolution of this act. 1994, then 1995, we had rules, then amendments came in 2008 and a major amendment in 2011. And now we have the consequent rules, that TOTA 2014 rules. So here are where we are, the 2014 rules. We know that it governs both living and the deceased donor transplantation. Everybody should have some knowledge about this act. The postgraduate students as well, many of us are not aware of this. And this article in Indian Journal of Transplant is a humble effort to simplify this act. Very simple, crude presentation of what the act entails. And I'm happy that it has a lot of downloads. I realized how important a topic this was and has been cited also. So in this act, we can divide the act in 10 major chunks. And I'll be discussing the amendments in each of these, which could be further made. The first one is the regulatory. The second portion is the hospitals. The third portion deals with the forms and the donors. The fourth one deals with the responsibility of the doctor. Fifth one is the transplant coordinator. Sixth is organ handling. Seventh talks about penalties. And the 8th, 9th, and 10th deal with tissue, banking, and networking. So these are the major sections in that act for the people who do not know anything about it. Now coming to the first one, regulatory. So what is the current situation and do we need an amendment? So as far as we are concerned now, we have 4 regulatories. One is advisory committee. It is at the state level. Then we have appropriate authority, which is again at the state level mostly. Then you have authorization committee, which can be in the hospital or at the state level. And we have competent authority at the hospital level. These 4 terms should be very clear, at least to the postgraduates, what we are talking about. We cannot use one for the other. Advisory committee is the top level state committee. You have many members in that. You can see, read it there. The main purpose of this is to aid the appropriate authority. And it's already there in the 2014, it's already there, advisory committee, topmost committee. It helps the appropriate authority. What is this appropriate authority? It is again at the state level, mostly the Director of Medical Education. And what it does, it looks at the legal aspects, the registration of hospitals, the standards prescribed. It has the powers of civil code. And it can summon any person to find out about the legal aspects. So that's the appropriate authority. The third important term is the authorization committee. This we all know. Mostly it deals with unrelated transplants, the foreign transplants. Again, it can be at the state level or for hospitals which are doing more than a certain number of transplants per year, more than 25 per year, you can have a hospital authorization committee. So the main purpose of authorization committee, remember, it's for unrelated transplants or for foreign transplants, mostly. And again, the members are defined. You have legal members there, senior registered medical practitioners, women members. So many members are there. So authorization committee, remember, for unrelated transplants or for foreign transplants. Then we have competent authority. So competent authority generally at the hospital level, and it's for living donor transplants. So this is a very simplified version of what's existing. So on the right side, you have advisory committee, which aids the appropriate authority. Appropriate authority looks at the legal aspect. Authorization committee is for permission for unrelated and foreign transplants. And you have competent authority at the hospital level, where for living donor transplants, the superintendent gives permission. So proposed amendment is that it would be good to have a government level committee of experts. The transplant physicians are the ones who understand their patient better, the problems better, know where they are represented. So if we have a committee on the government level or ISOT level, which can give some advice to the advisory committee, would be really good. We need this in-between body between the ISOT and the regulatory authorities. That's the first proposed amendment. Now coming to the second section, which deals with the hospitals. We all know that hospitals has been defined, experts should be there, equipment should be there, standards should be maintained, already defined. India had only 300 hospitals which perform organ transplant. This was earlier, and out of that 250 were registered with NOTO, which meant that fully equipped hospital for transplant, only one hospital for 43 patients. So keeping this in mind, 2011 amendment told that you can have organ retrieval centers also, where the transplant facility may not be there, but still if they have intensive care, they can be non-transplanting organ retrieval centers. So this part is over. That hospitals, the number has gone up. We have a lot of retrieval centers. All of them may not be doing the transplant. So here we do not need an amendment. We are satisfied with this, and all these should be registered, and these registrations are valid for 5 years. And then every time a committee goes and inspects these hospitals every 5 years. One possible amendment here could be, we are having separate committees for inspection for live donor and deceased donor, at least in Telangana. This should be abolished. The same committee can inspect at the same time and give permission for live or deceased donor as desired by the hospital. This will save the government's money, resources, etc. So that was about the amendments in regulatory and amendments at the level of hospital. Now coming to the forms. We had around 13 forms in the old rules, 1995, and 21 forms in the 2014. Very good. All of us should be very well familiar. They define everything: living donor, deceased donor, spousal, minor, mentally retarded, foreign, everything. Each of these forms, 21 forms, they are quite adequate. But what is needed in these forms is all of us should read those forms and use those forms for application for any sort of transplant. So that's important. Now coming to the third section of the rules or the act, the donors, type of donors. Now let me talk about what are the types of donors allowed and what could be the amendments. So coming to living donors first, we all know that TOTA says that living related donors, no problem. Parents, siblings, children, initially, and spouse for living donors. After 2014 rules, grandparents, grandchildren included. Very good. Competent authority for living donors is your hospital superintendent. And form, we know living donor form is form 1. So very clear. Documents required, we know birth certificates, relationship certificates, identity card, and HLA or DNA fingerprinting. This we all know, laid down in the act about living related donors. Spousal donors also very easy. Again, no need for state level, hospital level, your superintendent can give permission. And form 2 is the spousal donor form. Very good. So far, so good. And we know for spousal transplants, we need to have some certificates, duration of marriage, photographs, children, birth certificate, children. All this is already there and we are following it. And Form 6 is the competent authority for spousal. Fine, very good. This is already there. What is the amendment now for the living donors? Few amendments I would propose. I think the definition of living donors should be extended. Allow the parents-in-law to donate. This has been in cabinet discussion, not been finalized, not in the act. And any relationship can be a near relative donor if the relationship can be proven by genetic testing. For example, mama, mami, chacha, chachi, taya, tai, we are not including. But if the relationships can be proven, they should be included as living donors to increase the living donor pool. Similarly, step parents and half siblings. So these are important 3 suggestions for expanding the living donor related donor pool, which is not happening. Then foreign donors. The TOTA is very clear. Authorization committee at the state level has to approve this, fine. And the main important certificate is the embassy certificate. This all we know, 21 form, very good, we know that. But what are the changes which I would propose? First thing is translators. So many of these foreign donors, they come with translators sent from the treating hospital, which is not good. The government should have translators from the universities knowing all the different languages, because this is required to eliminate the bias. We are not understanding what the translators are translating. They are coming from the referral hospital along with the donor and patient, which is not acceptable. The second thing is embassy should also define the nature of relationship. If that form in 21, they clearly state the relationship, it would be protective for us. There are no clear laws about Indians going abroad for transplantation. This should be there in the act. And then there are the registries of foreign transplants. We should encourage transplant tourism, definitely, but maintain a register. What has been done? India has done how many? I mean, that's important. So these are the 4 suggestions for foreign transplants. It's not happening. Now coming to the most controversial issue, the unrelated donor. We know anybody other than near relative is unrelated. Permission here, not by the hospital, by the authorization committee, state level, and the form 3. We all know this is already there in TOTA. We all know that documentary evidence, ration card, all that is there in TOTA, bank account, the disparity in the finances, all those things are already there. We are following that. We also try to ascertain no commercial transaction and what is the link, why the donor wishes to donate, old photographs, no middlemen, financial status. All this is already there in the TOTA 14. Then what amendment do we need? Remember, other countries like UK, Canada, US, more liberal. Anybody can go and donate to anybody else. Whereas the other countries are restrictive. Singapore, Thailand, Myanmar, Sri Lanka, Pakistan, Bangladesh. They just cannot donate without the permission of the committee, without the permission of regulatory. And same is the situation in India, that you have to take permission from state authorization committee. And I'm quite okay with that. We can have some regulation looking at the situation in India for unrelated transplants. But again, the definition is that if the donor is altruistic, go ahead. What is the definition of altruism? It's not easy to define. Here we can take the use of objective scales. You have altruism scales. These can be incorporated. You can take the help of a psychiatrist who can be officially on board, and this could be incorporated in the rules. Assessment of altruism. So you can see the references there. So you have objective tools for assessment for altruism. So this would be a big help to the authorization committee. Then again, the validity of the documents being submitted, green signature with a stamp. None of the authorization committee members can find out whether genuine or not. It's very easy to rectify. Online checking between various departments and online links. India is so advanced in IT technology. So instead of getting paper forms and making the patient run from door to door, can we just not have online verification of all this, the police verification, the residence verification, everything can be done online, and that would be complete truth. So that would be one way of elimination of the forged documents. Unrelated transplants, we should not look down upon. We should look down upon unethical unrelated transplants, and this would go a long way in curbing that. Now, another important living donor is donors from other states. We know that this is allowed. Form 20 is a required form. TOTA 14 gives all these guidelines. We require NOC most of the times from the other state. So here, what would be the proposed amendment? The rules should be that TOTA 14 is not being followed in all the states uniformly. So we have a lot of problem with other donors coming from other states. Telangana does not follow 2014. We are still stuck with the earlier guideline. So one law, one rule, one country. So this would abolish the need for patient running from state to state. the NOC can either be abolished or can be made online. So this is regarding this. Regarding the swap donation, we know that swap is permissible, but only from near relatives. But here now, I would like to expand the donor pool.
40 seconds left.
Pardon?
Only 40 seconds left.
So swap should be allowed from other than near donators, and also from 3-way, N-way swaps should be allowed. And even compatible pairs can be allowed the option of swap transplant to have a better age match. So these are for living donor pool expansion, which I've already mentioned, these 5 points. Now, deceased donor. Some of the important points about deceased donor, we know that brain dead declaration committee, initially only neurosurgeons were there. Now, after 2011 amendments, we have that physicians can also certify. So that's good. The other thing is mandated desire. So all of us should be asked whether we desire to donate our organs after death. This can be with pledge, license, passport. So at the time of acquiring these documents, before death, we should be asked. It's not mandated. Otherwise, even after our death, if the relatives want to donate, they cannot donate. The third important suggestion is all doctors, ICU in charges should mandatory counsel the donor family about brain death. Brain death awareness is not there. This is the most important step. It's already mentioned, but not being implemented. Opt-in, opt-out system won't work in country like India. The fifth important thing is unified definition of death. The US has a unified definition where they incorporate brain death as well as cardiovascular death, but in India it does not happen. We have so many different definitions. So we should have a single definition to avoid this, where a patient was declared brain death in 2013, cardiac death in 2018. Sixth point is directed donation. For example, if a deceased donor relatives want to donate to the relative of a deceased donor who is on dialysis, this should be allowed. And this was a case report published in Indian Journal of Transplant. It was highlighted in 2016. The Ministry of Health and Family Welfare, they allowed the deceased donor to receive, the brother of deceased donor to receive the organ. This was once in a lifetime declaration, directed deceased donation. At least the 7 other organs from that donor would go to the other patients. So we should not refuse this. Many of the times, if we don't allow the donor's family, deceased donor, to give to one of their patients on dialysis, they completely refuse donation. So this amendment is required. We should allow the directed deceased donation. And this was the article which we published in Indian Journal of Transplant. The seventh, one important point is donation after circulatory death. Guidelines are coming. As of now, they are not there, but the Indian Society is publishing guidelines on this. Regarding transplant coordinators, we all know the rules are there, but what is not happening is that we don't have courses, neither we have any post of transplant coordinator in many of the hospitals. So this should be corrected. So this we are doing in Telangana, where we are training themselves, but we need a proper program. Preservation of tissues and cost, we all know that already it's there, that the cost has to be borne either by the recipient or by the government. Penalties and offenses are already there, no need for any amendment. They can be increased penalties if we want. Networking, the provision is already there. We already have Roto Soto. Unfortunately, we have so many states and some are following the 2014 rules, some are not following. We are one country, one law, and this would help with the networking. Registries provision is there, but registries are not being done. And here the suggestion would be data entry operators in all hospitals, recognition of hospitals only if they are entering the data, and integration of the various online platforms. We have Jeevanda and Transstamp, everything should be integrated. And tissue banks already are there, I think.
We are running out of time.
So that should be looked into. So I have already highlighted some of the simple measures which can be done: mandatory brain death declaration, unified brain death declaration, directed donation, transplant coordinator course, networking, and tissue banks. So TOTA has many aspects, and we have covered all the aspects where amendments can be made. The final message is TOTA covers all aspects of organ donation. We have come a long way. Now is the time to look forward, and amendments to increase donation further should be looked upon, and no documentation can replace ethics and the moral values. And this is not my opinion alone, it's collective voice of many. So thank you very much for the patient hearing.
Thank you, madam. Thank you for the nice presentation. Now I will request Dr. Mrityunjay, who is our co-chairperson, to have his comment.
Yes, couple of minutes.
Dr. Mrityunjay, please.
Yes.
Thank you, Dr. Manisha Sahay, ma'am, for your elaborate talk. If the organizer will permit, we can take 1 or 2 questions.
We are running out of time, so I will close the session. Thank you. Thank you. Thank you, sir.
So we move on to the next session, which is a panel discussion. And to moderate this session, I would like to call Professor Sunil Shroff, President, Indian Society of Organ Transplantation. And we have some big names in urology and nephrology from Bihar. So the first panelist I would like to invite, Dr. Ajay Kumar, currently Director, Institute of Renal Sciences, Paras HRMI Hospital. He's a well-known urologist. He's past president of Urological Society of India. He's also the recipient of BC Roy National Award and past president, Indian Medical Association. I would also like to call Dr. Satyajit Kumar Singh, again, a very famous urologist, and he is the director and owner of a well-renowned hospital, that is Ruben Patliputra Hospital. Sir. I would also like to call Professor Arpita Roy Chaudhary. She's currently heading the Department of Nephrology at IPGMR Kolkata and also in charge Roto East Zone. I would also like to call Dr. Rajiv Ranjan, who is the nodal officer, Soto Jharkhand, and Pragya Pant. Is she here, or I think she would be joining virtually. She is the assistant professor of nephrology at RIMS Ranchi, and Dr. Abhishek Kumar, consultant nephrologist and ex-assistant professor IGMS Patna, to come on stage. I told that, sir. So Abhishek is currently in Paras HMRI hospitals.
Thank you very, very much, Harsh. I know we're running late. Let me start. Just a few comments. We have exactly half an hour. We have 6 panelists. 1, 2, 3, 4, 5. Yeah, 6, and me 7. So we have probably 4 minutes each to be able to give our deliberations as well as possible, keeping it short. So just to show you some demographic, very 2 minutes I'll take. We have a population of 130 million, that is 13 crores in Bihar. Literacy rate is about 71% against 74 of national. The length of the state is about 345 kilometers, breadth is about 483. This is important when you want to move organs from one place to another place, perhaps in the future. There are 38 districts in Bihar. And if the slide moves, okay. Estimated demand for kidney nationally is 232 per million population. In Bihar, which should have probably 30,000 kidneys in a year, unlikely to ever happen, but we need to probably take care of the one side prevention, and the side we need to increase the supply of organs. Against this, we do about 50 to 100 kidney transplants per year in Bihar. One hospital bed for about 8,500 people. National average is 1 for 2,000. One doctor to serve 29,000 population. The national average is 1 doctor for 1,200 people. Number of hospital licenses for transplant is 4. Number of trained nephrologists is 14. Number of kidney transplant surgeons are less than 10. 4 solid organ transplant hospitals are authorized. 4 corneal transplant hospitals are authorized. IGMS, Paras, Apollo, Ruben. We have 6,634 fatal deaths from January to December 2020, 60% are head injuries. Potentially, there are 2,500 brain deaths in Bihar. To create a network, you need a cooperation of government with regulations. You need to identify the brain death, you need to certify the brain death, maintain brain death, and then counsel families. So we are likely to face many issues which we have discussed, like identifying, certifying, and so on, retrieval and distribution. So Dr. Arpita ji, you are the roto head, so I must start with you. What kind of infrastructure should Bihar create to get this cadaver program moving?
First, it's clear that deceased organ donation is required. Only living donors cannot satisfy this high demand. So there is no confusion that we need a deceased donation program in Bihar. Considering the number of hospitals under transplant license and trained nephrologists, I think similar picture is existing about urologists. So for the thing that can IGMS do, they can increase the number of their trainee, and more nephrologists can be produced, more urologists can be produced under MCH program, and government should encourage people joining for in government hospitals by every possible way. And at the same time, parallelly, private hospitals which are having transplant infrastructure can also participate in the program. Not that the disease donation program cannot run in private hospitals, because Tamil Nadu and Maharashtra are very, very good models where private hospitals dominantly participate in the disease donation program. So what we need is, the first thing is you have to do frequent, the multidisciplinary team that Professor Jha was mentioning, that multidisciplinary team has to be made, and that has to be made under direction of some SOTO nodal officer or somebody very much interested and passionate about it, who will have a coordination between this.
Because we are short on time, and I want to take multiple questions. I want you to give me, just give me 3 points. 1, 2, 3. What you'll do?
1, increasing the number of trainees and increasing transplant hospitals in Bihar. Number 2 is developing a coordination under SOTO. The SOTO is there. SOTO has to be more active. And number 3 is involving more and more awareness program, not in the audience alone, not in the general population alone, among the medical fraternity, because many of us do not believe.
Absolutely.
Most of us do not believe.
I totally agree. Dr. Ajay Kumar, your brief comments on this before we go to the next one.
Well, in Bihar, for transplantation, we are in an infancy, I must say. We have just started Karauli, and Satyajit is sitting here. He was the pioneer to start the transplant program in Bihar, which was followed by Indira Gandhi Institute of Medical Sciences, and then it came to Paras Hospital, where I went after I joined. So it's basically only 3 hospitals which are doing the transplant at the moment. Now coming to the cadaver transplantation. Indira Gandhi Institute of Medical Sciences got the permission from the government to start the cadaver transplantation. Fortunately, they had 2 cadaver transplants. They got 2 cadavers, 4 kidneys, but 3 went wasted because we were not able to take it. That
you didn't have a waiting list, probably.
Only 1 kidney. Yeah. But now Paras Hospital itself had applied last year, but due to Corona and all, things did not move. But with this proactive government, why I'm telling proactive government, this government is very much
keen,
encouraging. You know what they have done? They are giving up to 4 lakhs of rupees for those who are getting the kidney transplants, up to 4. Now, Chief Minister has said it will be 5 lakhs, up to 5 lakhs. Then medicines also that has been passed by the government.
Very good.
Passed by the government. This is the first government, I think, in India. There are so many things you hear about Bihar, but some good things I'm telling you. This is the first government which has passed in its assembly that we will be giving free medicines to all the post-transplant patients. But modalities are being worked out. Very soon it will be there. So the next point, Sunil, we also have got a very good NGO here.
I know, the Dadichi.
Yes. But your speaker was she from Mohan Foundation or somewhere else? When I came in, she was talking. She gave one NGO from Manipur, but she forgot about the Dadichi. It is working very well. The Dadichi Dehdan no, she did not mention in her lecture. I heard it. Anyway, not name, she didn't mention. So that is, the Dadichi Dehdan is working very well. And I hope that with more NGOs will come up and government will give permission to more hospitals, especially the corporate hospitals, to sort of be part of the cadaver donation program. So this much we have time.
Absolutely. Rajiv Ranjanji, you are from Ranchi and you just want to get started. I know you're having, I hope some useful points have been taken, and when you go back, you'll be able to start. So what do you want to do in your institution to get started? Briefly, if you can say 2-3 things we want to do first.
So it's categorized first to identify who needs that. So to identify the recipient and get a list.
Database, okay.
The first thing is that.
So you want to create a waiting list?
Yes, we have this waiting list.
Do you have license for transplant in Ranchi? Any hospital?
Yes, 4 hospitals are there.
4 are there, okay.
Yes, and 1 is being approved. The institute.
And how many transplants are happening in Ranchi?
They are all living transplant.
How many are doing in a year?
This year we have 5.
5, okay.
Already.
So you would want to first create a waiting list, and that's a very good idea. Only then if you get the retrieval, you will be able to do. Pragya, I think, is from again Ranchi. She is also a professor. She's somewhere.
She is my colleague.
Hidden. She's your colleague. So if she wants to say something, then we take her. Otherwise, we go forward. I also feel that as you all said, that we need to create a transplant infrastructure. There are 14 functional medical colleges, and Dr. Ajay Kumarji says that there are proposals for another 26 medical colleges or 38 in Bihar. So one of the things which you can easily do, because medical colleges have the right infrastructure, so they can become, at least organ retrieval centers to start, and then become transplant center. Because the thing is that most of the brain deaths are medical legal cases. Post-mortem is required. Post-mortem happens in government hospitals, medical colleges. So the donors, by and large, disease donors are in the government hospitals. Recipients, and by and large, are in the private hospital. That is the dichotomy of this program. We need to have equity, and a patient who donates, if he's in a government hospital, should be also able to receive a transplant. So my request is that the government can easily create infrastructure in this state, medical colleges, to become transplant center, and slowly over the years, over 5 years, 10 years, 20 years, we evolve. Because in 20 years' time, kidney disease death is going to be among the top 5 in the world. So if we don't do it now, many people will die. So we have to take small baby steps, and these are baby steps of my proposal, and you all also have the same thing.
Sir, I will like to highlight, just in very shortly, I will like to highlight that where are we at Jharkhand right now, what we need to do and what we have managed to do. So we are in the very early part of this journey. We have managed to form a SOTO, and that was done about 2 or 3 years back.
SOTO head is here, Pragya. Your SOTO head is here with us. So
yes, sir. So I have just, and we have managed to fill the positions except for the transplant coordinator. We could not get a trained transplant coordinator, unfortunately. Somebody was supposed to join, but she couldn't join. And then we are preparing a waiting list. We have been preparing a waiting list. Thirdly, what we need to do, and we have been doing some mass awareness campaigns, we need to do more, but we have been doing it at small levels. We still do not have any brain death certification committee. We'll need to get it made. And we need to work upon coordination with private hospitals, the hospitals which are already doing transplant, as well as we need to register the private hospitals which are not non-transplant, or which can be potentially the non-organ transplant retrieval centers. So I think in this way, if we look at it step by step, then we'll be able to move forward in better manner.
Thank you, Pragya. Thank you for your comments. And besides that, if we empower trauma centers, we'll not only save a lot of lives, but we'll also get a lot of organ donation. And that's very important. Again, we need to do in perhaps in all the medical colleges to start off with. Absolutely. Yeah, absolutely. And as Dr. Ajay Kumar said, that Nitish ji is very, very proactive. He's already announced eye banks in all medical colleges in Bihar. So the same way, this also can be attached to that same kind of clause. And non-organ retrieval center, there is actually a form available in Transplantation of Human Organ Act called Form 13, no cost for registration. I suggest that all hospitals about 25 beds, which has a ICU and which has an operation theater, should be made non-transplant organ retrieval center flat, so that you get more opportunities for organ donation to happen in the state.
We have a very proactive Secretary Health.
Yes, he's
who
coming.
Is coming to inaugurate.
We are going to suggest
and better you speak all this.
We'll suggest that, sir. Sir, I very again want to say one more thing, that you need to, Dr. Arpita ji also said that we need to have more trained people, and you need to train doctors and nephrologists. So how do we increase the DM and DNB seats in Bihar? Well, I think the number of DM and DNB seats in both nephrology and urology and perhaps liver as well are nothing, not much for this state. So is there something which can be done? Very, very briefly, Dr. Ajay Kumar. Yes, then I'll go to...
Again, we started from zero, my dear friend.
Yes.
We have got Indira Gandhi Institute of Medical Sciences, which has got MCH and DM seats.
Yeah.
In Paras Hospital, we have started the DNB program in urology. And the other thing is, those boys and girls who are getting trained outside, you will not believe. I was telling Satyajit that he should mention this, but since you have asked me, let me mention. 1980, we had one urologist in Patna, and only in Patna. And today, we have more than 80 urologists working in Bihar.
But transplant urologists?
And they are transplant, most of them are transplant
80
trained. No, most of them. यार यदि तुम्हें डीएनबी करवाते हो अपने यहाँ और एमसीएच, तो ट्रांसप्लांट के बिना ही करवा देते हो क्या? Jara, we have to find out.
Yeah, that's what I'm asking.
In your
you.
center, we do that.
Yeah.
So they have got the exposure. They have to have the experience. So that is what we are looking forward to. We want more centers to do more and more. I think the rest Satyajit should.
Yes, Satyajit, I'm coming to Satyajit ji. So Satyajit ji, what do you think? How do we increase the number of surgeons, nephrologists? Because we need that, not only in Patna, but also in Darbhanga, in Bhagalpur, in all the places,
Ajay ji has said, from 1 to 80,
yeah,
and many of them are exposed to transplant wherever they were trained. But the long gaps is because there's no active transplant activity here. So they need retraining. What I feel that the way I talk to my patients, that those who got end stage renal failure, transplant is the treatment, dialysis is a temporary.
Absolutely.
I also say that, like in developing country, we say the index of healthcare is what is the 5 mortality rate, what is the up to 5 years mortality rate. Same way in a developed country, the index of good healthcare is how many patients are on transplant and how many are on dialysis. So the dialysis has to be emphasized to the patient who is having dialysis, that your treatment, as it was told by Professor Jha, is even cheaper. Life becomes more active, person becomes more productive to the family. So that first thing I feel that all the nephrologists should be aware, and they should be very, very emphatic that this is the way you should go. You must prepare yourself for a transplant. Every time they come for a dialysis, a counselor should talk to them, and then they should offer the way we can help. So you talk to the relatives. Other thing is, as Ajay ji said, when we did transplant 2008, that time also government gave 1 lakh, 1.5 lakhs. Now it's much more forthcoming, and our patients are getting.
So, are you in a private sector able to manage a transplant in 4 lakhs here?
Yeah.
Kidney transplant?
5.5 lakhs.
5.5, not bad. It's very decent.
And except some immunosuppressive drug, which is another thing.
So, are you also giving them, medication free of cost after they have had transplant from the government?
I think we are giving for first up to the hospital and next 1 month. Rest they go for the government.
So can they not go to the government and get the medication free? Is it allowed?
No, I think as Ajay ji said, and I also talked to health minister, they are planning to give medicine for the transplant patients.
Very good. That's very required.
Other thing which I feel that this there is so much a requirement, as you said, the 2 lakhs is needed and only doing 15,000. I think that many countries have got a model where the base for the donor has increased, like in Iran. And I remember the day on sometime September 1989, there was a panorama 1-hour program on kidney bazaar. That was the title of the program, and they had a hidden camera. They have shown everything what's going on in India and their agents in Europe, in Nairobi, in Dubai. And the next day I came in the theater and I was with Professor Blandy. Professor Blandy said, Sajit, what do you think about did you watch that program, Panorama last night? Yes, I did. What do you think about it? I said, it's very bad to trade in the organs. That's not right. He said, why? Tell me, if I am an Indian Raja, royal, and I have plenty of money, there is a chap who is struggling to look after his children and his both kidneys are healthy. And if he donates for me, I survive, he gets something to make something with the family. So what do you mean?
I think, Dr. Satyajit, we will not talk on that today.
Right. No.
We should never endorse. Dr. Jha published an article in which he
not
has...
Jha.
Yeah.
No, what I'm saying.
No.
Let's not talk about that today. Let's talk about disease donation.
Right. Okay.
That's all.
Okay. I think the problem with us that in Bihar, the SOTA has been formed, but we are not still included in that.
So we need to work together. You can't have stakeholders only from government. You need to involve the NGOs. I'll tell you this again and again, because most of the transplants in this country, 90% happen in private sector. You can't exclude them. And this is what I'm appealing to Dr. Arpita also. We have to work together. 11 million blood donors in this country, 40,000 corneal donations. Most champions are Lion Bank, Lion Blood Bank, Lion Eye Bank, Rotary, Eye Bank of India, NGOs, volunteers. So there should be less government and more public participation. And you are holding such an important post, and I'm sure you're a wonderful job you're doing, but all the SOTOs, all the ROTOs and NOTOs, we need to work together. Only then we can progress forward and make this program great, because it's everybody's problem. It's not yours or mine. So that is very important, and that's what is not happening. I know that. Many states have this complaint.
This is the DHC is doing, but they are just doing for cornea. But that's one nodal society which we go, the civil society.
Yeah, I agree.
I also feel that, the religious bodies,
can do much more. So you could organize a religious body conference.
They should also come. Because in Indonesia, this health issues and organ donation, the masjid has come very forward. That's why this is taken very well. So we think that we professionals first emphasize the patients that the disease, the treatment for end-stage treatment is transplant.
Absolutely.
Second is that we all coordinate, and we must have registry which of our patient is needing a transplant, what blood group is there, and we all coordinate together. And third, we go into the society, do advertisement through the SOTA, and educate the people that this is the treatment. It is cheaper than dialysis, and you're more active, more productive. Thank you.
And we shouldn't forget Abhishek. He's also here in the panel, and he hasn't spoken. So Harsh, don't say finish it, okay? Abhishek, what do you think? I want to only two things I want to ask you. How do you increase your
questions about how to increase the DM?
We need to increase manpower. See, infrastructure can be given, money can be given. If you don't have manpower, how are you going to do this?
infrastructure wise, it's not bad here.
Yeah, I know.
But to have more DM nephrology students, we also need to have more trainees.
Trainees, yes.
In Bihar, last 5 years, we have added more nephrologists than over the last 15 years. So obviously over next 5 years, the things will improve, but this will take time. This can't happen
yes, of course,
overnight.
Of course.
And the first question which we were discussing regarding, I think the SOTO has to be strengthened much more.
Yeah.
The SOTO has recently launched a website in Bihar, so at least we are on a right path. But the number of registries in SOTO are very less. We need to increase that. Only then we can increase the donations.
So thank you. Yes, Arpita.
Critical care
Yes.
involvement.
Yes.
So I would request home to invite the critical care.
So, this
department every week, twice or thrice, and have
definitely. That's a very, very important point, Arpita. It's a very important point. In fact, Arpita, I'll tell you one thing. Last 3 months, we are trying to involve the Critical Care Society of Bihar to do this meeting today. And we said that we will host it. You do it. You become the stakeholder. We couldn't get. I got Rahul Pandit. I got so many national stakeholders to speak to our critical care. But it'll all take time. We should get, we shouldn't feel bad. It'll all take time. But they need to feel empowered. And they need to be given importance. When you have donation, you need to put them in front. Besides the donor, they are the heroes. You know what I mean? Sometimes that works. Last comments from Dr. Ajay Kumar, and then we'll finish.
Just 2 things I would like to say.
Yes, sir.
I think almost everything has been covered.
Yes, sir.
What we need to do, but one help I need, because since it is a national conference of ISOT, not conference, but midterm meeting, one appeal I would like to make to all my colleagues from outside Bihar. Narayan is here, he has been doing it, I know that, but more of you should say that Bihar is having transplant in centers, and the patients, you demotivate them. You see our results. If the results are bad, please don't send them back. But if we are giving results, please tell those, demotivate the patient from having the transplant in your place. Ask them to join by Patna जाइए ना, वहाँ पैसा भी मिलता है और सब कुछ आपको सुविधा है. Why don't you come, go to Patna and get the transplant? That will also a big motivating factors for us. That is a big problem.
I think, already जो follow-up हो रहा है, बिहार में काफी हो रहा है, and patients don't travel anymore. They do local follow-up, आप लोगों के पास आते हैं, but I think that will slowly stop. It's just a matter of time. So thank you very much, my wonderful panelists, Dr. Ajay Kumar, Dr. Satyajit ji, Abhishek ji, Arpita ji, and Rajiv for coming from Ranchi. And of course, we shouldn't forget Pragya from Ranchi. Thank
Just
you.
One announcement to say, on 2nd of April, we are launching liver transplant at Ruben.
Thank you. All the very best.
Thank you, Sunil sir, for conducting the session and inviting us for the panel discussion. For the next panel discussion, another interesting session, I like to call the moderators for the session, Dr. Sanjeev Gulati sir, who is the Director Nephrology, Fortis Hospital, Basant Kunj, and Dr. Sanjay Kolte sir, Professor and Head Department of Urology, Government Medical College, Nagpur. And the panelists for the session will be Dr. Ranbir Prasad Singh, Senior Consultant Urologist, Patna, and President of the Bihar Urological Society. Dr. M. Ansari sir, Professor Urology, SGPGI, Lucknow. Dr. Rajesh Agrawal sir, Urologist and Transplant Surgeon from Jalandhar.
Host has stopped it.
Dr. Purva Chaudhary, Senior Consultant Urologist of Paras HMRI Hospital.
Yes, अब आ गया.
Dr. Rajesh Ranjan sir, Senior Consultant Urologist, Ruben Memorial Hospital, Patna. And Dr. Kamlesh Gunjan sir, Assistant Professor and Head Department of Urology, AIMS Patna. Please moderate the session, sir.
Good evening, all of you. I thank the organizing committee of this conference for inviting me and entrusting me with this important panel discussion. With regard to the panelists, I think we all have an August gathering here of the panelists, but the topic itself is in its infancy. Wherever we go, the entire world literature is very short on this topic, that is of pediatric transplantation. And whichever series we have come across while brainstorming on this, they have we have realized that formed about just about 0.45 to 0.5% of their entire transplant number belongs to this category. So we are all probably going to learn something on this topic through this discussion. We, as have been introduced, my co-panelist, Dr. Sanjeev Gulati, somehow could not be present here himself, so he's available to us with on online. And Professor M.S. Ansari also is available on available to us through online mode. Welcome, both of you all. Dr. Gulati would like to speak a few words on this topic, so I hand over the mic to him. Gulati, sir.
Yeah, thank you, Dr. Colte, and I'd like to thank the scientific committee for keeping this very, very important topic. Am I audible?
Yes, yes, you're audible.
Okay. So, as you rightly said, that kidney transplantation in India is still in its infancy, and I'll just share my thoughts. I'll just share a few slides on, since the panel mostly is composed of surgeons, I thought that I'll just give you the medical perspective of the entire story. Now, this is a quote from none other than Nelson Mandela, that there can be no keener revelation of a society's soul than the way in which it treats its children. And there is no doubt that kidney transplantation is the gold standard as far as renal replacement therapy is concerned. It cures uremia, offers the best possible quality of life, the only opportunity for these children to complete rehabilitation and complete their schooling. It is also cost effective in the long term, and it actually offers superior patient and graft survival. However, in my experience over the last 3 decades, there are several challenges. First and foremost is the social challenge itself. And unfortunately, the child is never the decision maker. It is the parents and the pediatricians who are often dissuaded for offering kidney transplantation. To add to it is the economic issue, as there is no state funding and these children are not insured. A 70-year-old person from the same family without hesitation will go ahead for a kidney transplant, where a similar child would be denied. There are issues of cost, cosmetic, and compliance in the long run. So a lot of these children discontinue therapy. And in the pre-transplant period, there are issues of vaccinations. Then we have to decide what is the best possible immunosuppression, monitor for infections, growth. And I think there are enormous surgical challenges, which this panel will surely discuss in terms of abdominal tract and size. Just a couple of patients I'll share with you. This is a 14-year-old schoolgirl when I was at Sanjay Gandhi PGI. She had end-stage kidney disease due to reflux nephropathy. She was initiated on dialysis and she had fever. She was started on ATT, and the family consulted a few nephrologists, and so very surprisingly, leading nephrologists advised against a kidney transplant. And there were obviously financial issues also, but look at the story. Finally, we were able to convince the family. We raised funds through a big effort from the school and the society. She got a transplant from her mother in 2003. Was on cyclosporin as a prednisone. TAC, later on TAC came along, so she switched over to TAC. Had one episode of rejection that time before we switched over to TAC. Currently 19 years post-transplant. Serum creatinine of 1.4, and look at her progress, academic progress. She completed her bachelor's and master's from IIT and now is a faculty at IIT Bhopal. So this is what we need to tell that we can achieve today if these children are able to go ahead. But there are challenges. We have to optimize them pre-transplant. We have to make sure that they are vaccinated. Especially varicella vaccine is one vaccine which should be given because you cannot give any live vaccines post-transplant. Peri-transplant management is very challenging in terms of fluids and electrolytes. We need to keep in mind that graft needs to function much longer in a child. Therefore, the choice of immunosuppression, the doses is critical. It should be non-nephrotoxic, lowering the risk of malignancy. At the same time, facilitating growth from the child's perspective. That's one of the most important features, and we have to make it affordable. Some of the medical challenges. This is a 12-year-old boy who came to us with label of dilated cardiomyopathy, severe heart failure, and our cardiologist told us that cannot go ahead because he had severe PAH and 10% ejection fraction. So we put him on daily hemodialysis, optimized the ejection fraction, got him onto a kidney transplant. This was in 2013. And thereafter, this child who could not walk 2 steps was actually in the school athletic team. Absolutely remarkable story. This is another child who had failure to thrive since 2 years. It came to us from Cambodia. When he was brought to us, he was 4 years old. He was brought like a bag because he could not walk. Just weighed 10 kgs at 4 years, more like a 2-year-old child. So we initiated an automated peritoneal dialysis. This was in 2012. And we went ahead with the kidney transplant using induction with basiliximab, TAC, MMF, prednisone. And thereafter, this child is currently completed his school education as in college. There's another child who was in follow-up when I was at Sanjay Gandhi PGI, preemptive transplant 2001. And last follow-up was in 12 years post-transplant. At that time, had completed his education, gainfully employed. And this is something which I think the panel will take up, but a 9-year-old child who had anorectal malformation, ileocystoplasty, recurrent UTIs, had Metrafenov bilateral ureteric reimplantation, and this took its toll. He progressed to chronic kidney disease. May 2012, we did a kidney transplant, and post-transplant outcomes have been remarkable. We have also looked at steroid-free protocols in children, and they have, as you can see, this child grew remarkably. Post-transplant growth of, and non-compliance at the same time, we need to keep in mind at each and every follow-up. Another one of our transplants, first transplanted in 1993, was doing remarkably well. So well that he forgot to take his drugs. And in 2007, and sure enough, he had a rejection, back on dialysis, got a second kidney transplant, and since then has done well.
So I think we wind up now.
Yeah, we wind up. Just the last slide. Graft survivals have improved. 1 year, 98%, 5 years, 85%. And long-term survivals, this is a child we transplanted who's got married and takes care of his aging family members, his parents also, looks after himself. So I'll just conclude and hand it over the podium back to Dr. Kolte for further. But what I want to tell everyone here is that we need to communicate to the family, to the pediatricians, to all the stakeholders that transplant outcomes have changed.
Thank you, sir. Now we have seen through his presentation how transplant kids have grown up into mature and achievers as adults. Precisely that is what we are now intending to do, trying to convert ourselves from adult transplant surgeons to pediatric transplant surgeons so that they can make a difference to more and more kids. Now, to begin with, how do we actually differentiate between pediatric and adult kidney transplantation? Or so to say, what are the causes? How do the causes that lead to ESRD in kids, how do they differ from the adults? Primarily, the causes of ESRD in kids, they are mainly, how do they differ from the causes in the adults?
The posterior rectal valve is the most common cause. It's
Yes.
neglected.
So primarily, they are more of urological causes,
Yes, urological
and
causes.
rather than medical renal
Yes.
disease causes.
The high pressure system, VUR, vesicouretic reflux,
Right.
leading to recurrent pyelonephritis and all.
Right.
The bladder is always not evaluated in the child, and the hypercontractile bladder is the case which can lead to the high pressure system and the kidney failure. And
Right.
it is neglected even after the transplant. That has must to be addressed when we see the transplant in the kidney. And this multicystic dysplastic kidney and other which are poor from growth itself. So these are the few cases where the
Intravesical obstruction, outlet obstruction,
Yes.
neurogenic bladder.
Yes.
Dr. Rajesh, would you like to emphasize on the preoperative workup for a kid before he undergoes transplant? A kid with probably vesicular reflux or an unstable bladder or an intravesical obstruction. How would you work up this child?
As rightly as emphasized that most of the children are having renal failure because of the lower tract dysfunction. And that lower tract dysfunction is going to persist if we don't correct them. Even after transplant, they're going to affect the graft also. So we must address the lower tract for the successful outcome of the transplant for a long run. Now, 50% patient, they don't have lower tract obstruction, then there is no problem about the surgical. Only thing there is disparity of vessels and those things are different. But for those patients who have got lower tract dysfunction, we have to ensure that there is normal pressure storage of the urine and normal pressure wording. For normal pressure storage, you have to do augmentation, which I don't do at the time of transplant, just before the transplant. Normally, I don't have a very large experience of transplant. I have done about 10 cases of pediatric. In 2 cases, I have done a ileostomy, ureteral ileostomy, and after the patient stabilizes for 6 months, then I convert it into the augmentation cystoplasty, because immediately doing augmentation cystoplasty before the transplant has got more morbidity, and it is difficult to manage these children with augmented bladder just before the transplant.
Right.
So it is better. One patient had come with a vesicostomy. So I did transplant and I continued with, the child continued with the vesicostomy for 1 year. And after 1 year, we converted him. We did augmentation of the bladder so that he can have a normal pressure. Regarding reflux, if the reflux is high grade and patient is having recurrent UTI, then we have to either do a pre-transplant nephrectomy or we have to do ureteric reimplantation. I prefer doing a nephrectomy before transplant. The right nephrectomy we do at the time of transplant, and the left nephrectomy we do afterwards when the patient is stable on the with normal renal function.
Okay. Dr. Apurva, what are the problems that you can encounter when you transplant a kidney into an augmented bladder or a newly constructed bladder?
One major problem is, sir, the mucus discharge from the augmented segment of the bladder, which if bladder irrigation not done regularly and properly, it leads to mucus ball formation, retention of urine, infection, and because it is a child, doing a proper bladder wash is also not very easy, because you can place a small caliber catheter only, either through per urethra or through the mitrophanoff. And that small caliber catheter sometimes is not able to suck out all the mucus. So that is the first issue. Otherwise, sometimes that can lead to perforation and leakage, urinary leakage. Sometimes it can lead to metabolic acidosis, hyperchloremic acidosis, for which even gastric augmentation had been planned, but that had other problems like hematuria, dysuria syndrome, and hypochloremic alkalosis. So that is one of the biggest problems with augmented bladder.
Okay. So, Professor Ansari, what and how aggressively would you advise a kidney transplantation to an infant with kidney failure? Or what is your view about transplantation in neonates or children in their infancy,
Yes.
first year of life?
Yes, sir. See, the commonest cause of this infancy is the CACUT. And the congenital anomalies of kidneys and the urinary tract. That is basically the term these days is used in relation to the transplantation population in infancy. And there are certain criteria when you can take. It may be a cystic disease, it may be an obstructive lesion, or it may be a refluxing lesion. Most of these are called now as a KECAT. But weight is the criteria that it should be taken. And some of the centers has gone to 10 kg also, but preferably it should be 15 kg, so that the kidney which is being put there can be safely perfused in these babies. And besides this, the things which are usually ignored is the nutritional status of these babies. And so that also helps if we are having a poor nutrition in these babies. Besides the adult size of the kidneys, the oncotic pressure of the perfusion of these kidneys are less, then they are more liable to go for the thrombosis subsequently. So these are the certain apprehensions while we are considering the infants for this transplantation.
About transplantation of kidneys into such small kids. Would adult kidneys fit into a kid in the first year of life? Dr. Kamlesh, can you answer on this?
So my take is preferably if it is possible, one need to avoid transplantation in very small kid, like less than 2 years of age, because the chances of graft loss is higher again in those cases. So it is always better to attain the child to a weight of at least more than 10 kg, or at least let the age let him grow or her grow up for more than 2 years old, so the transplantation could be done in a better way. So as far as kidney transplantation in infancy or a small kid is concerned, adult size, we need to take donation from younger donors. Kidney has to be fit in the abdominal cavity, preferably, because of a small pelvis in those small kids. It would be difficult to fit.
Dr. Ranjan, your take on this? Because finding younger donors, probably that would what we can look for is children as donors, because for a 1-year-old, I don't think we can work on any younger donors. But if at all there's a cadaveric donor and we get an adult kidney, would that be feasible to put it into a child as low as 1 year of age? And if that is done, where is it done, and what are the surgically different aspects of it?
Sir, it's really difficult. We can better to put intraperitoneally, because extraperitoneal it is difficult, space is less, and if we put adult kidney, it's difficult to manage there, it's difficult to place there, and again complications are more. So intraperitoneal is the better option, though it's very difficult to find the donor for such a small kid, sir.
Deceased donation is what we can actually work on such patients. The other aspect of it, infants coming as deceased donors. Suppose we have an infant who comes with some reason which has caused brain death in him. Can we harvest kidneys from infants, and can we transplant them? Any one of you?
Yeah, can I take this, Dr. Kolte?
Please. Do combined both kidneys can be put together, and aortic patch can be taken, which can be anastomosed with the adult recipient if it is adult. And if it is a pediatric small, then it's just like in adult, we can transplant one kidney with one patient. So if the recipient is adult, then we can do combined both kidneys transplant.
Right. Dr. Gulati, you're saying something?
Yeah, absolutely. First, I would agree that in the lucky case that we are able to get a pediatric donor as a cadaveric, we would do an en bloc resection of both the kidneys, because the infant's kidneys are going to be immature, as Dr. Rajesh already added. But the fact is that a country like ours, the transplant program is almost live related, and we are still dependent on live donors for all children. I mean, the series that I have, the 98 children that I have from Fortis Group, and the 152 odd that we did at SGPGI, Dr. Ansari is here, he'll vouch for it. Well, all live donation programs, and there we are dependent on an adult kidney, and there it is the expertise of the surgeon, which is why that cutoff figure is critical. More important in the chronological age, it is the weight of the baby. So internationally, 10 kgs, and we were lucky to reach the 10 kg barrier at Fortis, but most of our children were more than 15 kgs, and the only reason is that for the surgeon, the life becomes easy to place an adult kidney, because that's what you are going to get. In fact, for the preferred donors in all these cases, we always offer the grandparents as the first donor, because we would like the parents to as a fallback donor in the event of a graft rejection.
Yes, very right. And with that, I think we should now culminate this. Yes.
Cystoplasty, pre-operative cystoplasty. How many children you have done transplant and how rapidly?
Dr. Gulati, could you hear that?
No, sorry.
Cystoplasty, how many transplants have you done?
Sorry, please
In
repeat.
kids with augmentation cystoplasty, how many transplantations have you done?
I think that is where the cutting edge is there. And in our series, we have got about 10 such children, and they develop UTIs. I mean, these are clearly, it's a real challenge to do all this. But then, see, what are we looking at? Life on dialysis is no way to go. So we are dependent on our surgeons here who have to fix the tract, as was rightly highlighted before, and thereafter we do go ahead with kidney transplant.
Okay. With that, we come to the end of this discussion. I wish there was more time. Probably an entire day would be short for such a detailed topic, and sometime in the future, we'll definitely come on this. With this, I would thank all the panelists for having participated, and my co-chair, Dr. Sanjeev Gulati. Thank you very much. And I request all of you to kindly mark your dates on the 12th to the 16th of October this year for the annual conference of the ISOT in Nagpur. Please make it possible, make it available. We'll definitely make it a successful as this one. Request for your wholehearted participation. Thank you very much. Thank you.
Thank you. Bye-bye.
Thank you, sir, for this important topic in which all of us have very little knowledge about pediatric transplant. So we are slightly enlightened about this. And coming to the last talk for today, a very important talk. For this, I like to call the chairperson, Dr. Sunil Shroff, sir. Sir has been here throughout the day, so doesn't need any introduction. Other chairpersons are Dr. Rajneesh Sahai. Sir is the head of the NOTO at Delhi, and Dr. Sameer Chube, senior consultant nephrologist from Nagpur.
Thank you. I have great pleasure and I'm very privileged to have two very eminent chairpersons along with me. Dr. Rajneesh Sahai is the director of our national body, NOTO. He's an ophthalmologist, very senior ophthalmologist. He's been in chair for now, I think, last 6 months with NOTO. And he's not well, but he's agreed to be with us. Thank you, Dr. Sahai, for your kindness to be here. This midterm meeting is very well attended in Patna, you'll be glad to know. They are very enthusiastic to start the disease donation program. Dr. Arpita Roy Chaudhary also is here, our ROTO head. Our SOTO people also are here. So full cooperation from your body and very grateful. And I wish you could be here in person here. All the same, very happy to have you. And we also have Dr. Chaube, of course, very eminent nephrologist, needs no introduction in this part of the world. Thank you, sir, for joining us.
Thank you.
And of course, our speaker, very distinguished speaker from US, and he has agreed to deliver this lecture, which is recorded, but he's very much live there as well. His name is Dr. Stephen G. Tullius. He's a surgeon. He's a Joseph A. Murray. Joseph A. Murray was the surgeon who did the first kidney transplant successfully in Brigham Hospital in 1954. So Dr. Stephen Tullius is Joseph E. Murray, distinguished chair in transplant surgery, division of transplant surgery. He's director of transplant surgery and research laboratory at Brigham and Women's Hospital. He's professor of surgery at Harvard Medical School, executive director of Transplantation Journal. He's also he's been nominated as the president-elect for the Transplant Society. He has close links with India. He wants to take the Indian program forward. He has been in touch with our secretary, Dr. Vivek Kute, and he is going to deliver the lecture this evening on a topic which is about how to preserve the kidneys. So I would like to hand over to Dr. Stephen Tullius. His lecture has been pre-recorded, but he's very much present in the room to take any questions. So over to the lecture, Vivek. Can we get it switched on?
Dear ladies and gentlemen, thank you very much again for inviting me to provide to you an update on organ preservation, including economic aspects. I'm thrilled to be at the Indian Society of Organ Transplantation midterm meeting, and I'm very grateful for the invitation of President Shroff, Secretary Kuti, the chairman of this meeting, Dr. Kumar, and the secretary of this meeting, Dr. Van Dan. I'm also glad to see the chairmen of this particular session, Dr. Sahai, Shroff, and Shorby. And I very much hope that you will enjoy this lecture, and I'm here to answer any questions that you may have after you listen to the presentation. Patients are waiting for organ transplants around the world. Those are US numbers that you see here. And it's approximately 120,000 patients, predominantly for kidney, but also for liver transplants waiting. So how can we serve those patients in the best way? And how do we make organs available for them? Now, another aspect that is important to understand, particularly if we look into the deceased donor organ transplant population, we see an increase of age. So the quality of organs related to age, but also to other aspects, brain death, prolonged ischemia, is decreasing, and we need to find ways to improve the quality of organs. And organ preservation and organ reconditioning is certainly one way to do that. And we have to have in mind that and this is again numbers from this country, due to the increasing wait time and the lack of availability of organs, we have approximately 20 patients dying per year. So what can we do of identifying organs, making them available, and on their way from the donor to the recipient, assessing their quality and improving their outcomes? There is the way of cold storage. That is the way that we have procured and preserved organs traditionally. And more recently, numerous ways of very innovative methods on preserving organs outside of the body at normothermic preservations, hypothermic preservations, with the addition of oxygen, with the addition of additional medications that have helped us to improve the quality and thus making more organs available. Organ injury starts in the donor and already prior to transplantation. And I'm listing here the most relevant aspects of organ injury. There has been a great deal of research being done that looked into the consequences and the damages that we have seen subsequent to brain death. And brain death indeed, and that is research that we have done together with others approximately 15, 20 years back, has shown that brain death per se represents an injury, an immediate insult on the organ, and that results into reduced and inferior outcomes long term. And it is clear that when we look into the outcomes of living compared to deceased donor transplants, that the outcomes of living donors are quite superior as those organs are healthy and they have not been injured in a comparable way. Now, subsequent to taking an organ out of a deceased donor, an organ goes through a more or less intense procedure of ischemia and reperfusion injury. And the prolongation, the time is playing a role there. The reperfusion is playing a role there. And there are all those aspects that you see here that play a role when an organ undergoes ischemia and reperfusion injury. Aspects that lead to an activation of innate and adaptive immunity. And what we have also seen subsequent to prolonged ischemia is an augmented immune response that results into more frequent acute rejections. And then certainly the quality and the critical piece here shown is aging, that also is important when we assess older organs. And those organs may be particularly relevant to be procured by novel preservation solutions. And this is again shown here that all those injuries, the immune injury, brain death, ischemia, reperfusion injury, activates innate immune responses, activates adaptive immune responses, and then leads to more frequent rejection and inferior long-term graft outcomes. And what options do we have? We have the option to treat the donor, we have the option to treat the organ, and potentially also the recipient. And we are going to focus mainly here on aspects of treating an organ through novel preservation devices, and also pointing towards an option on how to treat an organ in the donor already. Those are the principal opportunities that we have, cold storage being shown here. And this is one of the old devices. And it's important to remember that organ preservation, machine perfusion, has been already available in the 60s. And as you see here, those devices were way more cumbersome than the devices we are used to now. And at the same time, the treatment and immunosuppression improved at that time, and therefore organ preservation devices were less frequently used, and also the availability of organs, the quality of organs was quite different at this time. Those are the principal ways that we can treat organs. We can treat them already in the donor. We can treat the organ outside of the donor. And as I mentioned before, we can treat the recipient. I'm going to show you a few experimental data that show that the principle is working, but I'm focusing on clinical data that will show you on how relevant the perfusion and preservation is in the clinical scenario as well. Those are experimental data that we did many years back, and we treated the donor here with immunosuppressants. Donors were treated with steroids, MMF, rapamycin, and tacrolimus. And you see that the urinary protein excretion as a marker of chronic rejection in this model is lower, independent even, from the immunosuppressive treatment in a donor animal. And that leads to improved graft survival. Here shown long-term graft survival after a single donor treatment with prednisolone, tacrolimus, or MMF. And that goes along with reduced cellular infiltrates. So donor treatment with immunosuppressants is playing a role and has a potential. And that has also been shown clinically. This is a study in liver transplant recipients, biopsies taken at the time of procurement, and then after treatment, after reperfusion. And you see that all those pro-inflammatory markers, they are declining after an organ is being transplanted that has been treated in the donor already. And this clinical trial in liver transplant in liver transplant recipient also went along with improved outcomes and less frequent acute rejections, although those readouts were not significantly different. Another aspect that is of interest is targeting the products, the pro-inflammatory products that are produced upon reperfusion. And targeting radical oxygen carriers has been a particular interest in preserving and improving organ transplant outcomes. However, a limiting factor has been that there was a systemic approach rather than a local approach that targeted the areas where those products were actually produced. And here we tested an agent, APP103, that was again used in an animal model where we treated the recipient prior to transplantation, at the time of transplantation, and then shortly thereafter. And then we looked into the outcome, and what we saw is that we saw an improved preservation of tubuli. We saw reduced fibrosis after transplantation, and we saw less apoptotic cells. So there is, at least in theory and shown in experimental models, an opportunity to treat some of the unspecific injuries that we see subsequent to an ischemic injury, and ways then to improve outcomes after those treatments. And that all of this is also playing a role is shown here in a clinical study that has been published in the New England Journal a few years back. What has been done is a very basic approach that donors, brain-dead donors, were either kept under hypothermic or normothermic conditions. And what you do see here, again, correlated to the quality of the graft, that the delayed graft function rate is significantly lower when those donors were kept under a hypothermic condition. So lowering their body temperature just by 1 degree helped to improve the outcome of organs procured from those donors compared to donors that were kept under normothermic conditions. Now, perfusing organs can be done under several conditions. It can be done under hypothermic condition or normothermic conditions. Hypothermic conditions have been around for quite some time now, and they have shown here in a kidney trial, there's a prospective kidney trial, that the hypothermic condition was better compared to cold storage. And again, particularly pronounced when the organ was either a DCD donor, so a prolonged warm ischemia related to that, or an expanded criteria donor. And those outcomes were not only improved short term with reducing the rate of delayed graft function, they were also improved long term, which you see here. Machine perfusion leads to better graft survival, and particularly it leads to better graft survival in the combination of when delayed graft function is also present, and that is particularly then a sign of a poorer quality of an organ transplant. Now, normothermic preservation has been introduced most recently. Lung transplant has really led the way here. And this is a study by the Toronto group about 10 years ago now. And that shows if lungs are preserved normothermic for a short time interval, then that reduces the amount of transplants that show a primary graft function or a significant delayed graft function. Normothermic perfusion has been expanded now to liver transplantations. There are clinical studies going on at this time that show that there is an improved transplant outcome of liver transplants when they are preserved under normothermic conditions. And again, you see here the outcomes favoring normothermic preservations, particularly in organs that have an additional injury here, DCD donor livers, that show a particularly advantage after this type of preservation, but it is also seen in organs that are procured after brain death. Now, of course, there is a novel advancement that we have seen by a center from Guangzhou in China, where an approach has been used where organs are transplanted without ischemia. That is a technically very demanding device, but a surgically unique and excellent approach, which takes organs from a donor, puts them immediately without the interruption of oxygen and blood supply into a normothermic preservation, and then transplants them this way. And with that, the authors have seen an improved transplant outcome, and they have applied this approach, transplantation without ischemia, now for kidneys and hearts as well. I talked about the context and the link between injury repair, aging, and other aspects of injury. And here it is particularly important that those conditions do provide an impaired repair and regeneration. And there are ways, again, also where we can try to rejuvenate organs. And this is an approach that we have shown, and I have presented that to you in more detail below, a way that we can deplete senescent cells with senolytics that particularly target those cells. We then reduce the immunogenicity of an organ. And this is shown here, that old organs that were treated with senolytics, again, experimentally show outcomes that are comparable to those of younger organs. And those are studies that we are currently testing clinically ex vivo to see if that is also applying to human organs. Now, an important aspect is when we look into the different ways of how we can provide an additional improvement of organ quality, is that also an economically viable approach. There are two studies that I want to show you. One coming from the group in Sao Paulo, and one is a European study that looked into a very careful analysis comparing, again, cold storage and machine perfusion for kidneys. They looked into the amount of delayed graft function. They looked into the outcome by creatinine and eGFR over up to a year after transplantation. And they did see that there was an improvement of delayed graft function subsequent to procuring organs with machine perfusion. They then went through a very careful and strategized analysis that did compare the outcomes of 1,000 kidneys under machine perfusion, 1,000 kidneys under cold storage, and then looking into them under various conditions, either an immediate function, delayed graft function. And in all those scenarios, they did calculate the costs, and they calculated head by head if the machine perfusion, even by showing by improving clinical outcomes, would then still benefit in regard to a cost analysis. And this cost analysis is shown here as an annual cost in US dollars compared to an alternative in a Brazilian real. The cost of dialysis, the cost of graft loss in the first year, the costs for delayed graft function, the standard acquisition, the additional costs for machine perfusion, the additional costs for the transplantation, and the cost of the kidney transplant maintenance during the first year. And all of that is summarized then down here. And what you see here is a significant delta in regard to saved costs overall for the entire amount of costs, cost savings over 1 million, and costs per graft saved at about 30,000 US dollars. So based on this calculation, it seems to make sense to use machine perfusion compared towards cold storage. And this is also shown in this study here. This is a study from the European group, from Rutger Bloch's group, that was instrumental in doing the first prospective trial that I've shown you, published in the New England Journal. Here again, the numbers shown for specific components of the transplant. An analysis here in regard to the outcomes, quality of life, and then summarized here in regard to total costs, machine perfusion versus cold storage, transplanting expanded criteria donor organs, and transplanting DCD donor organs. This is all kidneys. $8,000 saved per transplant if machine perfusion was used for the ECD kidneys, and another cost saving, also not that pronounced, approximately $1,000 per the utilization of DCD donor grafts. Now, there is an additional aspect that is important to know when one wants to implement organ preservation devices. It may not be necessary to perfuse the organs the entire time. This is shown here, where organs have been in a liver transplant trial just prior to implantation with a hypothermic oxygenated perfusion. So this is hypothermia with oxygenation, and this treatment just prior to transplantation helped as well by improving, by reducing the amount of grafts lost from 32 to 8%, and by reducing critical factors in regard to the transplant outcome of liver transplantation, ischemic coagulopathy, hepatic artery stenosis, primary non-function, and then the rate of sepsis and chronic rejection. Now, what is the conclusion of all of those data? What to do in practical terms? I think organ preservation, novel organ preservation, machine preservation has the benefit of allowing us to assess the quality of an organ. It allows us to improve the quality of an organ, and the cost-benefit analysis seems to favor machine perfusion compared to cold storage. And what does that mean in a future vision? I think we have the opportunity And we will see many more clinical trials that will focus on this to recondition and potentially rejuvenate organs. There are already today organ preservation reconditioning centers. This is such a center where an organ would go after procurement, be reconditioned there, and then shipped to the recipient center. And I think there will be an entire new field of those who are running the reconditioning effort together with an entire group, with an entire orchestra, with the goal of improving organ quality. So with that, I thank you very much again for this very kind invitation, and I'm happy to take any questions that you have. Thank you.
Thank you very much, Dr. Tullius, for this very informative and important talk on this burning topic nowadays. I'm sure we can take some questions.
Yes, thank you, Joby. A very exciting area of research, Dr. Tullius, and I'm sure this is, of course, as you said, the future to recondition, rejuvenate the organs, future to recondition, rejuvenate older human beings, perhaps 20 years from now or 10 years from now, the way it's going. Great lecture. Any questions from the audience? But before I ask the audience, I would also ask Dr. Rajneesh Sahai, is he still connected? Dr. Sahai, are you still there?
I don't think so.
No. So he's not been well, so I suspect that he may have switched off. So Dr. Tullius, I just want to know, before I ask anyone in the audience to ask any questions, what percentage of patients today in US, or what percentage of organs perhaps in US, let's just talk about perhaps just kidney and liver, are actually undergoing machine perfusion? Because you do have elderly donors. So what percentage at the moment undergo machine perfusion before you utilize them? Do you have
so most regions and most organ banks in the country do apply hypothermic perfusion to expanded criteria donor kidneys, so kidneys from older donors predominantly, and DCD donor kidneys from donors after cardiac death. And I would assume that this results in approximately half of the organs that are procured in the country being perfused hypothermically. There are substantial differences geographically. Some centers, some geographic areas, organ procurement areas are more focused on perfusing organs, others are less focused. And then there is an additional aspect that is of importance. If an organ is procured and transplanted locally, it makes the entire implementation of machine perfusion easier. Absolutely. Up until now, machine perfusion is, organs are not allowed to be on a machine perfusion device when transported by a plane.
So can I just ask this, again, is your discard rates come down after machine perfusion over the years? Have you seen the discard rates come down of organs?
So that's a very interesting and very complex question. The discard rates have not necessarily come down. The discard rates in the United States are high, and they are high as there is great concern in regard to outcomes in the country, and organs are refused based on biopsy results, and some are refused based on pumping results. So there are two sides of this coin. You could make an argument that the organ perfusion device allows you to assess the quality of an organ. That may increase the discard rate, that may have benefits, that may be a good thing,
it may be a bad thing that the result of the assessment may not really reflect the quality and therefore result into the discard of an organ.
Thank you. Any questions? Yes, Arpita, please.
Great talk, great inspiration. A nephrologist from India, Arpita, and my question is, nephrologists are much bothered about the long-term graft survival. Do you think either hypothermic or normothermic perfusion is going to help the decrease the initiation of the chronic allograft injury? Because if I discuss the pathogenesis of chronic allograft injury, the first step that occurs, that is at the inception, that is when the kidney is suffering from ischemia perfusion injury. Do you think that it may help in improving any clinical support for that?
You know, that is a very, very good question. I don't think we know the answer for that in clinical terms. I don't think there has been a clinical trial that looked into this. I mean, there has been, I showed you the outcome of the first hypothermic machine perfusion trial that had been published in the New England Journal. And then they published also 3-year data. And the 3-year data showed that the outcome was improved. Now, is that outcome improved because of a lack of chronic rejection? That is not confirmed. But I think it is fair to assume that if we reduce the initial injury, that we will see an improvement of long-term graft function, and that improvement will be related to a reduced chronic rejection. Because as you said, chronic rejection starts with the initial injury after transplantation. And therefore, if we impact and reduce that, we would think that we have an impact and an improvement and a reduction of chronic rejection.
Great. Thank you so much. Any other questions from the floor? Yes, Dr. Pankaj.
Thank you, sir. Is there, we can apply isothermic perfusion to cadaver kidneys also?
What did you say, ISO?
Isothermic perfusion to cadaver kidneys.
Hypothermic perfusion to cadaveric kidneys, yes.
Normothermic perfusion, yes.
All the extended donor criteria.
Oh, normothermic, sorry. So yes, so normothermic preservation has been done for kidneys as well, has been done successfully for kidneys, and has shown an improved graft survival. Normothermic preservation, I personally think, will be the future of and the more advanced perfusion concept, and will help to even improve graft quality furthermore. However, the practical initiation and the application of normothermic preservation is more challenging, as it requires, at least at this time, a constant observation and assurance that the normothermic preservation works, versus the hypothermic preservation at this point is so established that you can just leave a hypothermic machine device in a corner and it will do its job, and you can come back a few hours later and do your transplant.
Thank you so much, Dr. Julius. I know it's early morning for you. And
that's fine.
Thank you so much for joining us. We are, a little short on time. So
yeah, absolutely. Enjoy your meeting.
Great lecture. Thank you again. And we look forward to perhaps having you physically in Nagpur when we have a meeting in October.
Yeah, would love to.
The COVID is receding, so the chances of you coming physically in person will be great to our Nagpur meeting.
Yeah.
But with that,
I would love to.
Again, loved your lecture.
Enjoy your meeting.
Thank you so much.
Thank you very much.
Thank you. Bye.
Bye. Thank you so much for joining from Ranchi.
Thank you.
Bye.
Thank you, sir. With this, we close this session and we'll meet again after 10 minutes for the opening ceremony.
Excuse me, sir. उधर रेडी है। अरे लेकिन ये बंद कर रहे हैं, माइक चलेगा ना? माइक चलेगा? नहीं ये कहाँ पे चलेगा? ये भी लाइव हो रही है। लाइव ही होगा, वहाँ से करना हो रहा है, वहाँ से हो रहा है। यहाँ से कुछ करना नहीं, यहाँ से कुछ शेयर करना है। इसको चलाना नहीं, बोलने में दिक्कत होता है। हाँ? अरे ऐसे नहीं, रुक बस
Hello. Hello.
Samaprabha.
May I request all the dignitaries to kindly come to the hall? जो भी बाहर है वो अंदर आ जाए प्लीज. May I request all the guests to kindly come to the hall, please? We are going to start in a short while. So, yes. I request our chief guest to kindly be seated. Namaskar. A very warm good evening to one and all present here. On this exuberant and really sparky Saturday evening, I, Minati Chaklanavis, take extreme pleasure in welcoming you to the Indian Society of Organ Transplantation Midterm CME 2022. Friends, Mother Teresa had once said, we cannot always do great things, Yet we can do small things with great love, affection, and effort. Giving your organ to somebody else is not just donation, it is making a difference. Adding some more years to somebody else's life. Isn't that great? Although giving life to people is the prerogative of the Almighty, the supreme power, although gods on this earth are the ones who transplant different organs to the patient, giving and adding more life to them. This is the reason that we all call the doctors the second god on this earth. A huge round of applause for all the second gods here. Today's evening is going to be a memorable one because for the first time, Patna has got the responsibility or opportunity to organize such a beautiful program here. So first time I'm welcoming, like it is a proud moment for the host as well as the guests who have come from the long distance as well as distant places to attend this prestigious CME 2022. We are happy to have such dignitaries coming here to grace the occasion. None other than the Honorable Chief Guest, Additional Chief Secretary, Government of Bihar, Mr. Pratyay Amrit has been here, and it is really a proud moment for us. So may I request you, sir, to kindly come to the dais, and somebody from the organizing committee may escort him to the dais. So I don't think the place vibrating, please. We are so happy to have you here, so. Kindly be seated. I also request Padma Shri Bimal Jain. That is really wonderful. General Secretary Dadhichi Dehidan Samiti to kindly come to the stage. He has graced the occasion by being the guest of honor. Whenever we talk of organ donation, one name that automatically comes to our eyes is Dadhichi. So we are really happy and proud to have you here. We also request Padma Shri Dr. Professor I.B. Sinha, Chief Patron, kindly come to the stage. Your blessings are always there, and your coming to this program itself, it means a lot to us, sir. May we have Thank you, sir. May we have Dr. Professor Om Kumar, Chairman, Organizing Committee, Professor and Head of the Department of Nephrology, IGMS, to come to the stage. A floral welcome. I also request Dr. Professor Hemant Kumar, Patron, ex-head of the Department of Nephrology, IGMS and PMCH, kindly come to the stage. A floral welcome. You too have to make your presence felt. I also request Dr. Sunil Shroff, President, ISOT, Indian Society of Organ Transplantation. As I said, so it has started sparkling now. Thank you, sir. Now I request Dr. Vivek Kute, Secretary, ISOT, Indian Society of Organ Transplantation, to come to the dais, please. I request Dr. Amresh Krishna, President, Organizing Committee, Additional Professor, Department of Nephrology, IGMS Patna. And now I request Dr. Harshvardhan, Organizing Secretary, Faculty of Nephrology, PMCH Patna, ex-Associate Professor, Department of Nephrology, IGMS Patna. Atithi, if doctors are the second god, Atithi too are Devo for us. So Atithi, Devo Bhava कहती है बिहार की धरा, स्वागत करके हमने निभाई है अपनी परंपरा. Now, may I request Dr. Om Kumar to kindly felicitate our chief guest, Shri Pratyay Amrit, Additional Chief Secretary, Government of Bihar. Yes, sir. Thank you. Thank you for accepting our love, our affection, our respect. I request now Dr. Amresh Krishna to kindly felicitate Padma Shri, Shri Bimal Jain. ताली तो बजती रहनी चाहिए. Dr. Preetpal Singh is requested to felicitate our patron, Dr. I.B. Sinha. Your presence itself is a present to us, sir. Thank you, sir, for accepting our love and respect. The organizing secretary, Dr. Harshvardhan, is requested to felicitate Dr. Sunil Shroff. So first time Patna is organizing such a prestigious CME. I also once again request Dr. Harshvardhan to felicitate Dr. Vimal Kute. This is the Bodhi tree, as it is a land of Buddha. I request once again, Dr. Harshvardhan, you are not supposed to leave that, to felicitate Dr. Hemant Kumar. This is the tree under which Lord Buddha got the enlightenment. Dr. Harshvardhan once again is requested to felicitate Dr. Om Kumar. Thank you, sir, for accepting our respect, the token of appreciation. Once again, Dr. Harshvardhan is requested to felicitate Dr. Amresh Krishna. Such a wonderful moment. Once again, I'll request Dr. Harshvardhan to felicitate Dr. Preetpal Singh. This is the pleasure that the organizing secretary always having such CMEs. Now, may I request Dr. Preetpal Singh to felicitate our organizing secretary, Dr. Harshvardhan. Little more. Why should be the vibration this side? Let the vibration come from that side as well. He is the organizing secretary. That feel should come. Now, may I have the pleasure to request Dr. Om Kumar, Chairman, Organizing Committee, for welcome address. Thank you, sir.
Good evenings. As Chairman, Organizing Committee of the 7th Midterm ISOT Conference at Patna, it is my pleasure to welcome all the dignitaries on the dais and dignitaries, faculty, delegates present in this hall. We feel honored to welcome Sri Pratyay Amritji, IAS, Additional Chief Secretary Health, with additional charge of Department of Disaster Management, Government of Bihar. Pratyay Amritji, a 1991 IS officer, is one of the main architects of Bihar turnaround story who has placed Bihar on the road of success. We know he is known for his get it done attitude and get it done now attitude, and his ability to give attention to details of any project. He is an able administrator and HR expert. He always ensures that the staff gets a congenial environment to work and the basic facility to carry out their jobs. Many milestones and historic achievements go to his credit, like turnaround story of Bihar Rajya Pul Nigam Corporation, Bihar Rural Electrification Program, and most importantly, the management of COVID-19 pandemic in the state of Bihar. I am grateful that you have spared time to come to our function, sir. I welcome Sri Vimal Kumar Jain ji, the guest of honor for today's function. He has been awarded Padma Shri by President of India for his work in the field of creating awareness for organ and tissue donation. He is General Secretary of Dadichi Dehdan Samiti and Bihar Vikas Viklang Nyas. Today only he was involved in distributing many of the artificial limbs, more than 300 or 400 artificial limbs to the disabled person or especially able persons. Welcome you, sir. I welcome Padma Shri Professor I.B. Sinha, sir, who has agreed to come in this function despite having some health issues. We know he has come only for giving blessings to us. So we welcome you, sir, and we are very much obliged for your coming and gracing this occasion. I welcome Dr. Sunil Shroff, the son of soil. As we have discussed in the morning, he is an alumnus of prestigious Patna Medical College and Hospital. He is president of Indian Society of Organ Transplantation and member trustee of Mohan Foundation. We all have witnessed his passion for propagating the knowledge of organ donation among the various stakeholders, and his brilliant communication skill and brilliant teaching skills we have all witnessed. So we welcome you, sir. I welcome Professor Vivek Kute from Ahmedabad, who is Secretary of Indian Society of Organ Transplantation. If Dr. Sunil Shroff is son of soil, I can say that Dr. Kute is an adopted son of soil in Bihar. Whenever we call him, he always obliges to come and help us. The nephrology and transplant community, both at national and international level, has witnessed his meteoric rise as a clinician, transplant physician, and a great researcher. So big hand to Dr. Kute. I welcome Professor Hemant Kumar, a senior colleague of mine, a very noble person, and who has done many awareness programs inside the state of Bihar. And recently he has very successfully organized the World Kidney Day to do the awareness among the public for kidney donation and other kidney diseases. I welcome my colleague, Dr. Amresh Krishna, Dr. Pritpal Singh, and Dr. Harshvardhan, the organizing secretary of today's program. I welcome all the dignitaries and faculties of the dais. To name few, we are having Secretary, Indian Society of Nephrology, Professor Narayan Prasad. We are having President Roto, Dr. Professor Arpita Rai Chaudhary, Dr. D.S. Ray, and we are also having Dr. R.K. Sharma, Dr. Satyajit Ji, Dr. Ajay Kumar, and other dignitaries, Dr. Naveen Prasad in the audience. So I welcome you all in this function. Finally, I welcome all the delegates, guests from the industry and the media person. Thank you very much, sir.
Thank you, sir. It is in our Indian culture that we do not start anything auspicious without the blessing of the Almighty, the Supreme Power. And to show this symbolic, our trust, our faith, we light the divine lamp. So now may I have the pleasure to invite all the dignitaries who are on the dais to join their hand in this auspicious task led by our Honorable Chief Guest, Additional Chief Secretary, Government of Bihar, Pratyay Amit sir, please. That is too close, I guess.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
Thank you, sirs. Now, respective seats. May I now have the honor to request our patron organizing committee, Dr. I.B. Sinha, who had been our guardian as well. So we are really happy to have him among us to address the distinguished guests.
First, I welcome you all to this conference of ISOT. This was delayed very much, or Harshvardhan, who is the organizing secretary, had arranged so many times, and every time, due to COVID, it was suspended. Hotel booking and everything was cancelled. But I'm very happy that today it is materializing. I don't want to call everybody from here because I know everybody and it will take a lot of time. But I can assure you that Dr. Om Kumar and Dr. Harshvardhan and his team, Amreshar and Pitpal, they have taken a lot of trouble and pains to arrange this conference. They will take proper hospitality care also, so that you may be comfortable. Because as she has said, that we consider our guests as Deva Bhava, means हमारे भगवान हैं. आप लोग सारे जो आए हैं बाहर से, वो सारे भगवान हैं हमारे. हम लोग भगवान को रुष्ट नहीं कर सकते, इसलिए सारा केयर लेते हैं हम लोग कि आराम से हैं. और बाकी और ये जो कॉन्फ्रेंस है ये तो चलेगा ही, लेकिन एक बात कह दें कि बिहार में ट्रांसप्लांट बहुत देर से शुरू हुआ. इसका कारण एक था कि डॉक्टर सत्यजीत हैं, डॉक्टर अजय हैं, ये जब मैंने शुरू किया था डायलिसिस, तो ये लोग बोतल पकड़ के 24 घंटे खड़ा रहते थे. स्टैंड नहीं था जिसमें बोतल लटका सके, तो ट्रांसप्लांट कहाँ से लगता है? सो आई वाज ए फेल्योर. बट so but Dr. Om Kumar, who is the chairperson of this conference, he is a very dedicated, knowledgeable, honest, and capable person who started this conference. Yes. With the help of his team of Dr. Ramnesh, Dr. Pitpal, Dr. Dr. Harshvardhan. They helped him, and he started the transplant, and he is doing a lot of transplant. Subsequently, in a Rowan hospital, Dr. Satyajit and Dr. Pankaj Hans, they started this transplant. And now Sasi is doing in, there are 3 centers where the transplant is being done, and the credit goes to the organizer, the top one, who takes a lot of pain. It is not ordinary thing to start any transplant program. So I think that for 2 days you are here, and scientific program is meticulously prepared by Dr. Pankaj Hans and others, and many VIP are also sitting in front, but I will meet them and not call them by name. So in 2 days, enjoy yourself and stay comfortably with the ardent care of Dr. Harshvardhan. Thank you very much.
Thank you, sir, for your wonderful words of appreciation, acknowledgement, as well as blessings. And we are really, really very grateful to you that you have made it in person, sir. Thank you so much. Now, may I have the pleasure to invite Dr. Vivek Kute, Secretary, Indian Society of Organ Transplantation, to address the August gathering. Thank you, sir.
all the distinguished delegates on the dais, all the invited delegates, members of Indian Society of Organ Transplantation. It is my pleasure to inform you that Indian Society of Organ Transplantation has done immense contribution in service, education, and research in the field of organ transplantation in India. And that is the reason why India stands number 3 in the world literature in terms of transplant activity, only after US and China. From 2013 to 2019, 61,822 transplants are performed in India. 65% are kidney transplant, 25% are liver transplant, and less than 10% are heart, lung, pancreas, small bowel, and multi-organ transplant. 85% transplants are from living donation, and 15% transplants are from deceased donation. Deceased donation is more active in South and West India. It is recently started in states like West Bengal, Patna, Goa, and still it need to be started in eastern part of India. So government need to prioritize deceased donor organ transplant with teamwork to achieve self-sufficiency for organ transplant so that there will be no need of near related family member to donate organ for saving the life of their loved one. This is the year-wise data of deceased donor organ transplant in India from 2013 to 2020. Over the last 6 years, deceased donation number increased by 2.5-fold. This is year-wise data of kidney transplant in India. The red column indicate deceased donation, green column indicate living donation, and blue column indicate total number of kidney transplant. This is the year-wise number of liver transplant in India from year 2013 to 2020. Red column indicate living deceased donation, green column indicate living donation, and blue column indicate total number of year-wise liver transplant in India. So 1/3 of the liver transplant are from deceased donation. Heart, lung, pancreas, small bowel, and multi-organ transplant numbers are less in India, but they are slowly increasing over the last 6 to 10 years. US is number 1 in terms of COVID burden in the world literature. But due to their established disease donation program, they were able to manage their transplant activity. The disease donation declined 12% at the global level and 51% at India level, as per data from Global Observatory on Donation and Transplantation. India is number 2 in the world literature for COVID-19 burden. However, the transplant activity is much affected in India, 40 to 50%, due to COVID-19 as a health priority over elective transplant surgery. During all 3 waves, we continued emergency disease donor organ transplant. Indian Society of Organ Transplantation has contributed to National Organ and Tissue Transplant Organization, that is NATO guidelines for transplant, what safety checklist should be followed when we proceed for transplant in COVID pandemic. We also contributed to NATO COVID-19 vaccine guidelines for transplant recipient, and NATO guideline on VITT donor, whether we should use it with all safety measures. All ISOT members contributed to the largest multi-center retrospective cohort study of 372 kidney transplant recipients who recovered after COVID-19. And as on today, this is largest series in the world literature on transplant on patients who recovered from COVID-19. We have also documented that transplant in COVID recovered patient is safe. More data is available for kidney transplant. 1 month should be the waiting time when we proceed for transplant. We should continue standard induction and maintenance immunosuppressive regimen. Emergency solid organ transplant can be performed even with active COVID-19 infection in carefully selected cases, and long-term follow-up is required. Indian Society of Organ Transplantation has also documented the largest series in the world literature on living donor kidney transplant from donor who recovered from COVID-19. Again, this is a multi-center cohort study from 19 centers with 31 kidney transplant. All members of the society has actively contributed to the research on COVID-19 pandemic, and we have published more than 66 papers in national and international peer-reviewed journals. There is a global impact of COVID-19 pandemic on transplantation. So if there is a future surge of COVID-19 wave, we should implement telemedicine, ensure doorstep healthcare delivery, rapid testing of pathogen, prioritize waitlist patient for early transplant, and development of early regional plan for taking care of COVID-19 surge. To conclude, I will like to thank all members of Indian Society of Organ Transplantation, all the contributors for their research, and I will say that Jite ji Raktadan, Marne ke baad Angadan should be the motive of our life. Thank you.
Thank you, sir, for your enlightening presentation. Moving forward now, may I request the President, Indian Society of Organ Transplantation, Dr. Sunil Shroff, to kindly address the August gathering. Thank you, sir.
Thank you, and good evening to all of you. This is a very emotional connect I have with this city. I came here 50 years back as a student. I stayed here for 10 years, did my graduation and post-graduation, and I went back. And now I have great privilege to be back here as president of this society, which has 1,500 transplant clinicians, which includes not only kidney nephrologists and transplant surgeons from kidney, but also from liver, heart, lung, hand, face, all kinds of transplant. So very privileged to be here as the president of the society. The theme of this meeting, I mean, it was a dream to have an ISOT here in my tenure, and this has been fulfilled. And thanks to Om and Harsh for working so hard, and huge privilege to be here in front of Dr. Indu Bhushanji, who was our teacher for all of us. Great privilege. So the theme of this meeting, I wanted to keep it as, transplants in emerging states. Bihar has made a start in transplant program. Great start. We have also done disease donations, thanks to Vimalji and his, the DG Dehran Samiti for, helping out and doing so many corneal and body donations as well. Simply amazing. Bihar is a great state, and we need to applaud these things. And we, some of our Biharis like me outside Bihar, always look at these things and get very inspired. And we want to do, we want to give back to Bihar as much as we can. And me more particularly because this is my alma mater, PMCH. In Bihar, the requirement for kidneys, if you estimate, for a population of 13 crores, is at the rate of 232 per million population, that is our rate of kidney failure, would be close to 25 to 30,000. I know that this demand can never be met. We need to do prevention on one side, and we need to increase the supply of organs on the other side. So I have come here with 4 wish lists for a very dynamic IS officer who's sitting in here. IS Additional Chief Secretary, Principal Health Secretary, IS Amritji. And, I have this 4 wish list because way back in 2008 in Tamil Nadu, we had a dynamic IS officer called Mr. Davidar. And he made a lot of difference. And he was a true champion of the program. And in 1 year, he helped us pass 10 government orders in the transplant field, which had never happened anywhere in the world. So today, sir, you have the opportunity to do the same thing for Bihar. And believe me, if you are able to do this for Bihar in transplant field, you'll not only help patients with requiring organs, but you'll also improve the health infrastructure of Bihar, which is lacking. Because if you improve transplant, because we are in the cutting edge area, you'll improve the lab services, you'll improve the radiology, you'll improve so many things in a hospital. The hospitals will start functioning like a machine, because when a disease donation happens, everybody's agog. All the departments have to work together. And it also creates so much of harmony, so much of good feel factor in the community that you want to do more. So you already have champions in this place. Select 10 champions from Bihar who are in organ donation. Vimalji is there. Ajay Kumarji is there. Satyajit ji is there. Om Kumar, Harsh, so many of you are here. Make a task force of 10 of these people. Let them meet once a month and make a report and take baby steps. And from your side, from government side, look at Tamil Nadu. We'll send you the orders, what you did. Pass similar orders. We have an excellent law today in Transplantation of Human Organ Act. But there are some things which you have to do at the state level, because health is a state subject. So what you need to do is define procedures, the so-called standard operating procedures. You are from HR background, you know what standard operating procedures are. You need to create the standard operating procedure. Every step of this cogwheel has to be defined. How do you identify brain death? How do you certify brain death? When you certify brain death, what do you do next? How do you approach the families to ask for organs? And once you ask for organs, how do you retrieve? Where is the waiting list? Who gets the allocation of organs? How do you then take care of postmortems? How do you give the body back? How do you honor the families? Everything. Define it as procedures. Make this as orders, and let all medical colleges become organ retrieval centers from start. Any hospitals in Bihar which has 25 beds, which has an ICU, which has a operating room, can straight away become non-transplant organ retrieval centers. So there are more opportunities, because death doesn't happen only in Patna, it can happen anywhere. So there are more opportunities for donations in Bihar. So kindly do that. So my first wish list is create a task force. My second wish list is define non-transplant organ retrieval centers and make all the medical colleges, there are 26 medical colleges, likely to be more, make them all transplant centers because they have infrastructures. Tell them that do dialysis, get the manpower in place and start doing things. So second wish list is increase transplants by doing these 2 things, making the medical colleges transplant centers and non-transplant organ retrieval centers. My third wish list is that all schools, class 9 or class 8, introduce a small chapter on organ donation. So a sensitization starts right there. So in 10 years time, 20 years time, we'll have many people who already know of organ donation. So the conversation for organ donation becomes much easier. So please do that. So if we do these few things, I think we can go forward quite easily and things will start happening. Small steps can do great things. You have to unite all the stakeholders. You have to unite the private people, you have to unite the government people, you have to unite the NGOs. Only then we can do great things. Like Mother Teresa said, I can't do what you can do. Very simple. And you can't do what I can do. But together we can do great things. So you have a moment of opportunity today to be able to make this movement happen, sir. If you do that, it'll be great service to Bihar. And Biharis like me are always there to help you, whatever you require. So thank you very much. Jai Hind.
That was truly myriad of emotions directly coming from the heart of the son of the soil. So thank you, sir, for those encouraging words, and surely we are going to fulfill your wish list. Now, moving forward, may I have the pleasure and honor to invite somebody who has almost become synonymous with the organ donation. So no prizes for guessing. It is, of course, Dadiji Dehedan. So I request Padma Shri Mr. Vimal Jain to kindly address the August gathering. Thank you, sir.
श्रद्धा, सम्मान और सेवा का बड़ा मंच ISOT, सब बिग शॉट्स यहाँ हैं, उनके द्वारा ISOT एक बड़ा नाम है देहदान का, ऑर्गन ट्रांसप्लांट्स का। हमारा एक छोटा सा परिचय है कि दधीची देहदान समिति के माध्यम से बिहार में पिछले 4-5 सालों से ऑर्गन डोनेशन के लिए एक मोटिवेशनल फोर्स के रूप में काम करने का प्रयास चल रहा है। आज मंच पर पूरे बिहार के लिए एक आइकॉन के रूप में जो जाने जाते हैं डॉक्टर IB सिन्हा जी, और आज बहुत सुखद था कि मोहन फाउंडेशन के श्री सुनील सराफ जी, आपका यहाँ आना, बहुत दिनों से इच्छा थी आपसे मिलने की, संजोग है कि आप आज आए और आपकी ब्लेसिंग्स मिली, ये बहुत बड़ी बात है। हम लोग बिहार के अंदर पिछले 4-5 सालों से लगातार काम कर रहे हैं। छोटा सा प्रयास शुरू किया था, लगातार के दबाव के कारण बिहार सरकार ने पिछले 5 सालों के लगातार प्रयास के कारण आज जितने भी सरकारी मेडिकल कॉलेजेस बिहार में हैं, वहां पर शुरुआत आई बैंक से हुई है, परंतु अभी भी फंक्शनल नहीं है। 1-2 जगह फंक्शनल है, बाकी जगह पर अभी भी वो डोरमेंट स्थिति में पड़ा हुआ है। आज संयोग की बात है कि मंच के ऊपर आज चीफ गेस्ट के रूप में बिहार के हेल्थ सेक्रेटरी उपस्थित है। बिहार के कायाकल्प करने में जिस व्यक्ति का बहुत बड़ा योगदान रहा है, वैसे अमृत प्रत्यय जी, एक बिहार के लिए नौकरी तो सब करते हैं, परंतु परिवर्तन का आगाज कहीं से शुरू होता है तो वो आप जैसे लोगों के माध्यम से होता है। बिहार की नई पहचान बनी है आपके कारण। अभी डॉक्टर साहब ने बताया कि बिहार के अंदर 30,000 की जरूरत पड़ेगी पर ईयर। आई की भी 12,000 से ज्यादा पड़ती है जरूरत, परंतु पिछले 4-5 सालों के अंदर कुल मिलाकर 300 से ज्यादा आई कॉर्निया डोनेशंस हुए हैं, सिर्फ प्रयास के बावजूद। जबकि लगता यह है कि बिहार के अंदर जो स्थिति बनी पड़ी है, हर मेडिकल कॉलेज में प्रतिदिन कम से कम भी 3 से 4 हजार पेशेंट्स आते हैं। डेथ रेशियो भी उसी हिसाब से होगा और वेंटिलेटर या बाकी सब चीजें भी जो है उनकी सुविधा के लिए उपलब्ध होगी। यदि इंफ्रास्ट्रक्चर को और सिस्टम को बढ़िया से डेवलप किया जाए तो बिहार पूरे देश का एक रोल मॉडल हो सकता है, ऐसा मेरा मानना है। और इस दिशा में हम सब लोगों का सहयोग आपके साथ है। आप जब तक हैं तब तक जो है इस काम को एक चैलेंज के रूप में लें। बिहार सच में पूरे बिहार देश का एक कह सकता हूं कि स्वाभिमानी स्टेट के रूप में गिना जाएगा। हमारे सामने डॉक्टर सत्यजीत जी है। बिहार में जब कोरोना का पीरियड था तो भगवान को तो लोग कम याद करते थे, आपको ज्यादा याद करते थे। मैं उस समय किसी को भी जरूरत होती थी तो सबसे ज्यादा आपके पास लोगों का फोन भी आता था, और हम सब लोग किसी न किसी रूप से बहुत अनुग्रहित हैं आपके सिस्टमेटिक और सपोर्ट के लिए। उस समय जब एकदम निराशा होती थी, उस समय आपका सहारा बहुत बड़ा था बिहार को। आज ऑर्गन ट्रांसप्लांट को लेकर बातें हो रही है, मंच पर ऐसे ऐसे लोग उपस्थित हैं जो विद्वान हैं, जानकार हैं। हम लोग तो सामाजिक कार्यकर्ता हैं। इतनी सारी अड़चने हैं ट्रांसप्लांट में। ट्रांसप्लांट उसी का हो सकता है जो एक्सीडेंटल डेथ हो या वेंटिलेटर पे हो। वैसे लोगों का जब हॉस्पिटल में यदि एक्सीडेंटल डेथ के कारण जाते हैं, हर साल करीबन 1.5 लाख एक्सीडेंटल डेथ होती है। परंतु हॉस्पिटल जाते जाते या फिर पुलिस केस के कारण वो ऑर्गन डोनेशन का काम यदि वो चाहता भी है परिवार, तो नहीं हो पाता है। सबसे पहले पुलिस केस होता है, एफआईआर होती है। डॉक्टर्स भी तभी हाथ लगाते हैं जब पुलिस की एफआईआर पूरी हो जाती है, फिर उसका पोस्टमार्टम होगा। इस लंबे प्रोसीजर के कारण जो ऑर्गन मिल सकता था, किसी की जान बच सकती थी, किसी का जीवन नया हो सकता था, वो नहीं हो पाता है। इसको लेकर एक बड़ी चिंता की स्थिति है पूरे देश के अंदर। अभी कुछ दिनों के बाद करीबन डॉक्टर साहब से, सराफ साहब से हम जरूर कहेंगे कि हम लोगों ने पूरे देश भर में जो भी इस फील्ड में काम कर रहे हैं, अगस्त सितंबर के महीने में दिल्ली में एक गेट टुगेदर करने जा रहे हैं, जिसमें कि ये जितनी भी हर्डल्स है, उस हर्डल्स को कैसे दूर किया जाए, सरकार से भी बातचीत करके उसमें क्या सिंप्लीफाई किया जाए। क्योंकि बहुत सारे देशों के अंदर तो डेथ के बाद वो बॉडी सरकार देश की प्रॉपर्टी हो जाती है। उसका यदि ऑर्गन काम में आता है तो वो ले सकते हैं। अपने यहाँ वो सिस्टम आज तो नहीं है, आगे क्या नियम होगा पता नहीं। दूसरा क्या कि डेथ होने के बाद उसके परिवार से कंसेंट लेना कि ये देगा कि नहीं देगा, इसके बॉडी के ऑर्गन्स लिए जाएं कि ना लिए जाएं, इसको लेकर भी एक कंसेंट लेने के टाइम में लंबा एक समय लगता है, जिसके कारण भी हम ट्रांसप्लांट की स्थिति में नहीं आते हैं। चौथा कि ये आने वाले दिनों में कहीं भी डेथ होती है तो एक ब्रेन डेथ कमेटी हर हॉस्पिटल में चाहिए। वो ब्रेन डेथ कमेटी का प्रोसीजर हम लोगों ने लगातार सरकार को भी लिखा है कि ब्रेन डेथ कमेटी का एक फॉर्मेशन हर हॉस्पिटल के अंदर एक गाइडलाइन के तहत कर दिया जाए, जो लीगल सिस्टम के अनुसार हो, ताकि जब डेथ होती है तो उस समय ब्रेन डेथ कमेटी नहीं होती है, और ब्रेन डेथ कमेटी नहीं होती है तो वो जब तक बनेगी तब तक में गंगा का पानी बह चुका होगा। ये स्थिति है। तो इन सब हर्डल्स को एक नई दिशा में फिर से हम लोग अधिक से अधिक प्रयास करके एक दिशा ले जाएं, यही हम कह सकते हैं। और आने वाले दिनों में डॉक्टर सराफ और पूरी टीम के साथ हम उम्मीद करते हैं कि एक नया भारत बनाने में हम लोग अग्रसर हो सकेंगे। स्पेन ऐसा देश है जहां पर कि 24% ऑर्गन डोनेशंस होते हैं। अपने देश में तो 0 पॉइंट समथिंग जो है। अभी डॉक्टर कूटे साहब ने बहुत अच्छी रिपोर्टिंग की, और लगता है कि 130 करोड़ का देश और किसी भी पॉइंट पर हम खड़े नहीं हो पाते हैं। ये आज की स्थिति है। एक बहुत बड़ा कारण और भी है, लोगों में जानकारी नहीं है। मुझको भी पूरी तरह से जानकारी नहीं है कि यदि किसी को किडनी लेनी है या देनी है तो वो रजिस्टर कहाँ कराएगा, उसका क्राइटेरिया क्या होगा, कैसे एक आम आदमी गरीब कैसे जो है उस जगह तक पहुंच सकेगा। क्योंकि किडनी का या और लीवर का जो भी सिस्टम है, उसकी जो प्रोसीजर है नोटों की तरफ से या सोटों की तरफ से, उसकी जानकारी का अभाव, वहां पर भी सिस्टमेटिक वे में प्रॉपर काम नहीं हो पाता। इसको कैसे हम लोग दूर कर पाए, ये एक सोच का विषय है। आगे इस दिशा में काम करने की जरूरत है। और हम तो चाहेंगे कि बिहार को खासकर एक रोल मॉडल स्टेट के रूप में खड़ा कर पाए। इस दिशा में अमृत प्रत्यय जी का बहुत बड़ा रोल रहने वाला है। हम सब लोग आपको शुभकामना देते हैं कि इस दिशा में अग्रसर हों और हम सब लोगों के साथ एक नया बिहार बनाने के क्रम में आपका योगदान मिले। अंत में एक ही बात कह सकता हूं कि जिंदगी छोटी नहीं होती, चलना हम देरी से शुरू करते हैं और जब तक समझ में आती है तब तक काफी समय लौटने का हो चुका होता है। हम लोग जितनी जल्दी करें, आने वाला जब भारत का 100 वर्ष पूरा हो उस समय तक हम एक नए भारत को बना सके। इसी शुभकामना के साथ आप सबों को बहुत बहुत नमस्कार, धन्यवाद।
धन्यवाद महोदय, आपके बहुमूल्य विचारों के लिए। आपने अचीवमेंट के साथ साथ हर्डल्स की भी बात की और सच में दोनों के साथ अगर हम हर्डल्स को पहचानेंगे तो शायद हम अपने रास्ते में सही से चल पाएंगे। आपके महत्वपूर्ण विचारों के लिए बहुत बहुत धन्यवाद। Friends, there are some people who are born with Midas touch. And it won't be an exaggeration if I say the same thing for our honorable chief guest. Whichever field he felt, whichever department he touched, it started vibrating. And after a couple of months, maybe you could feel the reverberating departments. Secondly, he infects people with his dynamism, workaholism, as well as farsightedness. He is our chief guest, additional chief secretary, Government of Bihar, as well as principal secretary health. So may I have the honor as well as pleasure, delightful pleasure to request you to kindly address the August gathering, sir. Thank you.
नमस्कार, गुड इवनिंग। मंच पर आसीन और व्यक्तिगत रूप से मेरे लिए बहुत गर्व और सौभाग्य की बात है कि जिस मंच पर मुझे आज, थैंक्स टू डॉक्टर हेमंत, डॉक्टर शशि, मुझे आज आप लोगों ने आमंत्रित किया, इस अवसर पर याद किया, उस मंच पर 2 पद्मश्री मेरे साथ उपस्थित हैं और मेरा अपना मानना है, विश्वास है कि मंच पर जो बाकी कुछ और लोग महत्वपूर्ण हैं आने वाले समय में इस श्रेणी में निश्चित रूप से जुड़ेंगे। मेरे लिए गर्व की बात है। एंड ऑन दिस ओकेजन इंडियन सोसाइटी ऑफ ऑर्गन ट्रांसप्लांटेशन के मिड टर्म सी में उपस्थित श्री बिमल जलान जी, guest of honor, a well-known man, and we have heard about his initiatives, Dadichi. ये मेरी दूसरी बैठक है जिसमें मैं डॉक्टर IB सिन्हा पद्मश्री जी से मिल रहा हूं, बट मैंने पिछली बैठक में भी इस बात का उल्लेख किया था कि as students also we had heard about him, and for me personally it's a matter of great privilege and honor to share this dais with him. Son of soil, Dr. Sunil Shroff, President ISOT, Dr. V. Kote, Secretary ISOT, Hemant ji, former HOD, Department of Nephrology, IGMS PMCH, Dr. Om Kumar ji, Organizing Chairman, HOD, Department of Nephrology, IGMS, Amresh Krishna ji, Pritpal Singh ji, Harshvardhan ji, and these eminent personalities, Dr. Ajay Kumar is here, Dr. Satyajit, so many of you are here, delegates, friends from media. This inaugural function is a sheer coincidence for me. 2 दिन पहले, अभी आप लोग अवगत हैं, असेंबली सेशन इज गोइंग ऑन. 2 दिन पहले एक प्रश्न इस विषय पर हम लोगों को प्राप्त हुआ, and while making the answer to that, I will definitely like to mention the Honorable Minister Mangal Pandey ji, and he was requesting with a very strong emotional plea that we should do something about this area. And I have seen respected Sushil Modi ji also. इस संस्थान के कार्यों को उन्होंने नजदीकी से देखा, and he is one of those leaders who has taken lot of individual interest. So for me it's a very happy coincidence. 48 घंटे पहले लगभग इसी समय ऑफिस में, we were, while framing the reply, we were thinking how to go about it. And thank you, Dr. Shroff, for almost giving us a blueprint. ये मैं नहीं जानता हूं कब होगा, कितने देर में होगा, but one thing I can assure you on behalf of the government and as an individual also, that you have asked us about constitution of a task force. आपने स्टैंडर्ड ऑपरेटिंग प्रोसीडियर्स वेल डिफाइंड वन के बारे में आपने कहा है, एंड आई थिंक इन बिहार द मोस्ट इंपॉर्टेंट चैलेंज अकॉर्डिंग टू मी इज सेंसिटाइजेशन, modes of communication, and you have suggested that we should start at the school level only, whether it's class 8th or 9th, where a chapter should be an integral part of the curriculum or the syllabus, so that the kids are exposed at that level. We will start working in that right direction. And Dr. Kote has made a presentation where we stand. और मैं यही प्रश्न ओम जी से पूछ रहा था कि हम लोग इस पूरे फिगर में कहां हैं. And as he was mentioning, and now as has been shown in that PPT, Maharashtra, Tamil Nadu, Kerala, Andhra, and it's not a coincidence. These are the states where we have one of the best health infrastructure facilities. So I'm not very surprised. But what gives me a lot of confidence today, whenever you are in this august gathering of eminent doctors, I always personally feel it's a matter of great privilege for me to be amongst you people. और मैं हर कार्यक्रम में इस चीज का उल्लेख करता हूं. We have not seen gods, but the living gods are the doctors. And I've seen it very closely during the fight in COVID pandemic. आमतौर पर श्रेय इंडिविजुअल्स को दिया जाता है, मुझे भी दिया जा रहा है, but with all humility at my command, I'm absolutely clear. This battle we have won so far 3 rounds is because of the doctors, the paramedical, and each and every staff of the health department, including the private sector. और जैसा कि डॉक्टर श्रॉफ ने कहा, definitely in this mission mode work which we have to do as far as transplantation of organs concerned, it has to be a well coordinated, integrated approach. It has to be a symbiotic relationship between a public and a private, partnership kind of a thing, where the role of somebody like Mr. Jalan is so integral because they are the pioneers. They are showing us the way. So therefore, I assure this august audience, और चूंकि आप लोगों ने यह मिड टर्म CME का कार्यक्रम पटना में किया है, इसलिए भी मैं अश्योर करता हूं आप लोगों को कि ये पटना का कार्यक्रम डेफिनेटली इट विल बी अ माइलस्टोन इन दिस जर्नी. एंड आप अगस्त सितंबर में दिल्ली की जो बैठक की बात कर रहे हैं, मेरी यह कोशिश रहेगी, और जैसा मैंने कहा माननीय स्वास्थ्य मंत्री खुद भी इसके लिए काफी इच्छुक हैं. So by that time you will see some important policies already approved by the government of Bihar. One thing I will definitely say, that there is a very strong correlation between the health infrastructure and the kind of initiatives which has rightly been pointed out by Dr. Shroff. But I remember when I went to the bridge sector, I'm a student from arts. थोड़ी बहुत सिविल इंजीनियरिंग मुझे वहाँ के इंजीनियर्स ने सिखाई, फिर इलेक्ट्रिकल इंजीनियरिंग थोड़ा बहुत मैं समझा. अब आप लोगों की मदद से थोड़ी बहुत मेडिसिन और इस फील्ड की भी जानकारी प्राप्त कर रहा हूँ. How I wish I had paid more attention to science in you know, of course I did pretty okay in science, but थोड़ा और बेहतर मैं करता अगर ये मुझे मालूम होता है कि साइंस के ही स्ट्रीम में मुझे ज्यादा काम करना है. But that's the beauty of the service to which I belong, and I'm extremely fortunate. And this is what I tell to my colleagues, the junior ones. This is one service which gives you this opportunity to give back to the society, which has given me this opportunity to be amongst you people right here. And I'm fortunate that I'm in my home cadre, and I'm quite a passionate person when it comes to my state and my country. And I just wanted to tell Dr. Shroff that इससे बुरा कुछ हो ही नहीं सकता है. जब मैं कॉर्पोरेशन में पहुंचा, ब्रिजेस की जो हालत थी, सड़कों की जो हालत थी, thanks to my senior colleague Mr. R.K. Singh and the kind of support we have got from the Honorable Chief Minister in this entire journey, transformation journey. So इस यात्रा में भी अभी हम जहां पर हैं, इससे बुरा तो कुछ हो नहीं सकता है. हमारा हर कदम इस यात्रा में बेहतरी के लिए ही होगा. और आज मैं विशेष रूप से हेमंत जी और शशि जी को मैं व्यक्तिगत रूप से धन्यवाद दे रहा हूं कि यू हैव अलाउड मी, आई हैव बीन एक्सपोज्ड टू दिस वेरी वेरी इंपॉर्टेंट सेक्टर विच नॉर्मली इन कोर्स ऑफ आवर ड्यूटी, डिस्चार्ज ऑफ आवर ड्यूटी, वी नॉर्मली स्किप एंड मिस इट. हमारी आधारभूत संरचना कितनी भी खराब हो, कोविड ने मुझे यह आत्मविश्वास और बल दिया है कि यही इसी आधारभूत संरचना केरल और तमिलनाडु के नीचे हैं, लेकिन कोविड मैनेजमेंट हम लोगों ने उन राज्यों से बेहतर किया है. और ये यहाँ के डॉक्टर्स और पूरी मेडिकल फ्रेटर्निटी ने ये मुझे विश्वास दिलाया. देयर इज नो रीजन व्हाई वी विल फेल इन दिस, एंड वेरी सून you will hear about us, the kind of strides we will make. That's all I will promise this evening. Thank you very much, ladies and gentlemen, for giving me this opportunity. And once again, I would like to thank all of you and welcome the delegates to this part of India where we not only worship the rising sun, we also worship the setting sun. बहुत बहुत धन्यवाद. जय हिंद.
Thank you, sir, for your encouraging words as well as your assurance. And truly, the rising sun as well as the setting sun, we are the worshippers. We are going to really fight it and make a name in this field as well. So now, may I have the pleasure to request Dr. Harshvardhan to felicitate the other special guests. Thank you.
Thank you, all of you. Thank you, sir, for that wonderful speech. And I'll take this occasion to felicitate some of the pioneers who have done their bit of contribution in the field of transplantation. So I would request Professor R.K. Sharma, sir, former director of SGPGI Lucknow and presently director of Medanta Hospital, Lucknow, to kindly come on the dais, sir. And I would request Shri Pratyay Amrit, sir, to kindly felicitate them. Now I would request Dr. Ajay Kumar sir to please come on the dais and receive this felicitation, sir. Acha sir is not there, sir. Dr. Satyajit Singh sir, please come on the dais, sir. I would request Dr. Narayan Prasad, Secretary, Indian Society of Nephrology, please come on the dais, sir, for your contribution which you have made. So please, sir, Dr. Ajay Kumar, sir, Director, Institute of Renal Sciences, Paras HMRI Hospital, Senior Consultant Urologist, past President, Indian Medical Association, past President, Urological Society of India. Dr. N.C. Prasad, sir, former Director General Health Services, for his immense contribution in management of COVID, sir. Dr. Arpita Roy Chaudhary, ma'am. She is the present head of ROTO, East Zone, that is the Regional Organ Tissue Transplant Organization. So we have some more names, sir, but unfortunately they are not here, sir. I'll just read out their names, sir. Dr. Arun Kumar, Director, Jai Prabha Medanta Hospital, Patna. Dr. Vijay Prakash, Director, Big Apollo Spectra Hospital, Patna. They haven't come, sir. Thank you, sir. Thank you so much. Dr. V.M. Dayal, sir, Dean, Indira Gandhi Institute of Medical Sciences, Patna. Dr. Vidyapati Chaudhary, sir, Principal, Patna Medical College. Dr. I.S. Thakur, Medical Superintendent, Patna Medical College. Dr. Kaushal Kishore, HOD Medicine, Patna Medical College. And Dr. C.M. Singh, Medical Superintendent, AIMS, Patna. Thank you, sir.
Thank you. Now, may I request once again Dr. Harshvardhan to propose vote of thanks. Thank you.
Thank you. So, first, I would like to thank Shri Pratyay Amritji, Additional Chief Secretary Health, Government of Bihar, for sparing time to be present here, sir. Shri Bimal Jain, General Secretary, Dadichi Dedan Samiti, for sparing his time and to bless us on this occasion. Dr. I.B. Sinha, sir, who has been a constant support and an advisor and constantly helping him in right from planning and execution of this program. Of course, Dr. Sunil Shroff, President, Indian Society of Organ Transplant, constantly guiding me in conceptualizing this program, sir. Thank you very much, sir. And Dr. Vivek Kute, a dear friend, Secretary, Indian Society of Nephrology, for a big support. Of course, Dr. Hemant Kumar, sir, for constantly guiding me. And thank you very much, sir. Dr. Om Kumar, Head Department of Nephrology, IGMS, my mentor. Thank you, sir. My dear friend and senior, Dr. Amresh Krishna, Dr. Pritpal Singh, for constantly being my side. And I would also like to thank Dr. Ajay Kumar, sir, Dr. Satyajit, Dr. R.K. Sharma, Dr. Shashi and other nephrologists, and sorry if I missed out some name. I would also like to thank the press, the pharmaceutical company. Without your support, this program wouldn't have been successful. So thank you, all of you. Thank you.
Thank you, sir. Now I request all of you to rise to the national anthem.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंधु गुजरात मराठा द्राविड़ उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंगा तब शुभ नामे जागे तब शुभ आशीष मांगे गाहे तब जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे जन गण मन अधिनायक
Sir,
Committee, I invite all of you for a dinner at 7th floor. Thank you.